And the coronary angiogram revealed minor coronary artery disease, and presently she presents with acute decompensated heart failure with ejection fraction of 45. She already moved from two hospital to then under my care, and she was dyspneic when I admitted her in my hospital and found to have high urea score. So the clinical examination, she had some basal capitation and definitely ejection systolic murmur will be there due to her severity of aortic stenosis and the clinical condition. The relative were willing for having TAVR, and surgeon also refused to do again redo surgery in this case. So CT was planned. You can see here that area derived from the Tremencio value. It was around it came around 21.1 millimeter. But there are some important point to remember here, that the left coronary height was about 10 millimeter, though the right coronary height was adequate, 12 millimeter, and the sinus of Valsalva on the right side, it was less, and importantly there was mild annular calcification. So this lady has only minimal calcified valve with bicuspid severe stenosis. So the Tremencio report, they comment that this is type 1 aortic valve with mild aortic valve calcification, narrowed right sinus of Valsalva diameter with borderline left coronary heights, and there is mild calcification or moderate calcification at the aorta. You can see there is not much calcium and intercommissural distance, though it has a favorable bicuspid valve to put TAVR, and the sinus of Valsalva already told, and the deployment angle we from this we took at LO cranial 1, LO 40 cranial 1, and you can see the calcium minor calcification was there. Though the peripheral angiogram, peripheral CT showed that this femoral is about 5.9 average, so there is not much calcium also, so it is favorable to the peripheral access. We can see here. So the issues from this case could be the presence of mechanical valve, whether there will be a valve-valve interaction if we put again the aortic valve. And this is definitely bicuspid valve, though it has some favorable anatomy of the bicuspid valve, and the patient is already having features of heart failure, and there is the LCA heights about 10 millimeter is not adequate and not very less or even. So should we have a coronary protection before putting a valve? And the narrow right sinus of Valsalva is important, whether it blocked during the post valvuloplasty, and there is only minimal calcification of the aortic valve, so the valve will stuck there or it will displaced. And the choice of valve, that is also important, whether we could have a balloon expandable or self expandable valve. I have talked many of the proctor in our country, and most of them actually they are afraid of doing this case because there is minimal calcium and there is low coronary heights again, and definitely the mitral valve is already a mechanical valve. So finally we decided to go with my valve, means with a balloon expandable valve. So the valve was crossed with little difficulties with the AL1 and over the Terimo, it's a simple step, and then we took a Safari extra small wire, and importantly we did the pre-dilation this case to, other than there is aortic stenosis, means we can dilate, but it's not in all the cases of where we are putting the balloon expandable valve we should dilate, but definitely in this case we dilate to look whether this raphe is occluding the LCA or not, because the LCA height was less. You can see here that the LCA is not occluding, but the RCA was occluding, because it could be our aim was to look at whether the LCA is occluding. If the LCA is occluding, then we have to keep the stents and wire inside the coronary before putting this my valve. But here you can see, though there is thick raphe towards the LCA, but it is not occluding the left coronary. So we are sure that our balloon expandable valve will not close the LCA. So Here we put the balloon expandable 21.5, the annular perimetry around 21.1. So we took this 21.5 millimeter my valve and deployed in the LO view, means what our CT showed. And we just deploy the valve little bit on the higher side. So if we keep on the lower side, then it can interfere with the working with the mechanical valve. So it is a little bit on the higher side. So we deploy the valve nicely, and you can see there is no regurgitation at all. And though there are thick raphe, but it is not occluding the LCA, and RCA also filling nicely. So the case was done successfully, and you can see here that the peripherally we closed with the 2 proglides only. So coming to the take-home message, it's an uncommon clinical scenario because patient is having on-site RSG mechanical valve, then another site is also having bicuspid aortic valve. And definitely high risk situation as the patient is already having acute decompensated heart failure. So TAVR has age in this subset of patient, and definitely it is important to know that the minimal calcification is to hold a valve is it's sometimes difficult, but we need careful when there is a borderline or low coronary heights, and with the bicuspid, especially with the bicuspid aortic valve or the redundant native valve, and get an idea with the aortogram while pre-dilating to whether there is coronary occlusion or not. And we need proper replacement of the valve, especially with mechanical MBR, otherwise it can deform, means it can create problem with the mechanical valve. And in our choice, that balloon expandable valve may be safer than self-expandable valve in this condition. Thank you so much for your kind attention.
What was the pre-procedure baseline ECG?
ECG was showing, sir, LVOH with strain pattern, patient was in sinus rhythm.
Sinus rhythm?
Yes, sir.
Okay. And what is the, did you stop the oral anticoagulation for how many days before? Because
that is a very good question. Actually, we stopped oral anticoagulation about 5 days before patient admitted, 5 days, because she needs stabilization before doing this TAVR procedure. Patient was orthopneic and all. So we stopped and we give heparin in the meantime during this pre-procedural period.
Okay. And there was no post-procedure conduction block or like that? And
no, because we deployed the valve little bit higher also, the chance of conduction block also is less.
Both the coronary protection as well as no conduction disturbance post-procedure.
Exactly. The patient was discharged very next day only. I discharged the patient without any features of heart failure.
Okay. And there was no, I mean, what is the gradient post-procedure?
3 to 5, sir.
Okay.
Mean gradient was 3 to 5.
Okay. Anything?
Yeah, I think
excellent case. Yeah, Dilip.
Wonderful case. Can we have some discussion on crossing the bicuspid aortic valve? So how many times the implant doesn't work and you have to take another kind of catheters like a JR or something else? Dr. Mehta, anyone?
I think similar case Dr. Ravindra Rao has presented, means in your LinkedIn account I have seen the similar case you have done in Mumbai. So you can have your experience, you can share your experience.
I think you did all the right steps, and congratulations, great case. We just have to understand the distance between the annular plane to the point where the mechanical mitral valve is projecting. This distance into the LVOT is very important. That will help you to place the valve. That will help you to choose between balloon expandable and self-expandable. So the interaction between the balloon and the mechanical mitral valve prosthesis struts, which are projecting into the LVOT, is important. But I think all the right steps.
Yeah.
Whether means we can put self-expandable valve in this condition?
Yeah.
So when there is less calcium, choose a balloon expandable.
Yeah. So good, Ravindra, you got that out, because I was going to ask all of you all, if you have less calcium, would you go with a balloon or a self-expanding? Anand, your views on that? Because both will work, so what would you choose? Almost
the first answer is the most valve you are comfortable with and the one you are using. That's the first answer. Theoretically, in terms of no calcium, there is a difference between no calcium and less calcium. No calcium at all, pure aortic regurgitation, whatever you do, the self-expanding valve staying there is not there. It will keep diving into LV. It will, popping into the aorta is less, it will keep diving into LV. You will put it, it might look fine there. You send the patient to CCU, later on again it will look the same. In that situation, if you have to put, you need to have an anchoring mechanism. So either you put a self, then you put a second self, or a self and a balloon. But less calcium is a completely different thing. If your CT shows the calcium is there around 1,000, 1,500, or even less than that, but there is in the leaflets, it will hold. The self-expanding will hold. Only the zero calciums will not hold. But in these situations, between the balloon and self, the oversizing. So if you have less or no calcium, a balloon expandable oversizing, you should oversize at least 15 to 20%. Normally we say not more than 10%. But there is less calcium, you oversize a little bit sort of higher with the balloon expandable. Self-expandable, again the same. Normally we say up to 20% oversize. Here I might oversize a little bit higher than that. But otherwise both will work. But in only those cases where there is zero calcium, probably balloon expandable has a edge.
Yeah, thank you. Regarding your question about crossing, so most of the time the catheter you choose helps. But suppose you have a horizontal aorta, then sometimes a JR helps, which is very, and sometimes a very large aorta, the AL2 helps. And especially in valve and valve, at times you struggle, because that struggle is more than most of the native valves.
So we have to prepone the lecture of Dr. Ravindra Rao. He has to catch a flight. So may I request Dr. Ravindra to his presentation on mitral clip. His best case of mitral clip.
Good afternoon and thank you. I think I'll label it as an educational case, not really a best case. So let's see. Can we have the slides, please? 59-year-old male, NYHA class 4, CAD, TVD, had a primary PCI to RCA, NYHA class 4, orthopnea, PND, all the risk factors, pre-op creatinine of 3 milligram per deciliter, pro-BNP of 14,000, EF of 30%, RWMA present to the inferior wall, dilated LA, and patient presented almost after 1 to 2 months of all these primary PCI procedure. This is the TE picture. If you can clearly see in the LVOT view, severe functional mitral regurgitation, BICOM view, wide jet, severe mitral regurgitation. The 4-chamber, you can see a non-coapting AML, PML, and a retracted posterior mitral leaflet. So functional mitral regurgitation, and you can see this is the 4-chamber A2P2 view, 4-chamber A1P1 view. So kind of more medial side of A2P2 is severe mitral regurgitation. Again, a BICOM view which clearly shows a wide jet of mitral regurgitation, classical functional mitral regurgitation. This is the tricuspid valve evaluation, mild tricuspid regurgitation. You can see fossa ovalis and IVC. And you can see the, let me play this picture again. And a bad TVD. You can see a distal left main, ostial LED lesion, and a patent stent in the distal RCA. So how to approach such patients? CABG plus mitral valve replacement oblique repair, medical management, PCI alone, mitral clip plus PCI, and if mitral clip plus PCI, should we do clip first or should we do PCI first? So surgery, CABG plus mitral valve repair replacement, anybody? Okay, so we have one hand.
If surgeons are willing.
Yes, so that's the right thing, if the surgeon is willing to operate. But in an ejection fraction of less than 35%, 30%, we all know that mitral valve replacement is not a class 1 or class 2A indication. We see very few surgeons who would go ahead and replace or repair a functional mitral regurgitation. So this was offered to multiple surgeons. Patient was a surgical turn down. Remember, the creatinine is 3 milligram per deciliter. Patient has an EF of 30%, severe mitral regurgitation, and a severe TVD. So patient has to take care of the renals, take care of the mitral valve, take care of the coronary artery disease. Medical management alone, anybody? Yes, sometimes we would do that in hopeless situation. PCI alone, anybody would offer a PCI alone in this patient? Just the left main PCI and hoping that mitral regurgitation will improve. Remember, when you look at the TE, we saw that it was the basal inferior posterior wall which is retracted and PML is retracted, and this is a functional MR due to the previous inferior wall MI where patient underwent a primary PCI. So this MR is not going to go away with PCI of left main LED alone. So mitral clip plus PCI, would you do a clip first or a PCI first? How many PCI first? Okay, we see some hands there. So when you do a left main PCI and a triple vessel disease, and would you use an impella in this patient?
Yes.
That becomes very important because you have to protect those lungs when you are doing a high risk complex PCI in presence of severe mitral regurgitation. So we had a different approach. Why not fix the clip? Why not fix the mitral valve first when we know that this MR is not going to go away? So here's a plan. We did a mitral clip first, 6 French vein, 5000 heparin, SL1 sheath, BRK needle, septal puncture, and a mitral clip procedure. This is a pre-clip mitral valve assessment. I'm not going to go into detail because my topic is not related to that. Severe mitral valve assessment, we do a septal puncture. The septal puncture height is very important. In a 4-chamber view, we got a height of 3.6 centimeter. For a degenerative MR, this is less, but for a functional MR, it can work because the tenting is way down into the ventricular side. Coumadin ridge, you can see the mitral clip is coming off the Coumadin ridge. We are checking the trajectory here, and the trajectory should be directed to the LV apex. Then we are looking at the orientation of the clip. The clip should be oriented 12 to 6 o'clock. A 3DT is must. You can see another catheter which is a pigtail in the left atrium where we are measuring the pressure simultaneously. And the clip is bisecting the jet in the bicom view. And here the clip is open into the LVOT and down into the LV. And here you can see both the leaflets are nicely sitting onto the clip arms. This 3D T view is very important, and this is the glass view where we are again looking at the orientation in 12 to 6 o'clock.
What clip did you use? What type of clips? Yeah, I'm here.
Sorry?
Which clip? What type of clip?
So this is a G4 clip where we are using an XTW.
You did use XTW.
It's a longer and a wider. But remember, upfront we have decided we'll be using 2 clips in this patient. So put the first clip medially so that you get rid of all the mitral regurgitation medially. And then you can look at the residual clip. Before we put a second clip, the mean gradient is 2 millimeters of mercury, and that's where the second clip goes in. Again, a 3DT orientation. And this is the residual mitral regurgitation. Then the patient also had, we increased the blood pressure and the mitral regurgitation still came in. We'd put a third clip in this patient, and you can see how the clip looks like, and the third clip was placed. This was the final result with trivial mitral. So that the important thing is the slide is not there, but after putting 1 or 2 clips, you assess for the residual mitral regurgitation. But before you assess for the residual mitral regurgitation, you also look at the systolic blood pressure. If your systolic blood pressure is 90, definitely you will have trivial mitral regurgitation. So we would increase the systolic blood pressure up till 140. We would assess the mitral. This is the final result. Trivial mitral regurgitation in this patient with mean gradient of 5 millimeters of mercury. And you can look at the pulmonary vein.
If I stop you for a while, why did you choose a second clip? What are the why did you go for second clip? By which criteria? Like your LA the hemodynamics was not in favor, the V wave, LA mean, because in central jet and all the lovely picture of leaflets, there is not much of tethering. The PML length is all right, the height is all right. An FMR.
So I'll play that picture of where there's a residual mitral regurgitation. So what happens, how do we choose the second clip? The second clip is chosen based on the residual mitral regurgitation. Look at the pulmonary vein flow and look at the LA pressure. We presented a patient at London Valve where we left the patient with 2+ mitral regurgitation, and then patient came back with severe mitral regurgitation at 6 to 9 months. At present, when we are doing a mitral clip procedure, we want our patients to have less than 1+ mitral regurgitation, provided mitral valve area allows that to do, provided the mean gradient is still within the acceptable limits. We would accept the mean, if the mean gradient is more than 4 or 5 millimeters of mercury at the end of a clip, we would not go ahead and put a second clip. But if you look at this picture, let me play this again.
What was the pre-MBA? I mean, what was the MBA?
Sorry? Mitral valve area in this patient is almost 5.5 centimeters square.
Okay, quite
That's a
special.
huge. So that's very important point which sir has highlighted. A mitral valve area of less than 4 centimeters square is almost a contraindication for a mitral clip procedure. We would use a NT type of clip in small anatomies, but if the mitral valve area is more than 5 millimeters of mercury, 5 centimeters square, we would go ahead and optimize the mitral clip procedure so that the patient has residual 1+ mitral regurgitation. So the other point is, how do we choose another clip? One is residual mitral regurgitation, residual gradient. So you can see in this patient, the residual gradient is 2 millimeters of mercury. Again, you also assess. So you also assess the pulmonary vein flow during the procedure. The pulmonary vein flow is important. You need to look at the pattern. Let me go to the pulmonary vein flow. So during systole, you have a S wave, diastolic wave, and during systole, when the AV rim moves towards the apex, the majority of flow in the LA happens during the systole. The S wave is prominent than the D wave in normal pulmonary vein flow. But here you can see the pre-pulmonary vein, there's a blunting of the S wave. Post-procedure, the S wave is more than the diastolic wave, which is a normal pulmonary vein flow. And after this was a standard PCI which was done from left vein to LAD. Patient is completed, no hospitalization, NYHA class 2, normal renal function. The creatinine came down from 3 to the normal renal function, normal physical activity. With this case, the only important point which I wanted to highlight is the choosing whether the clip first or the revascularization first. By doing the clip first, we protected the lungs and we staged the PCI after a month. But if we feel that this regurgitation is due to ischemia, then we would definitely fix the ischemia first. But this was due to remodeling of the basal inferior wall following an inferior wall MI and a late presentation to a hospital. Thank you very much for the kind attention.
What that TrueView or GLASG was doing here? What is the importance of GLASG of Philips?
GLASView looks beautiful. Otherwise, if you ask, is there a clinical importance? So why are we doing all those 3D TE views? That 3D TE view NFAS is very important. The clip has to be 12 to 6 o'clock position. Maybe if you are very medial, you could be 11 to 5, and if you are very lateral, you could be 1 to 7. The reason is, if you are not 12 to 6, there can be a stitch effect. You can be a little bit of stitch effect can happen, and there can be severe mitral regurgitation. So every time, even before we enter into the LV, we would look at the orientation. Below the valve leaflets, we will look at the orientation, and after partially deploying the clip, we would look at the orientation. So the GLASView, it's more like looks beautiful, and it tells you 12 to 6 o'clock. But a normal 3D TE views will also show you all that.
Great case, Ravinder.
And the TE cardiologist loves doing that, so they keep pushing the GLASView.
Okay. So great case, Ravinder. Just a question. With such a brilliant result coming off co-op trial in primary in FMR, how much do you wait for medical therapy? Or the first sign of heart failure, will you go and put a clip, or you give them how much time of optimum medical therapy before you
3 months.
for a mitral clip?
3 months. So the reason is, some of these functional mitral regurgitation, they do extremely well once you put them on Viamada and various newer medicines. So first time hospitalization with severe MR, we put them on optimal medical therapy for 3 months, optimize the volume status, optimize all their afterload and heart failure medications. The mitral regurgitation goes away. And that's why in the co-op trial, it was very difficult to enroll patients into the clip arm, because these patients would come through a heart failure doctor who would optimize the therapy anyhow.
Right. Any question from the floor?
So one comment from my side. It's a wonderful case. Sometimes it's very difficult to differentiate this ischemic MR or maybe a functional MR where there is a organic problem of the valves, or there is a kind of a previous damage and then valve has got some problem. Also, in your case, 3.6 centimeter. I think 4 centimeter what is the classical teaching, but this is XT.
No, creatinine was 3.6.
Septal length. Interatrial septal length, like the basic
Yes,
function.
yes.
8.6.
So 4 centimeter is the basic minimum, which is the normal teaching, and below that, usually it says that is a contraindicated. You may not be able to.
That's a very good point. So when we are doing a degenerative MR, you need 4 centimeters square for sure. But if you are not able to get it, there are various maneuvers. We give A knob and all those things to get the height. But in a functional MR, the tenting is not happening at the annular plane. The leaflet tenting is way below into the ventricular side. In a functional MR, you can get away with a 3.5 centimeter square.
Another thing, when we had the classical clip, we wanted 5. And then a non-classical clip like XTW or NT or G4, we have come down to 4 and 4.5. Now, one more question, like you have produced 2 holes, 2 mitral valve now, 2 orifice. The effective orifice of MBA should not be less than 2 after the clip. So how do you decide, like 2 holes, like if it is 1 plus 1 hole or 1.5 plus 0.5 hole? So some hole is 0.5 and other is 1.5, it's still 2.
So, I would be guided by the gradients. So, both the holes combined contribute to the mean inflow gradients. I would not be guided by their orifice area. So, if my mean gradient is less than 5 millimeter of mercury, I'm fine. But when I'm measuring my mean gradient of 5, I'm also looking at the heart rate. I know that on follow-up, at a certain heart rate, I'll have a mean gradient of 5.
So you give atropine? Suppose it goes into bradycardia. And
No,
you give atropine and see?
No, I would not give atropine and increase my heart rate. But what is important for me, I know that my mean gradient, let us say my mean gradient of 5 is at a heart rate of 100. Now I know during my follow-up, I need to maintain the heart rate of 100 and less. On the other hand, rather than increasing the heart rate, I would increase the heart afterload by giving isoprenaline and NORAD. I would increase the systolic blood pressure to 140, 160 to assess the residual MR. Because after putting one clip, sometimes we are happy there is no MR, but the systolic BP is 90. That's why you don't have an MR. So you need to increase the systolic BP above 140.
Dr. Dilkumar,
Thank you.
coming
Thank
to
you.
your height thing, that's a very interesting topic. In most of our population, it's almost difficult to get the height we talk about. So the mitral clip handle and all that has beautiful maneuvers which you rarely use to gain or lose height. So in case you have a slightly less height, then you use those maneuvers to...
But there's a cutoff, isn't
Yes.
it? So 4
Yes.
was the cutoff, maybe 3.5.
yeah, but if you can't, even if you're on secondary MR,
Yeah.
so even if you can't get a
Yes.
height in a secondary MR, you can use maneuvers to get
There are
it.
certain maneuvers you can do to gain
You can
height.
get in with the...
But if your height is not appropriate, you'll have a lot of challenges.
Thank you, Dr. Ravindra.
Thank you so much and thank you.
So we're now moving to the presentation of Dr. Anup Banerjee, and showing a DMVR with, yeah, please be there, sir.
With increase in longevity comes increase in tissue degeneration. With increase in degeneration comes the need of repeat procedures. Whereas innovations in cardiology hardware have improved patient success, patient outcomes. But what is required ideally is a cohesive surgical or a cohesive team, heart team, which ensures better and the best outcomes. I am thankful to Dr. Dilip for having given me this opportunity. And this is a 73-year-old lady who came to us in February with history of shortness of breath for 4 years, aggravated for the last 6 months. And past history revealed that she had undergone mitral valve replacement for a large vegetation due to infective endocarditis on a background of severe MR, an emergency procedure, 2018, Perimount 25 mm. Thereafter, she had symptomatic sick sinus syndrome, pacemaker, 2020. She had additional comorbidities of COPD, sleep apnea, morbid obesity, hiatus hernia, axonal neuropathy. So since the last 6 months, she was already on treatment for heart failure with whatever you have, treatment for exacerbations of COPD and anti-GRD, but with no respite. So when she came to us in February, clinically she had the sternotomy scar, evidence of severe restenosis, severe AS, and features of obstructive airway disease. The STS score after what we went through was 9.98, and she was in sinus rhythm, low pulse pressure, severe AS, borderline tachypnea, severe obesity, resting SpO2 was 94, ECG paced rhythm, echo severe AS, and severe mitral restenosis on a prosthetic valve. CAG done as part of the workup for TAVR, normal coronaries, right heart study, severe PVH, severe PAH. So this is the transthoracic and a TE report, which the salient features are a mean gradient of 42 across the aortic valve and 13 across the mitral valve, trivial AR, trivial MR. And what is also important is mitral annular calcification, severe PH, systolic function 50%, and whatever one expects. So this is the T, you can see a thickened aortic valve, trivial AR, severe AS, mitral valve, a degenerated mitral valve, post-bioprosthetic with trivial MR, and a mean gradient of 12 across the mitral valve. Severe degenerative AS, severe degenerative mitral restenosis, trivial MR, trivial AR. This is CT coupled with three-mentio assessment. What is striking is the area of 268.3 millimeter square, and the LVOTO 19.2, and the diameter only 18.5 mm. What is favorable is minimal calcification, which is expected in a rheumatic case. Again, CT and three-mentio assessment of the mitral valve, annulus area 4.7 centimeter square. Inflow outflow, fortunately, 26 mm. And the aortomitral angle, 53, which is again favorable for us. And also favorable is the access in this case. We therefore, as we said, we have an excellent heart team, and we have many of our members sitting in this August gathering. So to sum up, we have a patient with multiple comorbidities in age 70 plus with severely stenotic rheumatic aortic stenosis, restenosed mitral prosthetic valve. Annulus area 260.8 and 470. So the heart team decided to perform a high-risk simultaneous TAVR based on the calculations, 20 mm MI-valve at the aortic site and TMVR using 26 mm MI-valve in the mitral prosthetic area. So this is the procedure. As we said, it was a ultrasound guided micropuncture anterior wall, as has been discussed in the morning. Posterior inferior site puncture of the anterior atrial septum, usual Brockenborough needle. Septum has been punctured, and we are going to leave the INOU wire in the left atrium. After which we went with the usual steps of the TAVR. This is the pre-procedure aortic root angio. After which, usual crossing of the valve with AL1 and straight tip Teremo, and then taking a pigtail and a safari wire. Usual steps. What was important is initially we took only 19 ml in a 20 mm MI-valve in view of the LVOTO and other considerations that we have seen. However, post-deployment with this showed a minimal PVL. So we added another 0.5 ml, after which the aortic valve, MI-valve at the aortic position was deployed with no PVL. Then we proceeded with the mitral valve. And again, as has been discussed by one of our eminent speakers, deflectable Agilis catheter through which we, again a pigtail first and then a safari wire again. Prior to this, we had to take a Mustang balloon on 2 occasions and dilated the septum 12 mm into 40 mm twice. After this, we are negotiating the MyValve in the, through the degenerated mitral prosthesis. And in this, let me also add that with our critical care colleague, we had to so-called arrest the ventilation to provide stability to the mitral valve, to give it the best possible location for deployment so that we don't increase the LVOTO. So with that, and a slow deployment, which has also been discussed in the morning, this is the final position, final deployment of the 26 mm MyValve through the earlier on degenerated bioprocess. This is the final picture of the 2 valves. So as is very important to discuss, what we had is the mean gradient across the mitral valve coming down from 42 to 4, mitral valve mean gradient coming down from 13 to 2, and a PA pressure on the table reducing from 60 to 40 millimeters of mercury. So the results were quite gratifying. Obviously, this case being done through TE guidance was done under general anesthesia, and the patient with so many comorbidities remained on ventilator support overnight. So in a very brief manner, I have presented a case, an elderly lady, a case of rheumatic heart disease with multiple comorbidities, in which we have, with our excellent heart team, managed to provide two valves in a case of rheumatic heart disease. And we have demonstrated feasibility and success. Once again, the durability is not being discussed today. We have just discussed the feasibility and success of transcatheter valve replacement procedures in a case of rheumatic heart disease, including a valve-in-valve procedure done at the same sitting. And once again, gratitude to our entire heart team who not only was with us at the inception, but also during the execution and the follow-up of the patient. The patient is doing fine. 4 weeks and 8 weeks post-procedure, the mitral gradient remains the same. She's in function class 1, if I can say. Thank you.
Thank you, Dr. Banerjee, for presenting this fascinating and challenging case. Really, being an internist, I don't know the nitty-gritty of this perfect, but I was enjoying the case thoroughly. So now it is open to for any question.
Now, only thing is that in MVR, the bioprosthetic mitral valve replacement was done in 2018, and within a span of 4 years, she developed mitral restenosis. Number one, what is the mechanism of mitral restenosis in that valve? Number one, and what was the position of the aortic valve status at the time of the preliminary position?
So I think you have hit the nail on the head. One fails to so-called decipher as how early she became symptomatic again. So I went through the record. What I can foresee is the emergency mitral valve replacement that was done because of a large bobbing vegetation. Obviously, the surgeon that time wanted the mitral valve to be addressed, and possibly she had moderate AS there, which was either given a second priority. This is the only thing I can think of. Otherwise,
I think what Kashinabda has raised is a very, very important issue here. The mechanism of first valve failure will be the mechanism of the second valve failure. So if you do not know the mechanism of the first valve failure, how would you know that mechanism of the second valve failure? Probably it was maybe undersizing, that prosthetic mismatch, or a annular calcification which was not dealt with.
Annular calcification has been shown in the CT.
So there's not much of excursion of the mobility of the valve in the first failure. So my apprehension that perhaps this valve will also fail very soon, because again bioprosthetic valve, mitral annular calcification, valve in valve. So if you are asked to redo this case now, would you treat mitral annular calcification by some means, transcatheter? Is there any modalities available, Harish?
No, as we have been taught in our medicine days that there are people with hypercalcemia, CKD, hyperparathyroidism and other subsets who have tissue degeneration earlier than the others. So that's again a mystery, but as you have rightly said and was brought out in the CT, MAC has been there in this patient, which also increased the risk of the procedure.
Anybody from Anand?
Thank you, sir. I think we are.
Mac
Can
and
take
just
one comment.
one more.
No, that's an excellent procedure, and I think there's only very few procedures done, double valve in valves. We have done some cases Harish has done. There is no doubt, redo surgery in this patient, it's not an option. I think transcatheter is the option. The reason why the valve failed, it will be very difficult, but as you said, the first pathology was infective endocarditis, and MAC was there for the fear of putting a larger valve, because this is an adult patient, you could have easily put a 27 or a larger valve in a mitral position. They put a 25. So there was a specific reason the surgeon wanted to get out of there. And maybe that's the reason they didn't assess the aortic valve as well. So it's an emergency mitral valve surgery, as you said.
Is there any role of lithoplasty here?
Yeah, I'm coming. Some of these cases, when it's done like that, thrombosis, we are seeing increasingly seeing in the aortic position, the hypoattenuated leaflet thrombosis without valve dysfunction. These doesn't have any consequence at this point in time, but these are predictors for valve degeneration and valve failure, which we are seeing in the aortic position and which we are paying more attention to now. Even though halt, we don't treat it, at least we are capturing it and then trying to treat them as soon as there is a valve dysfunction. It's the same principle, same process would have happened in the mitral valve. Now, with regard to, in terms of whether this valve will fail or not, I would probably give anticoagulation. If there is no bleeding risk, I would probably give anticoagulation for two reasons. One is the previous failure. Second one, we have put a balloon expandable in the aortic, which is a small valve. A 20 millimeter is a small valve for adult patient. If cost is not an issue, I would have put a self-expandable in the aortic and a balloon expandable as you've shown in the mitral. But in India, cost is the issue, because when you are using two MyValves, you can complete the procedure within that 25-30 lakhs. But if you use a MyValve and a Medtronic, you would cross that 40 lakhs plus of it. So I've done the same. I put two balloon expandable in the mitral and aortic position. And hopefully this should last as long as we keep the anticoagulation and prevent any leaflet thrombosis. The only other thing is the appendage is not closed the first time around or this time around. So if there is an issue with bleeding other things, I think you can send it to Apicastra or you can close the appendage, because it looks a beautiful appendage to close.
Yeah.
Thank you so much. We've
Thank you, sir.
addressed
Thank you
issues
for
of
the-
anticoagulation, and what is
Actually,
very fortunate in this case is that this rheumatic heart disease has come at a very advanced stage.
Right.
Thank you.
Actually, this is a very beautiful
for
case
showing
to
this.
discuss, but we don't have time, because this is an ideal case for anticoagulation, because there's clear data in only mitral valve and valve, anticoagulation has fared better than no anticoagulation. So I mean, with two valves and a smaller valve, I think this has to be anticoagulated. Yeah.
Thank you. So now may I request Dr. Devargo Duha to present a case. So it was repeatedly, the operators have told here and asserted that when we do a PCI, it's 50% job, 50% is planning, 50% what you do there. In CRT, you do maybe 30% pre-procedure, 40% procedure, and post-procedure is 30%, because a lot of programming is there. But for tower and all structural heart is 90% what you do in the console room before you take the patient, 90% job is done. So that's what I think Professor Banerjee has done. It was a very detailed discussion. So many times meetings were there, and that led to finally a successful implantation. They were good.
Good afternoon, everyone. This is Dr. Devargo Dua from the Mission Hospital, Durgapur. For the uninitiated ones, Durgapur is a faraway place, something like 220 kilometers away from Kolkata. It's a Tier 2 city, and we have started our TAVR program there for the last 1 year. And I'm really thankful to Dr. Dilip Kumar sir for inviting me, for giving me this opportunity to present a case. And again, I want to make a statement before starting my presentation. I'm really thankful to Dr. Anuj Kapadia sir. He is sitting over there. He is my mentor in this case. So this is a 80-year-old female patient who presented to us with symptoms of heart failure. She was having definitely severe aortic stenosis. She was a known case of chronic obstructive airway disease, and her creatinine clearance, her CKD stage was 3B, and she was having a BMI of 17.14. Her ECG was essentially normal with some changes like STD changes due to LVH. normal sinus rhythm, normal peer interval. Her echo showed there is severe aortic stenosis. PSG and MSG were 92/66. AVAI index was 0.41 centimeter square per meter square, and our LVEF was normal. So we had a hard team discussion. We calculated the STS score. This is again debatable that how much STS score fit into our patients, like Asian patients. Still, I mean, we had to do it, and it was found that she was having an STS score of something like 5.0. And again, CT aortogram was done in TAVR protocol, which was analyzed in 3-dimensional software. This is another thing because we are dealing a bicuspid aortic valve in this case. So we need to be very sure whether this patient is treatable by TAVR. As you can see from this picture, the maximum ascending aorta diameter was 30.8. There was no ascending aortopathy. The valsalva, sinus of valsalva height and the diameter were very roomy, and the coronary ostial heights were also very good. So as you can see from this picture, it was a type 0 bicuspid valve. That means bicuspid valve without raphe, and there was some calcification in the valve leaflet as well. And the angle was something like 47 degree, and the femorals were essentially normal, except there is a little bit of tortuosity in the right femoral compared to the left. So that's why we took the left side as our primary access site. Now coming to the valve, regarding the annular diameter of 20.8 millimeter and the perimeter of 65.5, Evolute Pro of a size 26 was actually taken into consideration for the implantation with a 25% oversizing percentage. So this is the femoral access. In our early days, we did perform micropuncture technique to introduce the micropuncture needle, then the wire, and to confirm by fluoroscopy by giving some dye in it. And then we exchange it with a amplage wire, and we did some serial pre-dilatation. Then this is the 14 French Medtronic inline sheath, which was introduced in the ascending aorta up to the arch of aorta. Now this is the crossing of the valve, which was not that difficult. We took AL1 and a straight tip Terumo, and with little bit of try, it entered nicely without any difficulty. And this is again crossing of the aortic valve, as we don't get to cross aortic valve, every now and then, so we took a second chance to practice it, nothing else, in a different view. So then we exchange this catheter with amplage wire and calculated the gradient by introducing a pigtail inside the LV. Then we introduced the confida wire in the LV, over which we gave a pre-dilatation with a Z-made balloon of 16 millimeter into 4 centimeter. This is unfortunately not taken, not saved by our technician, so I apologize for that. I cannot show it. So this is the crossing of valve, positioning the TAV. It was very slowly introduced in the ascending aorta, then crossed the aortic valve. This is our implanter's view, which is cuspal overlap view. And we started implanting it up to 2/3. Then we confirmed it in another position, which is the LAO view. The left hand side is the RAO caudal view and the right one side is LAO view. Then we took a shot. We are not happy because the valve actually situated very deep in the LVOT. We plan to recapture it and reposition it at 0 to 1 level depth. Then we took another shot just to confirm the exact position. This time we were happy with the position. Now this is the final deployment, the last 20%, and this is the final shot. There is no significant PVL visible. So we are quite happy with the procedure. The gradient were absolutely zero, the difference. But when we took the last shot, the left femoral, we found it to be occluded totally. Then we quickly passed a coronary wire inside that part and balloon dilated it with a coronary balloon, 4O. Then the flow was restored and it looked like this. So there was a discussion between us whether to put a stent at this point or not, because there was a visible dissecting flap or like something like that. So we actually went against it, putting a stent. But after 2 hours, I got a call from our CCU that the patient is complaining of left-sided leg pain. And we took her to the Cath lab, only to find that the femoral artery getting occluded again. Then again we put the coronary.
How many proglides did you use here? Proglides?
2 proglides, sir. 2 proglides. One at 10 o'clock position, otherwise 2 o'clock position.
Idea how big the body surface area?
Body surface area was very less, sir. 17.14. Okay. I'll come to that, the reason.
14
yes,
only,
yes,
very thin
yes,
lady. Yeah.
Yes. So again we passed a coronary wire and pre-dilated. Unfortunately, we didn't have peripheral stent at that time. So what we did, we implanted a Synergy fibo stent at that position, and we didn't have a balloon either to inflate it further. So we went ahead with the stent balloon and inflated the 5x32 Synergy up to 24 atmosphere with some risk definitely. But we didn't have any other option left because we didn't have peripheral stent or balloon at that time. So here quickly coming to the anatomy, as you can see from this picture, the femoral artery left side was something like 5.5 to 6.5. And what we did is we inflated a 5x32 stent. This is a picture from another stent, and we inflated it at 24 atmosphere. As you can see from this picture, if you go to 20, it becomes 5.5, the stent inner diameter. So it was quite acceptable at that position. I'm not telling this is the right thing to do, but it's a bailout procedure. So this is the final result, which looked a little bit of under expansion of stent in the proximal part, but we were quite satisfied with it because we saved the limb. So there are some challenges in bicuspid, like bicuspid valves are asymmetric in shape and calcifications may impair the adequate tab expansion, function and durability. So the theme is to predilate always. There are associated aortopathy which is not there in our case. ACV, self-expanding valves, are better than balloon expandable valve in bicuspid aortic valve. There is a problem with bicuspid valve if we are dealing with a type 1, which is the most common type. That means if there is RAFE, then there is chance of PPM is higher. So shallow positioning of the tab less than 3 millimeter is actually recommended. FIVIL is more common with bicuspid. You can reposition the tab post-dilated if needed, if you are using a self-expanding aortic valve. And lastly, most importantly, you have to have your safety kit ready, which we didn't have at that time during the TAVR procedure. Thank you, sir.
Thank you. Rashida, any comment?
Dr. Kapadia was there at the time of the procedure?
Yes, sir.
Dr. Kapadia was there in that? You were involved? What is your comment?
So this was the first TAVR procedure they did, and we did together, and peripheral stents were not available. So we actually just balloon dilated initially and left him on heparin. But then later on, because of the clot, all this had to be done, and there was no peripheral stents at that time available. Covered stents also were not available. But otherwise, everything went on very well. Very small sized woman. Even the size of the arteries were very small. Hindsight, probably one per close would have been enough. That would have actually taken care of the whole thing. That was the only thing that I can think of.
Was the, per close device was responsible, or was it the size of the,
No, it was the per close, sir, because it is exactly at the site of the thing.
Right.
If it was the size of the device, it would have probably torn through.
Yeah.
Now, on the hindsight, we can think that it would have been better to put the per close device at 11 o'clock or 1 o'clock, even closer than that. I mean, maybe a way to...
No, one per close would have been enough, probably.
Yes, one per close and
One per close, even manual compressor would have done. Yes. Anyway, now what was the sievert type? Type 0.
What was?
What was
Type
the
0. Type 0.
Type 0. Both of you, would you and Anant, would you dilate all valves, like all stents should be post-dilated? What do you gain after post-dilatation? What do you lose after post-dilatation?
It's a very important question. Bicuspids is a different animal altogether when you're treating bicuspids compared to tricuspids. And bicuspid type 1, it's a completely different thing. The worst outcomes are bicuspid type 1 calcified. So you have a calcified raphe, bicuspid type 1. Those has to be adequately pre-dilated. When we say adequately, we pre-dilate to the minimum diameter -1. Here even we go slightly bigger than that and pre-dilate. But 90 to 95% of the bicuspids you pre-dilate, even if there is only minimal calcium.
I'm talking about post-dilatations.
Post-dilatation, the appearance should not lead to post-dilatation. The post-dilatation should be based, if you have pre-dilated, you deployed the valve, the appearance should not lead that. Your hemodynamics. So you cross it with the pigtail, get the hemodynamics gradient, AR index, and those are good. If your echo is good, don't be sort of led by this appearance. But if your hemodynamics is not good, if the mean gradient is kind of high, then post-dilate. Here it's a 0 position. Even 0 position, you can post-dilate it because it's bicuspid. The anchoring is at the raphe level, so I don't think I would be worried. The only issue about this single proglide is, if you are using single proglide, we have to use an angiosil. Very rarely you get away with the 14 French just putting a single proglide. Especially that puncture was a little bit on the higher side. So I don't want to have a retroperitoneal bleed. I'd be worried about a retroperitoneal bleed worse than any sort of occlusions. So 2 proglide was the right thing. A narrower angle would have helped it. The other thing with the peripheral is, if you ask the peripheral intervenists, they will tell you, a prolonged balloon inflation is required. It's not like coronary inflation, like 20 seconds, 30 seconds. A good 3 to 5 minutes or even repeated 3 to 5 minutes balloon inflations until you see a good flow, until the patient has a good flow before leaving the table. And that might have sorted it out. Prolonged balloon inflation the first time around with heparin, I think the reocclusion would have been less.
So there was a descending flap you can see. Would you recommend to put the stent on the first go?
No. You don't put a stent. And second thing is, you put a self-expandable stent, because that is a very flexible point.
Definitely. That we didn't have.
The hip.
Yeah, self-expandable. Or
I think it was a bicuspid anatomy, and one important comment is we always do pre-dilatation for all, but still the positioning what we went here 0 to 1, I don't think that is a good strategy for any kind of platform. Because invariably, even after a good pre-dilatation, bicuspids will end up needing a post-dilatation. If you place your valve 0 to 1, you are already losing your chance to post-dilatation, and you have only one chance to accept it, whatever the position is, whatever the gradients are and everything. Because if you post-dilate this patient, the valve will embolize.
okay.
So it is always better for bicuspid, whatever may be the type, you should always have a 3 to 4 millimeter depth. Because bicuspids, how they are going to behave is extremely unlike.
Would you use octacore? Would you use octacore? The force shortening is minimal?
Yeah, see, any balloon expandable valves in bicuspid, they will have all the circularity. The chances of post-dilatations will be very less in balloon expandable. And the depth, you can easily 2 millimeter is normally required.
Right.
I'm
Last
talking about
comment.
self-expandable. Self-expandable.
Last comment with Dilip's permission.
I think we are moving, having sort of...
Last, you can make your comment quickly. When
Doctor,
Next presenter, please.
Hi. So I'll give a little bit of a surgeon's viewpoint from here. So while I was in the UK, we used to do a lot of cut down for patients with this kind of a narrow caliber femoral arteries for our cardiology colleagues, especially if they are tortuous and less than 7 millimeter. And that gives a lot of control. So if you do have a vascular surgeon or a CTVS surgeon with you and you take their help, this kind of things is possible to avoid because it's very easy to take care of the femoral vessel with a very small incision in such scenarios.
Right, thank you.
Thank you.
So there are many possibilities.
I think now we have 4
2
point.
ProGlide, 1 ProGlide, angioseal, manual and surgery. Last thing is manual. We did compress the ECMO with manual, I tell you.
I think we don't need like a surgical cut down even while doing impella or towers. 14, 16, I think it can be done with 2 ProGlides. Okay. So we can move on with the last presentation of this session, Dr. Devpriya Mandal.
Good afternoon, everyone. With prior permission from the chairperson, respected Dr. Hajra and other people here, very good afternoon. I'm here to discuss one of our cases. This was actually a case of Dilip sir. Thank you, Dilip sir, for allowing me to present this case as a representative. So he was a 67-year-old gentleman who complained of functional class 3 dyspnea on exertion as well as repeated episodes of giddiness. He's a known hypertensive. He had severe anemia with LV function of 28%, and the baseline ECG showed an incomplete right bundle branch block and intermittent complete heart block also. So basically this gentleman was turned down from surgery in view of high STS score, which was around 5.6%, and patient had opted for a transcatheter aortic valve implantation. So the Trementio analysis revealed it was a bicuspid, again a bicuspid valve with a type 0, Sievert's type 0 anatomy with severe calcification with a annulus derived area of 529 millimeters square, area derived diameter of 26 millimeters, and other measurements of LVOT was 28 millimeters, calcium score of around 3000 millimeter cube, and with a favorable coronary height of 15.5 millimeters on the right side and 18 millimeters on the left side. He also had a dilated ascending aorta which was associated with bicuspid aortic valve, and both the femorals, left and right, were pretty accessible with moderate calcium and little tortuosity at the iliacs. So these are the intercommissural measurements which was taken 4 millimeter and 6 millimeters above the annulus. The intercommissural measurements at 8 millimeter and 8.1 millimeter above the annulus revealed a 26 millimeters valve, which I'll come to the sizing part. The deployment angle was this was a RAO 48 and overlap, cuspal overlap view of around 39 degrees in the LAO view. This CT scan shows a moderate calcification in the valve commissural region without any significant calcification extending downwards into the LVOT, and the aortic valve calcium score was around 2800 as I have described. And this is an important slide where we'll select the valve size according to the diameter of the valve, which we showed that the 3D annular area millimeter square, the appropriate sizing with a 0.3% oversize would be 26 millimeters valve, which we actually chose. And the next sizing in case of this patient would be a 27.5 millimeter valve, which would be oversized by 12.2%. So initially, as per this calculation, a 26 millimeter valve was chosen. These are the standard steps which have already been described by all my previous esteemed speakers. The angiographic view of this individual shows a severely calcified aortic valve. His coronaries are also extensively calcific with probable no risk of coronary artery impinging on implantation, which was also ensured by the CT scan analysis. The valve was crossed after a few attempts with a straight tip J wire. A safari wire was placed in the LV apex, and subsequently the valve was pre-dilated in view of severe calcification with a 20 into 40 millimeter sized mammoth balloon. Following which we introduced a 26 millimeter sized MI valve, which crossed in the valve with moderate easy way without any much of difficulty. This was the positioning which was done. It was like we planned lesser deployment because it was a bicuspid valve and it was severely calcified valve, which is a risk factor for development of conduction system abnormalities post-deployment. And then once the valve was deployed, this was a balloon expandable MI valve, the subsequent angiogram showed there was a significant paravalvular leak for which it was post-dilated with a 26 into 30 millimeter mammoth balloon again. So post balloon dilatation, the valve did not have any inherent damage, neither did it pop off. It went smoothly, but what happened was post dilation with the 26 balloon, there was again a significant paravalvular leak which kept on continuing without causing much of improvement in the hemodynamics. And the gradient still was remaining with a significant drop in diastolic blood pressure to around 40 millimeters of mercury. Hence, to salvage the situation, it was decided to put another valve with the risk of immediate conduction abnormality on the background of an RBBB with the next higher sized valve, which is a 27.5 millimeter valve, and it was deployed slightly lower down and on top of the other valve. So due to high calcium, a low implant was decided, and during the procedure, the valve got deployed lower than the original position, which I have already described. And post deployment of the second valve, after removing the parallax, what we see here is there is a mild paravalvular leak, and the significant paravalvular leak which led to a diastolic pressure of 40 had significantly improved, and the diastolic pressure this time went up to 60 to 65 millimeters of mercury. And this was the final result, and a femoral angio after the procedure which revealed a flowing bilateral femoral artery with no evidence of any vascular access related injuries. So conclusions from my side would be patient with coexisting comorbidities with severe AS should be properly selected. A 26 millimeter MI valve was deployed with pre and post dilatation using a mammoth balloon. However, the balloon had slipped from the original position because of the pressure exerted by the heavy calcium, and hence a 27.5 millimeter MI valve was again deployed with adequate results. A permanent pacemaker was implanted with the DDD mode on the same day after the procedure. Post-procedure stay, the patient improved significantly without any hemodynamic disturbances and was subsequently discharged on the second post-operative day. So what are the lessons learned? The high calcium load is actually a factor where we have to think this could lead to conduction disturbances, number one. Number two could be a risk of annular rupture. Secondly, post-deployment severe PVL could be one of the factors to implant or to post-dilate again. And sizing of the valve in severe calcification needs more clarity, specifically in the background of a bicuspid aortic valve. Thank you, sir.
Thank you. I think this is the best case I see today.
Thank you, sir.
Congratulations. One of the best, very exciting and very, very innovative solution to the leak.
Thank you, sir.
At the end of the day, I'm sure the patient did very well. Any comments from the floor?
It was a classical type 0.
Type 0.
Yeah, bicuspid aortic valve. So could we have
Anmol,
oversized it?
Anmol, before he comes, I put one question to you. Look, going back into the case, how do you pre-treat those type 0 severe calcium? Is it a time to treat this calcium before you put your valve or the first cut or balloon into the aortic stenosis? For example, can you do a basilica type of thing in native valve? Can you treat pre-treat this calcified aortic valve with lithoplasty or a shortcut, pre-dilate, then you choose your valve, dimensions, rather than regretting this? This is a valve regret, like you have undersized the valve, you've not treated the calcium. So what's your thought?
See, I think first of all, the valve modification techniques. First of all, the wall modification techniques, what you are talking about, whether basilica and all. Native valve, they are all heavily calcified valve. Any intervention there will have a significant embolic phenomena. Even laser, whether you are cutting with basilica and everything. They have not been proven yet and not been done yet to the native valves as of now. Pre-dilatation is what we can offer to these bicuspid anatomies. And as we all learned from this bicuspid data, these are the kind of patients who are excessively leaflet calcium.
I'll pause you for a while. Do you think the chance of embolism is much higher than pre-dilatations vis-a-vis native basilica or native shortcut or native lithotripsy, chance of embolism is almost negligible.
See, for
In comparison to pre-dilatation of the balloon. So what I'm asking you a question here, seeing the case in hindsight, should you treat the calcium first and then you treat the valve?
It is not massive calcium, boss. How much?
2,800.
2,000. It's not massive. Massive is more than 4,000, 5,000, more than, yeah.
He mentioned the cause of the PVL was calcium.
Calcium, it's not very.
See, there are two etiology for the PVL here. I think the valve, as inadvertently, they tried to place little higher. And in the post-dilatation, if you see, the valve was into the sinuses. Though the valve got anchored because the coaptation in bicuspid type 0 was supraannular, valve could hold the position inside the sinus. There was a good amount of possibility to have and PVL from the side or from the open cell also. Second thing, even if they deployed the valve, second valve down, still if you see the last picture, there was a moderate, it was moderate PVL according to me. So what lesson we should learn? These are the anatomies are not suitable for tower. See, we know everything. Heavily calcified leaflet is an independent risk factor for these patients. For 2 years, mortality is 20%. Though it was a type 0, but the excessive calcium is a not suitable anatomy. Excessive calcium with calcified raphe, they are worst anatomies. We can offer when the patient is rejecting, that is another part. But still, according to me, these patients are not a good tower candidate to get a good optimal outcome. You saw the PVL, pacemaker, in spite of a second valve, the PVL was moderate. The moderate PVL in a young patient with that LV, how they are going to come back a little earlier than later. The lifetime management of this patient is crucial. Though the patient is saying they are not willing for surgery, but we have to really tell them what years they are going to come back, and they don't have any option when they will come back to us.
So you are saying it's a high-risk tower. Please take your seat.
I will tell you. Yeah. So this patient was basically elderly male with, he went to surgeon and he had a 26-30% ejection fraction with CT angio showing some, coronary artery disease as well, moderate coronary artery disease. And he was surgically turned down. And he rushed to us in emergency. You see, he was having more of symptoms, and then we planned. And so we waited for him in our hospital for him to come from Murshidabad. So he traveled all along 12 hours, almost, with NYHA class 4 in ambulance. And it was a kind of a bailout, tower procedure was done on him. That was basically the, he's doing well, sir. He's doing well.
I don't think it's surgical down, because surgical down and other risk factors, TAVI is class 1. So doing TAVI was not an issue. The two important aspects, one is the heavy calcification, but all of them are in the leaflet. It's a type 0 and equally distributed. Both sides, the superior and inferior, both have got calcium. So whatever you do with this balloon expandable, unless it takes the circularity, it's not going to oppose, and you are not going to get away with paravalvular leak. The other option would have been to go with the self-expanding, which conforms to the shape. To do this case with the balloon expandable, we need to understand how the valve foreshortens. That's very important. The first generation my valve and the second generation octocore, they're completely different. The foreshortening with the second generation octocore is literally not there. The first generation, the my valve, it foreshortens from LV towards the aorta. When it foreshortens almost 30 to 40%. So the only thing I can see from that picture is where the middle marker, or where we want the second dense band, was to start with high. It was already high. And when it foreshortened to almost 0 to -1. Now that is fine. Now when you post-dilate, you don't need to take a separate 26 balloon, because the first result looked excellent to me. All we needed to do was to reduce that paravalvular leak. I would have put another 2 ml in the same balloon, the one which was used to deploy the valve, because it is already there and it gives you much control, and dilate it and accept a mild paravalvular.
So extra 2 ml and octocore.
No, extra 2 ml in that same
we did the
same
same.
valve,
We did the same.
Or other type of valve.
Other type of valve could have been fine.
Octocore nowadays.
I think what is probably happened here is the 26 mammoth balloon, when it was brought, that is probably brought the valve up a little bit more. I don't know, I didn't see a deflation shot, because when we post-dilate with a balloon, you have to completely unless you do that and bring it, it will bring the valve.
Pull up the valve.
Yes, but having done that, do you accept that to leave that valve there and put a second valve, or do you dislodge that valve completely, bring it to and deploy it in the descending aorta and go back with the 27.5 and put it in that? That depends on the
So that means you are suggesting steering the valve into the descending aorta, go with the higher size, the quarter size of the valve.
Because we don't know what this kind of platform is doing there at the moment. So if the patient is stable, that is the thing to do. You snare it, bring it, deploy it in the descending aorta, go with your right size 27.5, deploy it in a good position. But obviously that all depends on the hemodynamics and everything
Right,
about
so you
the
prepare
patient.
the second valve because we want to pull out the torrential air.
Yes, that is the issue. You don't pull out. Unlike the self-expanding.
Unlike the second valve is ready.
No, self-expanding, you snare and pull out. Balloon expanding, you put a balloon inside, inflate the balloon, control retraction because you don't snare and pull out. Balloon expandables, you inflate a balloon and then bring the balloon. Yes, by that way it doesn't have any contact with the aorta, it will come smoothly. If you snare and pull, you will tear.
Okay.
I think that was very important.
Very important
When we are post-dilating a valve, we have to wait for the temporary pacemaker till the balloon is totally deflated. This is I think in this case it happened, and we went with the extra 2 cc volume first, and there it happened, and then we had to deploy the second valve.
So it was a fault with the temporary
Last
pacemaker.
one question can I ask?
Yeah.
Dr. Anandraman, in your clinical practice, on
Next
how many occasions did you require 2 valves?
Next presenter, please, on the
No, I
podium.
think so. Over. This session is over, sir. So
My job
next
is
The
over.
answer to that is self-expandable. Nowadays we don't get it. Previously it's almost 10%. You kind of have dislodgements. But with the cuspal overlap and all the other techniques with adequate preparation, we don't do it. As long as you reduce the post-dilatation in both the valves, you don't get much valve dislodgements. But understanding how these valves foreshorten, all those things are important.
Thank you so much. We end the session over here. Thank you so much, doctors. We move on to the next session, left atrial appendage.
Prakasa, you have to be there.
I would like to invite the coordinator of this particular session, Dr. Robin Chakraborty, on the dais, sir, please, kindly. Also, I would like to invite the chairpersons of this particular session, Dr. R.D. Yadav, Dr. Dhiman Kahali, Dr. Ashok Kaur, Dr. Amit Sharma. If you kindly come on the dais as chairpersons. As discussants of this particular session, I would like to invite Dr. Nishant Tripathi, Dr. Avik Karak, Dr. Ashfaq Ahmed, Dr. Bashavendra Chaudhary. Thank you.
So what I'm going to do is we are combining next 2 sessions. So we are combining the next session with this. And may I request Dr. Rishi Sethi to be there on dais, Dr. Gautam Datta, Dr. Dipankar Ghosh Sachidar, Dr. P.S. Banerjee, Dr. Imran Ahmad, Dr. Ashok Parida, Dr. Siddharth Mani, Dr. Parijat Dev Chaudhary, Dr. Sumant Mukherjee. So Dr. Imran, please come on dais. Yes, we can. Dr. Anil Singhi. So we have the first presentation by Dr. Anil Singhi. This is on imaging in left atrial appendage. So we are moving towards single operator, in rotablation we are moving to single operator and everything, but in left atrial appendage you need to have 2 people, 2 persons. One is on the imaging and second on the procedure. So you can't just, ignore the importance of imaging in these situations like left atrial appendage.
Slide, please. Good afternoon, everybody. It's my pleasure to be here. It's nice to see post-lunch session. The hall is looking very full, and people are showing nice cases with a very extensive discussion. So much of discussion is again heartwarming. 2014, when I left Chennai, I used to see so much of structural interventions there, and 8 years down the lines, seeing same thing here is very good, thanks to the pioneering work of Dr. Hajra and Dr. Kumar. My job is as a part of structural intervention. Most important thing, as Dr. Kumar has told, is pre-assessment. 90% of the job will be done if we are true. Thanks to Dr. Shivakumar. Some of the slides I have shared with him. The anatomy of the left appendage, Dr. Shetty has already put a lot of light and made my job clear. We know it's a complex structure. in multiple plane. It has a neck, a ostium and an apex, usually 3-part, and highly variable structure with elliptical orifice, more than one plane. That's more important. A good imaging is essential. Usually bilobed in 50% cases, single lobe or trilobe in 20% around cases. Length around 27 to 60 millimeter with a mean of 44, and 10 to 24 is the long diameter with a 5 to 20 millimeter short diameter. So it's highly variable. The assessment is important to choose the correct device. If we see the shape, wind shock, chicken wing, cactus, cauliflower, multiple shapes, and the representative images in the transesophageal, we can see the wind shock. Though in the correct generation of the devices, the shape has come down in importance because the current generation of devices can suit in majority of the appendages. When it comes to imaging, transesophageal leads the show. Though CT angiogram is discussed in the preoperative imaging, but essentially a detailed transesophageal echocardiogram sets the ball, and which is again important in during intraprocedural imaging and also in the follow-up for thrombus apposition and any leak. So the essential role is to identify the anatomy, shape, measure the size of the ostium and the landing zone. We'll come to that. Any thrombus present or any smoke, whether there is any existing PFO or AHD. So septal anatomy assessment again is a very, very important thing. We often miss the other things like cardiac function. So we should be aware that during the assessment how is the cardiac function, and it will again help to prognosticate the case. So T is helpful in, as we discussed, transeptal puncture and device deployment. In the newer machines, this X-plane imaging is very good in same time, like a biplane lab. It gives a orthogonal plane assessment and help us to understand and measurement and shape in two different planes. We can see in the 90-degree plane, we can same time assess the size. So shape, as we discussed, is elliptical. Axis of the neck and body are different. Here we can see is 0 and 45 degree, and 3D helps to understand the shape better. Here we can see two openings for that shape, and this glass view imaging, which is coming to the newer generation Philips and GE machine, they helps to give the 3D picture little better by reducing the backdrop noises. So it is more clear. It is removing the side noises. So the two parallel images, and it is appearing more clearer, because as if some light has been shown inside the cardiac specimen. We all discuss, though the measurements vary between these different devices. The ostium is discussed between the circumflex artery and the ridge of the pulmonary vein, and 10 millimeter deep to it is the landing zone size. Length also is measured, but nowadays non-Watchman devices, this is less important. So multiple view, as Dr. Shetty told, 0, 45, 90, 135, and these measurements in the baseline as well as during the lab, after ensuring there is adequate volume inside the left atrium. 10 pressure is again a rough guide. So multiple time measuring, because we are going to take our device based on that measurement only. Checking for the LA thrombus, if it is, then it will create trouble. So we always should try to rule out. CT angiogram, earlier, I think in present era, very less role for CT angiogram for appendage closure. It is also, if it is there, it helps to get another imaging modality to understand the stage and site. Angiogram still is important on table to understand the shape and the size. The best projection is RAO cranial, RAO 30 cranial 10, and caudal view helps to understand the tip. So this is the RAO, the cranial, the next one is RAO caudal. And the AP lateral, these views are not going to give too much information about the appendage. So in the real life, there are two angios. It's a 10-minute talk, I believe. Okay. So these are again iliocranial and iliocaudal. Coming to the septal puncture, broken borough needle, 8 French. It should not be going through the existing PFO because the alignment of the sheath will not be appropriate. Posterior inferior part of the septum, and nicely shown by Dr. Shetty. In X-plane, we again understand it is posterior and inferior. In the 3-dimensional view, we can see the needle coming through the left atrial side. Here we can see the indenting in the LA. And that's an index case done in our institute where we are doing the puncture and seeing that. So sheath entered. Inside the LA, we can appreciate the 2 lines of the sheath outer. In the 3D, we can appreciate the sheath or the pigtail catheter coming inside. And during the device deployment, again, transesophageal is extremely important because this is the modality which will show where you are in the place, how much deep. Peri-procedure, appropriate positioning, any residual leak, all can be checked in different views. Again, 0, 30, 45, 90 and 135. So the one point I wish to add this, in isolation T is not going to give all the information, and it is an integration of the fluoroscopic image as well as the T. The operator need to check on both the screens same time to have a holistic idea regarding the procedure, the device. So in septal puncture, as we see during the device deployment, the device is inside. So in the anatomically, in fluoroscopy, how it is opening, we can see in the parallel. So these are all corresponding time images taken in the fluoroscopy. So final check injection, again, small injection has been given. The device is sitting very well. And this is an image from another patient where pre-procedure to post-procedure, how nicely the device is sitting. An add-on part is how the glass view adds to the viewing. You can see in compared to the conventional 3-dimension, improves our understanding. So this LA appendage closure is a heavily image-dependent structural intervention. Detailed pre-op planning is essential. All the operating team members should have a detailed understanding before starting the procedure, and TE tops in the list of the imaging modalities available. Thank you.
Nowadays, CT has much better, sizing is done mainly by CT. In West, they do sizing by CT.
For aortic valve, etc., sir, it is possibly more in CT, but for LA appendage, it's more dynamic.
They have changed.
It depends on the operator's choice, but majority of the operators like to size by T. CT is also another modality.
Because that is the natural LA pressure, because if you, for T, you have to keep the patient fasting, that lead to LA pressure down and appendage size lower, or you have to give fluid to see the LA pressure around 12 millimeter of mercury.
Pre-operative assessment of the LA appendage, that's what, not on the table, the pressure may be down. So assessment, the detailed transesophageal echocardiogram, when we have decided that we are going to do, if we assess at that time, that will add lot of value to our understanding and planning the procedure, sir.
Dr. Anil, without T, this procedure cannot be done. But sizing and planning all based nowadays with the CT.
That is also, yes.
Yes. I've got one question. Because we know that for this procedure, the site of septal puncture is very important. Now, is there any correlation between the site of atrial septal puncture and the morphology of the left atrial appendage? Is there any correlation? If this morphology is this, then the site of puncture will be on this side?
No, I have not found any specific literature site for any shapes and the relation of the puncture site. Only your sheath, all those things will be better posterior inferiorly if you puncture. That is there, but individual appendage and the puncture site difference, that possibly is not there.
May I make a comment?
Yes.
So coming to CT measurements for LA closure devices, CT is basically when the patient is dehydrated. The CT will give you a wrong, measurements. And T is the standard of practice. There is no recommendation to go for CT. Some of the, privileged centers, they are doing CT scan for extra, additional information, but there is no such recommendation that we have to do CT before a left atrial appendage devices.
Regarding puncture site, nowadays with the sheath which is coming is a deflectable sheath. Both companies brought the deflectable sheath, both ACP Amulet device and Amulet 2 nowadays is coming, and with a deflectable sheath, with that anywhere you can puncture and you get into the LA appendix without problem.
Right. I would like to give one comment. Most of the Western countries where CT is reimbursed, people are moving towards that because you don't need to subject a patient to TOE pre-procedurally. You can get to know about the thrombus up front. I do understand that because of the volume status or sizing may differ, but you get a hell of information about the kind of anatomy you are dealing. You don't the number of second device used goes down by 40%, because as your slide only showed that like more than 80% patients have more than one lobe, and if you are using now with the different devices available, Flex is coming up, and you have a Lambre with a branch device and everything. So having the information up front, which is three-dimensional, it's really good. We can't expect that such a complex structure can be seen by a fixed 30-10 view. It can be a different view or different coplanar view for different patient. So your implant angle, site of puncture, device selection, your catheter selection is much more simpler. Your procedure becomes much more predictable. Indeed, but yeah, sizing, we have to corroborate with hydration status and while we are doing inside. And there are enough information and enough articles on that, how to size your LA appendage on CT. So obviously like CT.
That is again, that is another weapon in our hand. Both can be used, but non-ionizing add-on. If it is there, it is good only. It will add value. Definitely CT has also role.
So
I have also shown.
Democracy here. You can do on T, you can do on ICE, you can do on CT also, but paroperative ICE is important. What CT does, you can have associated information on clot and coronaries by doing angiogram. Second, you can have a 3D printing, which is not possible here. You can have a fun of fusion imaging, like if you have a G machine from your CT lab, you can put this on echo. And the fourth, the biggest fun is virtual reality. So what is the fourth D? Fourth D you see on time. The fifth D, you can play with the LA closer device or positioning or in front of you with the VR camera. So if you have CT, then you can go for virtual reality. But things are changing very fast.
One point I wish to add, with the new integrated NAVIC integration.
No more point.
NAVIC integration, the 3D TE can get integrated with the fluoroscopy. So we will see during putting our device that LA appendage of the TE will come. So you know you are inside the LA appendage in the 3D in the same screen. So that NAVIC navigator is a very, very new add-on for the structural intervention.
The radiation safety. Like you don't have to prove all the time. You can see it on the fluoroscopy skin intermittently. You can directly enter into the.
No, that's not in CT. 3D TE and fluoro. Fluoro and 3D. You are anyway deploying the device in fluoro. So same time that.
About CT scan, utility of
no, I am
CT scan,
telling in the imaging what I was telling. NAVIC is add-on. That matter is closed.
Okay, thank you very much. So next presenter.
So good afternoon, everybody. So my talk is on timing of NOAC after left atrial appendage closure. Many doctors, physicians, cardiologists may think that after LA appendage occlusion, there may not be any need of oral anticoagulant, which is not totally true. And if you have somebody with a non-rheumatic atrial fibrillation, like in this case, we know today that most of the time the site of thrombus generation is probably the left atrial appendage, and that is the site from where the thrombus gets fragmented and dislodged different places, creating ischemic event, be it cerebral, be it cardiac and peripheral. But if you occlude that left atrial appendage by device, then obviously that can be taken care of. Normally for atrial fibrillation, the recommendation is to give new generation of oral anticoagulant, but there are certain situations where it cannot be prescribed, because we know that atrial fibrillations are having increased risk of thromboembolic stroke, predominantly due to formation and embolization of clots from within the left atrial appendage. But historically, the standard care is anticoagulation. But there are situations where you need to do some mechanical device closure, like left atrial appendage closure, which may reduce the incidence of stroke significantly. And we need to remember that even the device needs to be treated with antithrombotic drug for some time. It could be warfarin, it could be DOC or NOAC, or even dual antiplatelet drug to prevent further thromboembolism and device-related problem. So device-related thrombosis is currently one of the most concerning complications that occurs about 4% of patients after left atrial appendage closure and is associated with 4 to 5-fold increase in ischemic event. Device-related thrombosis is caused by formation of thrombus over the atrial aspect of the device before its complete endothelialization, which typically takes about 3 months' time. One possible explanation may respond to the increase in prothrombin fragment, which is very important for all of us to understand, that there could be increased a number of prothrombin fragment, 1 or even 2, and thrombin, antithrombin 3 following the procedure with no increase in platelet activation. And there are predictors. There are clear-cut 5 important predictors which may actually cause thrombosis even after left atrial appendage occlusion. DRT presence may actually cause thrombus formation. These 5 factors are hypercoagulability, pericardial effusion during the procedure and after the procedure, renal insufficiency, implantation depth, more than 10 millimeter from the pulmonary vein, and non-paroxysmal atrial fibrillation. So if you have out of these 5, any one of those factors, then you need to understand that if device-related thrombosis, the chances is very high. And following conversion of risk factor points, patients with more than 2 risk points for device-related thrombosis, there's a 2-fold increased risk of device-related thrombosis compared to those without any such risk factor. So that is what is very simple message from this talk. And Dr. Barnenmeyer from Germany and his colleagues from other parts of Europe, they actually created a consensus statement on catheter-based left atrial appendage closure, which you know. But from the same paper, it has been derived that mobile thrombi visualized by screen transesophageal echo are considered a contraindication. We know that. But in such cases, if there is a more than 4 weeks, NOAC may be prescribed, and after that you may think of giving what is called LA appendage closure. A lot of anticoagulation protocols were tried: heparin, LMWX, aspirin, warfarin, clopidogrel, so many. But transesophageal echocardiogram performed after 4 to 6 months is highly recommended to verify outcome and define further anticoagulation program. So that is extremely important, that you need to follow them up at least for 6 months by transesophageal echo to see what is going on inside the left atrial appendage, particularly the atrial side of the device. Therefore, consideration should be given to transesophageal echo follow-up at 1 month, as theoretically this is a crucial period for device-associated thrombus formation. And PROTECT AF trial has shown that the device-associated thrombus formation is as high as 4.2%. And that could be 0.3 per 100 patient years. Anticoagulation therapy is recommended in all patients with device-associated thrombus, regardless of symptoms, until thrombus resolution is confirmed following transesophageal echocardiogram. This is a big registry called NCDR Left Atrial Appendage Closure Registry-based study. And in this particular study, this is a Dr. Vivek Reddy from Mount Sinai and his colleagues from other parts of the USA. They have done analysis of 32,000 patients of antithrombotic strategic and associated risk and adverse outcome. These are the drug therapy that are given: warfarin, aspirin, others DAPT, NOAC, or NOAC and aspirin and warfarin. So there are varieties of combination in isolation or in combination were prescribed in these 32,000 patients and were analyzed. And it was found that this particular study demonstrated clearly an association between increased risk of adverse event, particularly bleeding events associated with adding aspirin or anticoagulation, and discharge on warfarin or NOAC anticoagulation alone was associated with a reduction of major adverse events. So the rapid onset and offset reliable pharmacokinetics and avoidance of laboratory testing actually finally said that probably NOAC or DOAC medication makes them an attractive alternative to warfarin. So this is a new understanding has come up. And furthermore, there's another trial which is very interesting called ADRIFT trial. And ADRIFT trial has shown, this is a study, they have shown the absolute risk of device-related thrombosis appears low and has been estimated to be 3.8 to 4% in a meta-analysis. And DRT is not benign, is associated with 4-fold increase in ischemic events. So it is important. Percentage may be 4%, but it is important. So in ADRIFT trial, where it has been shown that the reduced rivaroxaban dose versus dual antiplatelet therapy after left atrial appendage closure, they found that the summary of ADRIFT trial is that 87% had contraindication to chronic oral anticoagulant therapy. People more than 75 years of age. ADRIFT enrolled patients at high risk of both stroke and bleeding. Average CHADVAS score was 4.6 and average Hasplate was 3.7. 2/3 of this trial population received the Amplatzer amulet device and the remainder received Watchman. And the conclusion was that it has been found that 3 months' time, there was no significant difference between thrombin generation between two dosage of rivaroxaban, 10 or 15. At 3 months' time, although thrombin generation was lower in all three treatment arms, DAPT, very important point, DAPT remained significantly associated with highest level of prothrombin fragments after LA appendage closure. And that is amazing. So the concept of putting them on DAPT has gone because the similar trends were also seen in other markers of thrombin generation, including thrombin antithrombin complex, D-dimer, and these differences were not significant. Another trial where actually they tried apixaban after left atrial appendage closure, and this trial has shown that low-dose apixaban after left atrial appendage closure may be a valid alternative to DAPT and single antiplatelet therapy as depicted by reduction in occurrence of major bleeding and combined with DRT, device-related thrombosis, and major bleeding respectively. So a low dose of apixaban, maybe 2.5 milligram twice daily, can also be a considered option. They also found that within the first 3 months following left atrial appendage closure, numerically higher rate of non-procedural related bleeding were observed in DAPT patients. So clearly DAPT patients are having higher risk of bleeding, more prothrombin fragment as compared to a low dose of NOAC, like low dose of apixaban or rivaroxaban. Still many such trials are going on, and we have to wait to get much more information about the new understanding of NOAC therapy or DOAC therapy after left atrial appendage closure in patients with atrial fibrillation who are otherwise not fit to remain on a long-term anticoagulant drug. So you have to wait till we get the results and come back again to have further information and further insight about this understanding. Thank you very much for your attention. Before that, in conclude, we can be said that NOAC has shown promising preventing complication after LA appendage closure. Low dose apixaban is a good antithrombotic treatment. Current evidence is limited. Randomization trials are warranted. Some of the upcoming trials in this regard are following. NOAC have been used in the control arm of some of the studies. Thank you very much.
Ravin, I have got two questions.
Sure.
One is, what will be the optimum duration of NOAC after LAO? Second, one of the indication of this LAO was that in patients who are eligible for NOAC or anticoagulation, but because of the high Hasbled score or INR was unstable or there is a high bleeding score, and that was the indication for LAO. Another one indication. In those situations, what you are going to do?
No, as of now, we know that those patients who are unsuitable for long-term anticoagulant therapy, be it NOAC or warfarin, then we do not consider we consider them, or even previous sort of problem with cerebrovascular problem, then we consider them a right candidate for left atrial appendage closure. This is a kind of standard practice. Nevertheless, we realize that even after left atrial appendage closure device implantation, there are chances of having problem, although it is less, 4%, but still it is there. So we need to consider them that whether some of those patients would require a kind of some drug to thin the blood. Conventionally, we give DAPT. But then they realize that, well, DAPT has actually causes more prothrombin fragment left out. That is a prothrombotic anyway. So why not to give a reduced dose or modified dose of NOAC? For that, a couple of things to be done. We do not have enough information as of now. We are not quite clear that what is the right duration, right time, right dosage. But what we need, that they need to be under follow-up, and transesophageal echocardiography is very important to know what is happening to the atrial side of the device, and also to see what is happening clinically to those patients. As of now, maybe first 90 days as of now, but we need to have much more data to substantiate this observation and to create a guideline.
Just, I know it's a structural meeting, and left atrial appendage occlusion devices are getting popular. But to all those who are interested, I would suggest that at the time of when they're free, they should listen to an electrophysiologist by the name of John Mandrola, and his comments that we have based treatment of over 100,000 patients in the United States with these devices with data which is suspect with less than 1,000 patients. So I was actually telling Anuj that a little while ago, and what I wanted to ask Robin is that with factor 11 inhibition now knocking on our doors, with milvexian likely to be the new NOACs that we are going to be using without much bleeding which would be anticipated, although that's quite counterintuitive. What do you think will be the role of left atrial appendage occlusion in that time, once milvexian is available?
Yeah, that is again a very, very provocative thought, and we do not have any answer to that comment, to that question. But what as I have gone through the literature before presenting this talk, I was really astonished to see that even a lower dose of DOAC may do a good job in some of these patients. But this is too early to make any comment. We need to wait to get much more information to give a final opinion.
Thank you very much, sir. I think it's really interesting. Once the agendation will come, factor 11 inhibitor, and there will be hardly any candidates for left atrial appendage devices.
Before it comes, would you go for LA closer or not?
Yeah.
Really, actually, if you really look at the landscape, other than very individualized choices where I have strict anticoagulation contraindication, I would think that anticoagulation works as well. And I would not really recommend LA appendage occlusion to everybody. Just like...
I think just two comments, like one, the DRT is a passing weather. It's like summer and winter. You don't die until it's extreme summer or extreme winter. So it does not translate into stroke. Second, the NCDA registry nicely has mentioned out of 32,000 patients, 70% reduction of ischemic stroke in NCDR. Forget about the hemorrhagic stroke. 70% reductions of ischemic stroke by LA closure.
I think you should look at your data a little more carefully. Just don't go by the NCDR registry data. Look at the trial data, because the NCDR registry is also considering the fact that there have been improvements in care. And we all know that the stroke risk in atrial fibrillation is not truly related to atrial fibrillation alone, because even when you calculate the CHA2DS2-VASc or the Hasbled, you're actually looking at systemic factors. So just food for thought.
A year back, one trial was conducted, RCT, Apixa-1 versus LALAC, and there it was found non-inferior. Non-inferior means it has numerically higher, problems like thrombotic events, but it was non-inferior. So both are equal as of now. So Dr. Kapadia, yeah.
One food for thought, being an interventionist, I'm still talking of surgery. Has there been any comparison between just a left atrial ligation, where I think once we do that, you don't have to give even an antiplatelet for people who are in high risk of bleeding. And I think it's not a very high risk
surgery. That's a very old sort of treatment people used to do.
Yeah, so like a CMV, because
we do not have those data at the moment.
Yeah, we've seen so many PBMVs who had undergone a CMV earlier. Then nobody has ever had a LA clot. And once we actually bring them back for a restenosis, Probably, and it's a cheaper treatment, lesser. We don't have to give any antiplatelets or anticoagulation later on. I think that's a war won. So.
Yeah, this is a good thought, but do not have. Rishi got a comment. But before that, Anil, just again, I think this is for everyone. What is very impressive that those patients, with those 5 factors: renal insufficiency, pericardial effusion after the procedure, peri-procedure after procedure, renal insufficiency, pre-thrombotic stage, hypercoagulatory. These are the important factors to be remembered even after LA appendage closure.
Yeah, Dr. Rishi.
Surgical closure is winner. The last trial on surgical closure, definitely winner. Yeah, Rishi.
So I was also going through some literature, and I would continue to what Dr. Dhal was saying, that true that NCDR registry may have shown a reduction in ischemic events, and predominantly if we take the patients who are absolute contraindication for anticoagulation, then that's a different story. But otherwise, in all the 3 major clinical trials, the ischemic events have not reduced. Actually, there has been a non-statistical increase in the ischemic events, and the benefit has actually come from the decrease in the hemorrhagic events. So, I think that is, I mean, all the 3 clinical trials have shown it, very, very conclusively that ischemic events are not going down, they are actually going up. Going the fact that the thrombus on the device, also the incidence between 3 to 4.5 or 5% in different clinical settings is also one of the concerns that.
But it's statistically non-inferior, and these are the reasons.
The non-inferior with NOACs, with warfarin, there actually has been an increase in the.
It's about NOACs we are talking. Warfarin, nobody's talking.
You are talking of protective.
Protective.
Yeah, protect.
The point here is that whether the thrombus is in the coronary or anywhere, it's difficult to manage. Even factor 11, the phase 2 trials, not with milvexian, the other molecule, they have not shown the very good results with the comparison with placebo. Whether it has, phase 2 was with the dosage trial, and they didn't give any good safety benefit or even ischemic, although ischemia was not a part of the study. So I think everything needs to be taken into consideration and probably individualize, and maybe after LAC as you see risk factors.
Sure, and don't you get carried away with that DAPT enhances the prothrombin.
Okay, one last comment. The older trial, like the biggest one, the Protective Prevail, they were like a decade-old trial, and that's where the LA appendage started. When they started this, it's not India. They have the separate pediatric cardiologist, separate cardiologist. There were higher embolism. People used to navigate and touch the things with a wire in the LA appendage. That's why the pericardial effusion risk was 4%. And that all negated the whole benefit. And that's what the people were kept on anticoagulation post-procedurally, irrespective of their HAS-BLED score. Now, if you see what you are saying is the, I think, Prague 17 trial, the Prague 17, there was again NOACs. Now, what happened, if you see TAVI, it started with extreme risk, high risk, then low risk, and now we are going to talking about some different anatomies. The device evolved, our understanding evolved, our experience evolved, imaging evolved. We moved from 3rd generation devices. So now if we compare our experience, compare the device and everything, and we can't compare the trial, what happened a decade back or a little around that. So we have to understand that there are always subset of patients. We can't just say because the older trial.
I think time is running out. If you really want, you have to change with time, and otherwise time will change you. If you really want to go to the ocean, you have to leave the shore.
Dr. Abhishek, from comment to now you go for presentation because we missed your presentation. Your flight got delayed. So there is a development on both fronts, devices as well as drugs. So I think it will be very exciting to see. No. We missed his lecture tower. So it's not in tower.
My
it's on
flight
tower,
connectivity is not fantastic to Ahmedabad. First of all, thank you, Dr. Dilip and Kolkata, for inviting me. My topic is little controversial, and we don't have much data. So let's start with the problem statement. We think that aortic stenosis war is almost won by transcatheter therapies, but aortic regurgitation in China, above 70, prevalence is around 2.2%. And if you take a country of 1.4 billion people, that makes a big number. The annual mortality of a patient of aortic regurgitation with severe dysfunction is nearly 20% per year. But only 5% of these patients are treated. The problem we have is lack of randomized data. Aurora study is like kind of enrolling patients in China with a Vitaflow valve, and we don't know how the results are going to be. And most important thing is we don't have dedicated devices like Jena valve, Engager valve, or J valve in India. So what are the challenges? The problem is that in AR, patient has a dilated aortic root, dilated aorta, elliptical annulus, lack of calcification, which creates a problem for our anchoring. And these anatomies are usually very large. So this creates a problem of your THV anchoring, lead to dislodgement, PVL, and your oversize. As a result, you need to be more. So you end up in a very high pacemaker rates, which is approaching around 25%. Stroke risk was in older data was like 0 to 5%. Severe PVL, moderate to severe PVL was with the older generation device was around 20 to 23%. And nearly 25% of the patient required in those data was second THV. But if we come with the newer generation of the devices, the device success rates has gone up from 71% to 95%. All-cause mortality has gone down from 12% to 7%. Moderate to severe PVL has gone down from 28% to 7%. It was nearly zero. And we had one discussion going on around what's valve to be selected for the patient with a zero calcium. So with zero calcium, it's always, sounds very safer to use an oversized device. And when you want to oversize a device with the safety, you want to go with a self-expanding valve. And at the same time, at aortic stenosis, we are solely on annular level for our anchoring. But when you treat aortic regurgitation, you should think of different anchoring points in LVOT, above the annulus, STJ, and ascending aorta. Possibility of recapturing the device is something very fascinating, but most of us who has used the self-expanding devices have realized this movement of the device happens once you release that. So I'm really not sure how much it can really help for an experienced operator. Self-positioning of a device is one aspect, which is like you have a Boston Accurate Neo 2 in India now, which is a self-positioning device because it will align itself first and then the valve will open. It can have indeed a very unique idea to use in a pure AR cases where the anchoring is not so much dependent on a valve calcification. But at the same time, we have to understand not all the self-expanding devices are same. So this is like a different anchoring site. These guys have mentioned about with the different kind of devices we have. We can have an anchoring on annulus and higher above STJ, LVOT, and as well as into the ascending aorta. So we have to understand our device well. We have like four pattern of devices available in India. The middle one is like Sapien 3 or MyValve, which is a balloon expandable device. Most of us have used this, at least one of them. The first one is Accurate Neo 2, which is a unique hourglass kind of design, which is the broadest in the middle. And there is upper crown. The upper crown is almost like 8 millimeter larger, or 5 to 8 millimeter larger as compared to their bench size. This upper crown specially helps you to prevent the embolization of the device in the ventricle. If you use a Medtronic device, that device is like tapering device. It's a flat bottom device. So if you lose the position, if you go dive in, it lies a little inside the LV. It goes really deep in, and that creates a problem. But with the older generation devices data, most of the study and experience is with the core valve only. Then you have a fourth type of pattern, which is like a kind of a hydra or a portico type of devices, which is nearly cylindrical, which prevents the very deep embolization of the device into the ventricle. Before you start treating a pure AR case, first of all, we have to see whether it is a primary AR or it's a secondary AR. Is the ascending aorta an annular disease which has led to the dilatation, like in Marfan or bicuspid aortopathy or something, or it is kind of a primary disease like endocarditis or the aortic valve cusp prolapse. Usually it's the right cusp which prolapses much. If you are going with the primary pathology patients, many of them are usually suitable to get a transcatheter devices. If you go with the secondary devices, you usually end up in having only one anchoring point, that is annulus, and such annuluses are usually very distensible, so chances of device embolization are very high. So we did one interesting case this week, courtesy Dr. Amit Bhushan, he is my colleague and friend. We did quite some of cases. This patient was a 74-year-old lady, severe OSA, diabetic, some CKD and hypertension, and now had a worsening dyspnea, severe AR, normal EF, moderate PH. Surgeon turned down because of the severe OSA. So now if you analyze this case, what is happening at the level of annulus, you get an area of from 322, but 1 millimeter below or 2 millimeter below, your area is only 280, and 3 millimeter below, it is 298. So it's a small anatomy. Usually you have many options with us to treat such kind of patient with available valves. This is not like a very large anatomy where you have only one or two options like MyValve, Medtronic or Sapien. But when you're treating an AR, always see what is happening above as well. So above the annulus, up to 1 millimeter, it is fine. It is like 367, still you are falling in the range of 23 millimeter valve. But higher up, it's bigger. So I expect I'll be having only one anchoring point. This is the image where there is no calcium, access is good. So this is what we have to understand our anatomy and device. This is this Aurora trial has tried to classify your AR cases into four points of anchoring: above the annulus, LVOT, and ascending aorta. If you have more than 2 anchoring points, like up to type 3, you can still consider this patient suitable for transcatheter therapy. They are not trying this kind of, they are not enrolling the patient who are in type 4 where there are only 1 anchoring point. So in our case, like with a 1 millimeter below the annulus, around 280, the oversize with around 21.5 millimeter valve is 30, and with 23 millimeter valve oversize approach is around 48.4%. With 23 valve, it is 13 and 29. So it was really kind of a tricky choose for us whether to go with the 21.5 or 23. But with a balloon expandable valve, you can certainly make your choice better by oversizing the valve, putting extra CC. So we opted to go with a 21.5 millimeter valve and some extra CC. This is a view, this is an angio of a coplanar view. Instead of putting my pigtail in the non, this is a small anatomy, I put my pigtail in the right so that I get a more adequate information about the anatomy on both the side, what is happening on left and non. As well as if you require, you can put an extra pigtail in the LCC cups and NCC cups, but you should have a proper location because you don't have those calcium landmarks, what you have in aortic stenosis. In the next image, as you see, my valve is not in having a very high position, which we usually prefer to have in case of aortic stenosis valve deployment. We usually prefer to have like 60, 40, 70, 30 kind of deployment. As well as when you deploy, just because we wanted to save some fluoro time, we lost the images of deployment. So once you deploy the valve, unlike aortic stenosis where you deflate the valve rapidly and inflate the valve relatively faster, if you are going with a balloon expandable valve, go with a slower inflation like you do in a mitral cases. And instead of stopping your pacing immediately from 180 to 0 or 60, we usually prefer to go slowly, let the hemodynamics come back, avoid any spike of stroke volume coming out of LV, and make your one imaging through there and just check, is there any PVL? We suspected some kind of things happening in that way, but we didn't chase it much. Post-procedurally, there was like suspicion of no PVL or anything, good result. So, and usually we prefer that this kind of patient has a pacing going on like 100, 120 for 24 hours to avoid a delayed embolization. And I always keep in mind the bottom of the valve, as you can see, that it is flared up. That's a very short sign that the anchoring is going well. And the indentation is happening above the valve frame to ensure that you have proper anchoring going in there. And just quickly, I will just go with the one quick zero contrast case. This is nothing very unique. It's just a different kind of techniques we use for avoiding contrast in a particular case. 80 years old male patient had a CKD already. We didn't listen to ourselves. We went with the CT scan. The creatinine jumped to 4, nearly approaching dialysis for that patient. Luckily didn't require, had aortic stenosis, NYHA class 3-4, and had a peak gradient of 65, mean 45, aortic wall area 0.4, EF 45%, and patient already had a pacemaker. So this was a blessing in a disguise. We didn't have to chase for multiple things in a single patient. We wanted to have a safe placement of the valve. So going for a very high valve position, when you already know this patient is gonna need a pacemaker, I would not play around with that. So this is a pre-procedure echo. As we can see, some LV dysfunction, bicuspid, tricuspid valve, and high gradients. Here the annulus perimeter was around 71.7, and LVOT was nearly same, 71.4. Wide enough sinuses, so no need to worry about coronary occlusion. Left height 15, right head 18. So this is what usually happens when the patient grows old. Usually the sinuses dilate. You try to treat a younger patient, bicuspid patient, you find those effaced sinuses. Once you have a patient growing older, so this like dilatation of sinuses is a kind of a sign of aging. So we were like happy with that part. STJ was around 74.5, so this could work as a third anchoring site for us, even in aortic stenosis case. Had this patient not having a pacemaker inside, I would have counted on this side for anchoring and opt for a very high valve position. But it was not the case with us this time. This is a regular angle coplanar cuspal overlay. And there is some calcification of the arch and some at the STJ, so not a very good case for the surgeon also, because this calcified STJ would have a difficulty in implanting the surgical valve through that. Symmetrically distributed calcium, nice femoral access. So we went with Hydra 26 millimeter valve. We are really in the kind of the middle of that range. So to start with, we put a 2 pigtails to ensure that our coplanar view is correct. Although we had some information on a CT, but we wanted a guidance continuously during the deployment. So instead of using 3, we were okay with 2 because we already had a CT done with the contrast. Then, as usual steps, the pre-dilatation. And then we took our valve with the transesophageal echo guidance. This procedure was done in general anesthesia. Standard initial positioning. Now I have my idea regarding where the left is. So my pigtail moved. I didn't bother much because by this time, I already have my TE probe to guide me in case if it is required. Initial deployment as standard with most of the self-expanding valve. Go slowly till the valve opens. Then you go faster once the annular contact happens to prevent the occlusive period. We went on a further release of the valve and we moved to the coplanar view just to check the depth, what is happening on the left side. Left side depth was little low. So we always, when you are not using a contrast in such cases, and as such also, when your device, the position is low, especially on the left side, that's where your device might be impinging on the aortomitral continuity and you can have an MR. And you can always like to check, is there any worsening of MR before you decide to deploy the valve? So in this case, there was no much worsening of the MR, there was no much PVL, so we continue with the deployment. And so this is a final release. We didn't take any pictures, so there was no sense of exchanging pigtails and all those things. Hemodynamics was good. Post-procedure echo, like single-digit gradients. Trivial PVL, no any worsening of MR, no any turbulence through the aortic valve in either of the view, 4 chamber or in the 120 degree. Echo findings, peak gradient 6, mean 2. Conduction testimony, nothing new. So it was like just a one experience to share with. Thank you.
Your topic was on pure air, aortic regurgitation. Yeah? TAVR in air.
Yeah.
So what do you think?
Was the pure air.
Pure air. So don't you think the 21.5 valve in air is undersized valve? How much extra CC did you take?
So so because the 1 millimeter below, it was 280 area. And with 21.5, my oversize was about 30%. And with balloon expandable valve, you have a liberty to make your size little bit changed. So we went with 21.5 plus 2 upfront, because the last CC delivery you can, with experience, you can decide to, depending on the balloon flaring. And then we give an extra push with more 2 CCs. So that's the difference between the second generation balloon expandable and third generation. When Sapien XT was changed to Sapien 3, the leaflet overlap was higher. So official IFU says you can go with the 10% more extra volume. But off late, all of us must have tried to go with the 20% extra volume. And I didn't stop pacing immediately to prevent embolization. The first picture we took with a pacing on around 120, and we give extra push at that time.
If you have access to Jena valve, Jena valve. No, it's not. Jena valve is the only valve which can
clip mechanism.
Put this leaflet under his arm, and a different mechanism. And that is the only valve recommended for pure air. FDA. And this is the only valve which can take care of the VTC. If the VTC is compromised less than 4 millimeter, the coronary access issue, without doing basilica or snorkel or chimney, you can take care of the valve. So Jena valve, I think in the future, if you have a bulky leaflet, if there is a chance of occluding the coronary sinus, it holds the valve first and air. If you have LVAD and air or kind of support beforehand, then you can go for a stent scut, where just a stent scut, then the regular valve can be deployed. But without a LVAD or ECMO, if you put the stent scut, larger stent scut, there will be huge torrential air. The patient may not be able to tolerate that.
Shortcut device.
In LVAD, if you have LVAD. Air, left ventricular assist device, LVAD air, pure air on LVAD.
Okay.
There you have a scut, you put a stent scut, larger stent scut from Cook, and that can hold your balloon expandable valve. Otherwise,
I think there is a RCT going on.
ECMO or LVAD?
Those who are LVAD, usually it is closed. Aorta is closed because there will be AR. So there in LVAD there is no need of, the aorta gets closed, but aortic valve is closed.
No. LVAD, you can have systolic air also, you can have diastolic air. It's a continuous.
When it sucks the blood, AR develops, and that mild AR can be more. So they close, leaflets is closed.
No, that is one of the treatment. But if you do not stitch the valve, you still have air, you can put a stent, larger side of the SCART, on the SCART, like pulmonary valve. Muthu, are you there? Oh yeah, he is there. Great man. I mean, so in PR, they do the same procedure. You put a SCART, stent SCART, on that you put a melody valve. So similarly here, what's your take on if you have a pure air? Yeah, Anant, oh, you're beautiful.
It's okay. I think you have summarized some of the issues with the pure AR. As I already clarified, a pure AR and a mildly calcified AR are completely different. A pure AR dilated and non-coapting leaflets, obviously self-expanding balloon, whatever you use, it's going to give trouble. Self-expanding will keep sliding into the LV. The only way to do a self-expanding is to combine with another valve. So you put the self-expanding like your platform, and within that you put immediately a balloon expanding. So that acts like an anchor. So as you said, pulmonary valves, we stent it and then we put it. But for the aortic position, to kind of reduce that instability period, you put a self-expanding first, immediately you put a balloon expanding inside that so that you're not worried. LVAD patients, severe AR, most of them will have some calcium. So you will easily put, there are much sort of both balloon and self cases are done. We have also done with the self-expanding, so it doesn't give much trouble. You can safely put a stent and then put a valve, but that's not necessary. But most of the times you can get away just putting one valve in those LVAD patients. That's fantastic.
Sir, good evening, sir. Thanks for inviting me. So actually, the pulmonary valve, what we have done so far, so we are not doing a stent now. How we size it is basically they are very elastic and no calcium, we can upsize them. We go with the balloon sizing and we see a complete seal on a balloon sizing. We inject an RV and see for any leakage into the PA and simultaneous injection. And that from that point, we take 25% over sizing. So it's a balloon sizing. I have done two pure ARs so far in India with the balloon expandable valves. One of them, both the times I used a balloon to dilate the annulus. Looking for sizing rather than balloon dilatation. So I go for the highest diameter of the CT scan and see what's like. And if I see there is not enough tight fitting of the balloon, then we increase it up. Yes, we increase the volume a bit and go for the tight fit. From there we go to 20% more. And this, particularly the elastic aorta doesn't rupture basically because of calcium in the rupture. So we go more than 20% of. That's the thing we have done a couple of cases and the good results we have. So one case we used 29 valve, one case we used 32 valve.
Yeah, so another difference physiologically. So yeah, just a minute, sir. Yeah. So AR, the aorta is used to large volume of blood, whereas in aortic stenosis, aorta is not used to large volume of blood because of less stroke volume. So as Muthu is saying, aorta, pure AR, it can accommodate higher size.
Higher size.
Yeah, and there is a trial going on, a realigned trial. I think Martin Leon and Raj Makkar is doing. And one of the webinars I was just hearing them, listening them, that they were very positive about the initial results with the Zena valve. So maybe.
But thank you, Muthu, for coming here. We are much more excited to have you here. Muthu.
21.5 usually don't have severe.
We are much more excited and enthusiastic to see your face here.
Thank you, sir. Thank you, sir.
So I think Muthu has a flight to catch. So I request Muthu, Dr. Muthu Kumar, to give his presentation. Then we'll have a short cases and then we'll move on to BMV sessions.
Muthu is the guy who taught me VSD in the middle of the night. He came from Singapore at 1 o'clock. He taught me how to do VSD in my early days. VSD. Machuka.
Thank you, Direkima sir, for inviting me. I always love to come to this part of the world, and I've been with Dr. Hasra and everything, it's like home for me, second home for me, Kolkata. So, It's been a nice journey for last 6-7 years with valve implantations, and I'm so glad that India we improved a lot, and we've been able to do and share experiences with the world. Actually, we got a lot of cases available, and with the advent of new valves around and new things like Hydra and other valves coming in, it's getting more and more interesting. So my topic is going to be on mitral clip. How do you select the patient? Slides on. Yeah. Coming up. Sometimes doesn't happen. So the important thing about I think they're getting the slides in the mitral clip is patient selection. Which patient will have going to have good result, and we know that it's a very expensive procedure, and very important that the patient has to be selected properly. So the pre-op evaluation of mitral clip is very important, so that we're able to properly select them, and we get the results. I think this is not a problem. I think. See, you should recognize right away. Shut it off. I'll do in between.
In the meantime, I will show them some cases.
Yes, okay.
It's coming, huh?
Yes, see, sir, I just logged in, I can see. Sometimes it recognizes once you switch off. No.
उनका एक पेन ड्राइव में ले लो, ठीक है ना? ठीक है सर.
Okay, fine, I'll do that.
पेन ड्राइव में ले लो. इसको लगाओ जरा. इसको ऑन करो. Can you on this? Can you project this? So by the time Muthu is fixing his presentation, we'll show some of the cases of left atrial appendage devices. Showing up. ठीक है चलो. Yeah, so we have seen tips and tricks by Dr. Ranjan Shetty on how to do a left atrial appendage device, and we also showed the imaging part from Dr. Anil Singhi. So in our experience of 25 cases, what we have encountered is you can do left atrial appendage devices by so many methods, It's just kind of you need to just hang around that we will do that, and you can do different ways of doing that. So this was a case I will show you. This was a lady, a 68-year-old female. He had post PTCA 2010, 12, 15. All angioplasties were done by me, and it was not the same vessel, it was other vessels, and not also ISR. She developed acute coronary syndrome with different lesions, and every time she required a PTCA. We also did a pacemaker in this lady in 2013 because she was having 6-sinus syndrome, atrial fibrillation, and she was on VVI pacing of late because she was always in AF ablation, atrial fibrillation, and in between she had a very high heart rate as well. So we also did AV node ablation. So she was on VVI pacemaker after that. Then she developed recurrent hematuria. We brought the dose of apixaban from 5 mg twice daily to 2.5 mg twice daily. Still, the patient had occasional hematuria, and this time she had a CVA, thrombotic CVA. So there was a need of a proper solution for that. She was persistent atrial fibrillation on with PTCA, on PPI, VVI or pacemaker, with node ablated. So atria was always in atrial fibrillation, and there was a hematuria, there was a bleeding on anticoagulant, and once the anticoagulant dose was reduced, she had a CVA, thrombotic event. So there was a desperate need to do something for this lady, and we planned for a left atrial appendage. So this was the puncture, which we all are aware that we can do that the conventional way, posterior inferior, go in, and you can go ahead with a pigtail there, and then you can take the device in left upper pulmonary vein, and you have to unsheath the device a bit, make a ball, and when we come down, and it comes to LA roof, and then little anti-clockwise, if you push it, it will go in left atrial appendage. So here what we did was, it was with the pigtail, we were very clear that it was a left atrial appendage only. So we deployed the device there. So other ways, you can go in left upper pulmonary vein, make a ball, come down, it will slip into the LA appendage, and then you can deploy the device. And the device sizing is very important based on your on table, on GA, well hydrated patient, and then you measure the the diameter at the circumflex level, and then that is there. And then for watchman, you also go a little distal, because watchman is a little, you have to go deep, and then a 10 millimeter distal diameter also need to be chosen. And then we deployed it, and then we did a wiggle, and then finally the device was released. So this was one way, and second is you can directly deploy, take a, here you see we went inside the appendage, and you take sheath over a stiff wire, and once your sheath is in on this, then you can directly deploy the device. This patient had a subdural hematoma on anticoagulation, and he was in chronic atrial fibrillation. So these are basically the 5 signs of proper deployment. Before device release, always check the 5 signs, and this is for amulet, because our most of the experiences with the amulet, last 3 cases I have done with LifeTech, you need to see the compression on the lobe. If the lobe is compressed, it means you have chosen an oversized device. Separation between the device lobe and the disc, there should be some separation. Concavity of the disc is very important. Axis of the device lobe in line with the axis of the LA neck, it has to be ensured. 2/3 of the device lobe distal to the left circumflex artery should be there. Otherwise, it is going to pop in the left atrium. So that is what, the basic principles which guides us. When to use which device? When there is a very short left atrial appendage, amulet may be a better option than watchman, because we have to go deeper. And if there is a very large left atrial, appendage, then the maximum landing zone for watchman becomes handy there, and it can be a device to be chosen. Multiple proximal lobes, amulet again may be better. But if there is a bad angle between delivery system and LAA, watchman may be better. But for last couple of months, I've started using LifeTech devices, and they are extremely user friendly. And I have also seen chances of pericardial effusion to be less. It's less traumatic and easy to be deployed. Thank you so much.
Wonderful presentation, sir. So when we form a ball in the pulmonary vein and when we drop it down, how do you make sure that you've actually hit the left atrial appendage? Do you feel a resistance?
Yeah, no, this is entirely the job of the person who is on imaging. Yes, and that is why this is not a single operator job. You have to have a person who is on imaging, and that and he should be proficient in his job. He will guide you the procedure. So we do together, myself, Dr. Anil Singhi. He is on imaging, and then I do the procedure, and he guides us that you have gone into left atrial appendage. So you just have to come down, make an anti-clockwise, push it. It goes there, and it is not your feeling. It is the your imaging person or the co-operator will give you an idea that you have gone inside.
You do the tug only when you release the disc also.
Yes. Yes.
Yeah.
Muthu,
and no anticoagulation is required if it is a if it is a neck-centric device.
Yeah, so dual antiplatelet does the job.
Only
dual antiplatelet does the job, and in one of the situation when the subdural hematoma was there, I kept the patient on a single antiplatelet, and after 1 week time, and that patient is still doing well. There was no further thrombotic effect.
Now newer devices are coming like Amulet 2, so that made me even softer and more accommodable with the appendage, and Watchman Flex Pro, which because there is in the apex, in the apex it was open, so there was risk of tamponade, but now it has come with a close and more rounded, so the chances of tamponade is very low.
Yeah. Yeah. Go to Muthu. Yeah.
Okay, good evening once more. So we got this glitch started out, and I always ask for a second person help. Anil Singhi's hardware worked up. Whenever in the cath lab something gets stuck up, we just call up people. Only one Anil Singhi's things work all the time. So the FHRS mitral clip is based on, you all know FHRS, the FHRS stitch, which is basically making a single orifice mitral valve into a two orifice mitral valve. And this is supposed to be the surgical technique. Initially it was felt to be successful, but a lot of other reservations on this technique. But this has been the background behind our mitral clip. So mitral clip approval CE 2008, and since 2013 more than 100,000 implanted around the world. And India we got about 3 years ago, and we have done a few cases, less than 100 so far, but still then we are getting more and more experience with this mitral clip. So, so my talk is going to be who, what, why, when and where, and that's going to be my basic talk. So there are two types of patients. We have primary mitral regurgitation and secondary mitral regurgitation patients. With primary, who have got extreme surgical risk, who are not able to go for surgery because of high STS score, and those which can be considered for mitral clip based on what we have find the echocardiogram. And if you have a secondary mitral regurgitation due to any other problem, we have to meet the co-op criteria to go for it. Severe MR assess that you are looking for the MR in quantification method like PISA method to make sure that we are dealing with severe MR. And if we don't, then even though a mitral clip may not help in getting the symptoms better, and why we improve the quality, prognosis of life and functional capacity of the patient when mostly are symptomatic patients who are anatomically suitable for mitral clip, particularly with secondary mitral regurgitation, we have to maximally give them the maximum dose of anti-failure measures, CRTs and revascularization been tried on, and then still then it's not improving, then we could try a mitral clip. Where, and I stress on this point because it's not a single man show. Mitral clip is a multidisciplinary team. The anesthetist, imaging person, intensive care person, internal cardiologist, surgeon, everybody's work together in mitral clip, and that's very important because that's the single operator technique. This is not a single operator technique. Unlike a TAVR, is mitral clip is always a multidisciplinary approach. So these are the criteria we going to look for selection of MR severity. The MR etiology we look for what are the anatomical criteria suitable for mitral clip, and then additional feasibility markers and parameters. And are we really looking at mitral clip as the only option or looking for other options? If we go look at all these questions and once we answer them, we are ready for a mitral clip. So according to the American echocardiography guidelines, significant MR is your regression orifice area is more than 0.3 centimeter square, which comes to grade 3, grade 4 severe MR, and where you have regression volume more than 45, and you have a slightly reduced ejection fraction, but what we go for is the orifice more than 0.3. How we assess is by the PISA method. We make sure the aliasing velocity is not too high or too low. If you too high, you may underestimate; too low, you may overestimate the MR. Something around 30 to 40 should be okay. And we look at the PISA radius. We reduce the aliasing velocity and come to 38, and then we look for the MR peak velocity. And by this formula, we look for the maximum regression orifice area, and by that we quantify the MR. Once we quantify, we look for other signs of severe MR like systolic flow reversal in the pulmonary veins, and we have a huge coarctation gap, and 3D echo looking for particular valve leaflets. With all those things, we quantify and say this person fits into a severe mitral regurgitation with symptoms. So then we look for the mechanism of the MR. How does it happen? We look for the Carpenter's classification, type 1, type 2, type 3 and 3B. Most commonest one, what we use for mitral clip is type 1, normal leaflet motion, and due to pathology of the ventricle, your ventricle dilatation, which separates this valve leaflets, and due to that you have mitral regurgitation. The most commonest variety of this, where mitral clip can be very useful, is a functional MR. Which is secondary to ischemic or other causes for cardiomyopathy. So here we see normal valve annulus, dilated annulus, cardiomyopathy and central regurgitation. So most likely in the central point A2, P2 area, and pressure and filling dependent. And so most often we see a patient who comes to the hospital after medications and being very symptomatic outside. On admission, we reduce the filling pressure, and the MR disappears potentially when they come back again. And 2 or 3 admissions, you see the patient coming at severe MR. That's a candidate for a mitral clip. The type 2 is excess leaflet motion, where you have diseased valve, excess motion, prolapse and fail. This is already you have a problem with the valve with mitral valve prolapse, or you could even have ischemic changes where you have a flail mitral leaflet like a P1 or P2 and prolapsing valves. So here again we have to look for few of the criteria to meet before a successful mitral clip can be implanted. 3A is basically restricted leaflet motion due to the valve disease, diseased valve, rheumatic heart disease, where you have thick leaflets and you have stenosis. Here is a big no for a mitral clip. Already a stenotic mitral valve annulus, and we cannot convert that one small one into one. So here we say it's totally contraindicated to think of a mitral clip. Type 3B is again a functional MR due to regional wall motion abnormality, where you have restriction in the posterior mitral leaflet due to ischemia of the papillae muscles there, and you have the restricted motion, and so the posterior mitral leaflet does not contribute to the coaptation because of restriction. And here we have demonstrated that putting a mitral clip does help. And you can see that's where a gap in the coaptation, and looking at the point where is not coapting, we put a leaflet mitral clip there. So summarize, looking at the types of leaflet, the functional MRs are called secondary MRs due to idiopathic ischemic cardiomyopathy or other cardiomyopathies. Type 1 and type 3B are more suitable. And between the degenerative MR, where we have primary pathology of the valve, type 2 increased leaflet motion we can consider. Type 3, where you have restricted leaflet motion due to thickness, it's not suitable. So look at the big nose for 2, and rest of them in a functional and dysfunctional mitral regurgitation we can consider. So once we have a thorough examination of the valve, which is the mechanism of the leaflets, what is affecting, why the motion, why the regurgitation is happening, and we know exactly the mechanism, then we plan our procedure. Then we go on to the next stage. Here we have decided that the mitral clip can help. Next is looking at the mitral clip as per se as how is going to hold on to leaflets. What are the criteria you need to have on the leaflets before going on to mitral clip?
So mitral clip basically wants to clip onto the edges of two leaflets, making it into two orifices. So restoring the normal leaflet coaptation. That's the mechanism. This is the previous generation mitral clips where two NTR, XTRs, 15 mm, 9 mm is your one NTR's arm's length, and 12 mm is the XTR's. And depending on your leaflet length, you can be able to decide which mitral clip is going to use. Now the fourth generation G4NT, G4NTW is in the market. NTW is a new one where you have a increased width of the mitral clip so that you can have more of the valve leaflet inside, and moreover G4 system you can capture the anterior and posterior independent of each other. Previously, we were able to do it only once with only one movement. Now, the grippers which are in the for the G4, where we can individually operate them so that we can capture the anterior leaflet first, and if posterior is not happening, we can manipulate the G4 system and catch it again, and that's the latest one. So, what are considerations we have here is with all the peer-reviewed journals, what are the most successful mitral clip can be central pathology in segments A2, P2. If you have any problem in A2, P2 in the central segment, that's the best thing you can have. So central one clip will definitely get this mitral regurgitation less, and no leaflet calcification in the grasping area. Mitral valve opening area should be more than 4 centimeters square. Is important. More than 3.5 also is okay, but 4 is very ideal. Flail width less than 15 mm. The width of anterior and posterior leaflet should be more than less than 15. The flail gap noted in short axis should be less than 10 millimeters. And the posterior leaflet is very important leaflet. Anterior leaflet is very long. Posterior leaflet should be at least 9 millimeters, or ideally more than 10 millimeters to have a good mitral clip. And the coaptation is basically less than 11 millimeters. So, what are the warnings? If you have calcifications, if you have mitral valve orifice less than 4 centimeters square, if you have a leaflet perforation, those things are warnings, and you need to very cautiously guide your patient regarding success. Absolute contraindications are acute endocarditis, rheumatic mitral valve stenosis, and if you have inferior vena cava thrombosis or femoral vein thrombus, and patient who cannot tolerate anticoagulation during procedure. So what we do is we go for segment analysis of mitral valve, biplane imaging on 3-dimensional echocardiography, and assess all components of mitral valve on A1, A2, A3 and P1, P2, P3. And look at the in the 3D we have this MPR images where we go for analysis. It should be more than 4 and pressure gain less than 5. That's the criteria. And ideally, this is basically one area is going to be 2, so you should possibly have a good area. The coaptation length, basically what it means, the where it basically attaches to each other should be more than 10. And coaptation width should be less than 3, and the flail gap should not be more than 15. So if you have a severe calcification and you have a very small annulus, you can't consider a mitral clip here. So additional parameters, LA clot, we have LA appendage clot, very aneurysmal intrathecal septum, but we are using cautery-based perforation for these septums, and we're able to get away with it nowadays. And in very thick interseptum, again we use cautery now, and PFO, PFO, big AST, sometimes we cannot manipulate the system as easily like what you do with the perforations. So we just went through it. With each stage you are analyzed, and once you are through, you look for alternate options, whether a surgical angioplasty or surgical replacement can be considered. If all those things are no, then you go for a mitral clip. Just quick, a typical example, a 74-year-old gentleman with normal coronaries with symptoms. And what I mean by here is, you can see this is a 4-chamber view in the TE showing a P2 flail over A2, clear P2 A2 central regurgitation, and P2 is flail, and the flail width is not more than 3 mm. So it's just basically we can hold this valve together, and the mechanism basically a ruptured cord and flail segment. So basically it's a secondary MR, and with this it's a primary MR. So what we have got is affected region orifice is 0.4, slightly less than what we said, and regurgitation volume of 67 ml, and so this all things fits for a mitral clip.
We went for a mitral clip and we pre-procedure TE, assess it once more. Then we have perforation done at the position where we have a nice, I'll show you this. You can see that we have to have perforation here so that we have 4 centimeter length from this point, so that we have a nice, the mitral clip can be manipulated easily. If you have less than 4, the mitral clip manipulation will be difficult. Even at this point of time, if you can't get a good length, you should reconsider your mitral clip procedure for this patient. So we went on, and here the guiding system has come up, and then we went to the mitral clip. The whole procedure is done under echo guidance with a prop echocardiographer, and you see that the A2, P2, this is a long axis. So, and we make sure that we are jumping at the level of the jet. We go inside, and then we open the clip, and then we put the grasper down, and then we close the clip. And once we are sure that the clip is holding up, we got a good result. And you can see there's a very good result. And so, in summary, the patient selection is the key to success of this procedure. Detailed evaluation with echocardiography, TE is very important. McLean's MR, visibility of mitral clip is very important, so the patient can be counseled regarding outcome. And measurements are very importantly taken. The additional feasibility technique should be assessed. Always think for alternate surgery. Thank you very much.
Muthu, there are so many parameters for suitability of TR in mitral side. On the tricuspid side is another different ballgame. So what is the most important parameter? Like, is it a calcium? Is it the width? Is it the flail length? Is it the tethering? Is it the centrality of the jet? So which one do you think is the most important piece?
Sir, actually there is no one important thing.
Okay.
Because this is basically a procedure involving a complex anatomy, mitral valve. And it's not that one thing we can point
on. So if
on.
you can't give me one, give me 3.
Sir?
Give me 3.
3. So you look at the length of the post-mitral leaflet. Mitral valve annulus should be more than 4. That's the important criteria. If you don't have more than 4, even consider a mitral clip. Number 2 is, then you have a post-mitral leaflet about 9, at least 9. Because you're going to hold, the post-mitral leaflet when you're going to be very small and you're going to be held by the leaflet. So that's very important that you should have post-mitral leaflet length is 9 mm. And flail width, flail gap comes next. So those things, nowadays with this particular G4 system where you can switch it from finger from anterior posterior, you may able to get both leaflets. But importantly, mitral annulus area should be more than 4.
Yeah, I think what the technology has evolved over time, these things are actually pre-GT4. So after GT4, we have more flexibility and more unsuitable anatomy, hostile anatomy, can be done in the hands of Muthu Kumar.
Yes.
So Muthu has got experience, anybody who has got the experience, plus the company people, as Jadhav was telling me, if you're in soup, if you're in difficulty, ask the company people, because they have the much more technological know-hows than the doctor himself. But the biggest advantage of having this device on the mitral side, unlike TAVR, you have plenty of time to go anterior, posterior, medial, lateral, go up, drop the clip by 60 degree, grasp it as 120 degree. So those things, you have time, because this is not in crisis, a ventilated patient, very nicely stable patient. So that's the beauty of having knowledge. The only problem is the cost.
Cost, yes, cost the major things.
Yeah.
So basically, a lot of time is there, and you should have expertise to look at it. Echo.
Thank you. Thank you. So Chinese, Chinese mitral clip has been presented in PCR 2023. I won't tell you the Indian price, but it comes to around 3 lakhs rupees, Indian rupees. Chinese tier clip. Okay. So that's what they are promising.
So thank you.
Future is good, sir. Thank you, sir.
And this brings to the end of this session, and we'll move on to the next session. Yeah.
Thank you so much,
Big round of applause
chairpersons.
for
Thank you
all
so
the
much.
speakers and moderators and chairpersons.
Thank you all. We move on to the next session, BMW. I would like to invite the coordinator on the dais. BMV, I'm so sorry. I would like to invite the coordinators on the dais. Dr. R.D. Yadav.
Coordinator come speaker.
Welcome, sir. I would like to invite the chairpersons on the dais, Dr. Alok Majumdar, Dr. Anup Banerjee, Dr. Bhuvan Majhi, Dr. Pankaj Sharkar. Also, I would like to invite the discussants on the stage, Dr. Ram Mohan Roy, Dr. Arvind Kumar, Dr. Shupratim Kundu, Dr. S.S. Das. Thank you so much.
So the topic BMB.
I request Dr. Rishi Sethi to also there on dais. So now Dr. R.D. Yadav is going to give us the tips and tricks, and I think he has amongst the maximum number of BMVs in India he has done.
No, not
so much
that.
of complex.
But in private, yeah, I'm doing
No, you
good
must
number.
have done proctored maybe hundreds of BMVs, isn't it?
So the problem is that in any structural intervention, there is no lecture on BMB because there is no implant. So no implant means no money. No money means it is not kept in any conferences. Even India Bhal, they don't keep. And they don't have registry for my BMB because it doesn't have any implant. Anyway, so as you know the indications, this is 2021 indication by ESC guideline. So I will go to the summary of the indications later on. First, where it should not be done. If the mitral valve area is more than 1.5 centimeter, it should not be done. LA thrombus, if it is in the cavity of the LA or the septum, it is absolute contraindication. But if it is localized to the LA appendage, you can safely do the BMB. And if the MR is up to 2+, you can do the BMB. If severe bicommissural calcification, you cannot do. And absence of commissural fusion is not there, then you cannot do. Severe concomitant aortic valve disease, severe combined tricuspid valve stenosis, all this can be done. If they have TS and MS, you can do. If you have AS, aortic stenosis as well, mitral stenosis, rheumatic, we do BMB and ABVD. Concomitant coronary artery cases, we also do nowadays. So these are the classification of mitral stenosis, which I am not going to go. This is the Cormier classification, LA appendage closed, we do it, this is the BMB balloon. Now in hurdles of BMB is the first hurdle is technique of transeptal puncture. So what we do, look in AP, LAO 45 degree, RAO, because hardly we do TE guided, so all based on transthoracic echo as well as the fluoro. And RAO 45 degree, left lateral view, try to puncture in the lateral view, puncture in the middle third of the distance between the pictal catheter in non-coronary cusp and the outer border of the LA in lateral view, never puncture in the posterior third of the line between the pictal and the lateral wall of the LA, because that is the part where tamponade will occur. Check by transthoracic echo that the needle is pointing in black fossa ovalis, that is very, very important. If poking of the puncture, then the best way to avoid tamponade, if we keep the needle at the end of the dilator and just poke it and it goes, that means you are safe. If puncture is unsuccessful, then inject dye to delineate the septum and then tent it and puncture. If needle drops suddenly, then restart again from the SBC. Make sure needle should be 1 centimeter behind the tip while taking out from the above SBC. So this is all, and a special situation like pregnant lady, where you can do with the main problem is the radiation exposure. So try to do less and less fluoro, that is the special situation. And other special situation I am going to discuss. So here you see all the views, and then puncture in the lateral view, it didn't puncture, then it's but you give the contrast lined up and then puncture the septum and then do the angiogram, and you can use the echo interictal septal puncture. You can see directly that it is in the fossa ovalis, and after that you do the angio to see if any clot or anything which you missed in the TE or any not done the TE before, and then put the pictal wire, 14 French dilator. And next hurdle, second hurdle is crossing of the balloon from the LA to LV. There are 3 techniques: stellate technique, making the reverse U, and counter rotating the stellate with dowel of it. So we counter rotate and then push. If the another technique is called reverse loop technique, by rotating clockwise the balloon so that it goes on the pictal wire or jalebi wire and then goes backwards, and then you enter. I will show you that. pigtail wire in the LV by help of Mullin's sheath and putting the right coronary angiocatheter, and then thermo wire go into the LV and then put the jalebi wire there, pigtail wire there, and over the wire put the balloon and dilate it. So this is the shape, stillate shape. Sometimes you have to make like this, and then this is the reverse loop technique where you can, will it run? Yeah. So reverse loop, it's not running. I have given with videos. I don't know if videos will not be there. Not running. It is there with, is running there? Because I have given whole folder. Yeah. So another thing in entry, first inflate the balloon, pull up and down, it is free or not, whether it is in the cordy. If it is not coming back or not going freely, that means it is entrapped into the cordy, and if you will inflate, it will rupture the cordy and do mitral regurgitation. So this is very, very important. So how to prevent development of moderate to severe MR? Make sure that balloon went into LV through steno's orifice rather than through the fused cordy by inflating balloon and moving back and forth for free movement. Start 2 mm lesser than recommended by the Inouye formula with gradual dilatation by multiple attempts rather than full dilatation in a single go. Select the patient with Wilkins score less than equal to 8, and this is the mean gradient which will appear like this, and after dilatation there will be no gradient or zero gradient. Now difficult situations or complex anatomy is the giant LA where puncturing is very difficult, left atrial appendage clot or left atrial clot, calcific MS, moderate MR, severe mitral stenosis, severe submitral stenosis, dextrocardia, anomalies of the IVC and SBC, whereas IVC is blocked, kyphoscoliosis. These are the special anatomy. Now MS with giant LA. Here you see your needle will not touch the septum properly. So what we do here, you can use two things. You can use echo, and based on echo, wherever you touch the septum, you can use the PTCA hard end of the wire and then go in and then switch over to the soft end of the wire and then do the BMB. And anywhere you can puncture, you can do the BMB, either reverse loop or stillate technique. If that doesn't happen, you can use the cautery. Cautery is the simplest, easy way. You can puncture where you want. So this is the way we do the BMB in these cases. So you can use reverse loop, you can use stillate technique. Both technique can be done. Or if you fail that, you put the pigtail wire inside the LV, and over the pigtail wire put the balloon. Oh, sorry. Now PTMC in LA appendage clot you can do safely. For that, the technique is that directly go pigtail wire inside the LV, and over the wire you inflate and deflate and come out. Or you can do reverse loop technique and directly go into the LV, dilate and come out. And this type of LA clot is a absolute contraindication. Where septum has a clot, you cannot do BMB in these cases. But LA appendage clot you can do directly, see and go with the pigtail wire into the LV and dilate over that. So even in LA roof may be dangerous. I have not done this. I have taken from the Dr. B.C. Srinivas. They have done it, but I will not suggest to do BMB in LA roof clot. So I will not suggest. Then severe calcific MS. This is reported by Chennai Group and Railway Hospital, and they have found significant benefit without much MR. And this is the valvaria after dilatation. Moderate MR and PTC eligible central jet in, sometimes you see in 2 plus MR you can do it, because after doing MR even decreases because coaptation is better. Now severe submitral disease. You see here the high LA pressure despite moderate decrease means less than moderate mitral stenosis, disproportionate PAH balloon impasse sign like this. Balloon proximal part is inflating, then the distal part, that means this is a subvalvular deformity. It is catched in that. You don't dilate here, otherwise you will do severe MR. And difficulty in balloon reaching LV apex, and it is not free. Frequent slipping of the balloon during initial dilatations. But if you have proper way, you can do it. This is, you see, caudal orifice is narrow than the commissural orifice. Then you have to dilate at the commissure. And then you can split with that. You put the balloon over the wire system and then dilate first and then put the balloon and then dilate. And then valve area can be reached over the wire, snare and over the wire you can do it. Then another group is the Luton-Becker syndrome. This is very important. Here, although there is ASD, the balloon will flick out. And pressure gradient will not give you the right idea where the valve will open or not. So here, put the pigtail wire inside the LV and then over the wire do the BMP. That is the technique in Luton-Becker's. And then close the ASD with the device. We have done just 1-2 more minutes. In subvalvular deformity, I have told you first dilate distally. And in dextrocardia, you just try to do the BMB not from the right side but from the left femoral vein puncture and look backward. Just orient your image as you see in the RAO and LAO and lateral and invert, or you can invert the image. And if you have confusion, you can do the pulmonary artery angio and see the levophage of the LA and you puncture the septum based on that, as well as take the help of echo. And this you can do the angio and see the, and then puncture the septal puncture, and then you can do the BMB safely without any problem. Then patient having both aortic stenosis and the mitral stenosis and having dextrocardia, both can be done in the same procedure by snaring the wire across the aortic valve, and both can be dilated. BMB can be done as well as the aortic valve dilatation. In interrupted IVC, you can use the azygous route, and here jugular vein puncture is done by Edris needle, or you can use pediatric broken bro needle, or you can use the same needle, but you have to be more backward. And there was a special sheath, curved sheath, 16 French is available. You can use that sheath based on, and on that sheath you pass the jalebi wire after puncturing into the LV, and through that you pass the BMB balloon and dilate it across it. So as I told you, you can use adult broken burrow needle also, but pediatric broken burrow needle is easy to handle because you are doing from neck, or you can use Edris needle, which is 30 centimeter. Jugular approach. So this is the problem when there is a no SVC. So you have to come from SVC to puncture. You know, this habit is already made, but many times either SVC is occluded or there is no SVC. LSVC is going to the coronary sinus, and your needle is every time going to the coronary sinus. In that case, you have to puncture higher to get the LS to get into the LA by the septum, and you just give dye and then puncture into it higher, and then you also look for the echo because your CS is usually dilated. You may confuse and go into the CS and puncture the CS. So please avoid that. And BMB can be done by over the wire system. Put the jalebi wire into the LV and you can do the BMB. Complication of BMB, as I told you, death can occur 0.2 to 3%, acute mitral insufficiency, cardiac tamponade, embolism, maybe cerebral or systemic embolism, atrial septal defect if you have taken out the inflated balloon. Small ASD can close spontaneously. Device-related complication can occur like broken wires. We have wire, jalebi wire, broken inside the LA. So we took out by the snare and then punctured and did the BMB. And failure to deflate the balloon, when it happens, we put this your hard end of the PTC wire end and perforate it, or you perforate it and then take out the balloon. So all these are, kyphoscoliosis and dextroverted heart is very difficult here. And here you have to look both echo as well as or if you have doubt, you do the pulmonary angio, and then do the transeptal puncture, and then do the BMB. So this is the way it has been done in this case. I think if tamponade occurs, don't be hesitate, just put the 14 French dilator inside, seal the septum with the 14 French dilator, or put the pictal inside the pericardium, take out the blood. And two things must keep in your hand. One is ADO2 device, any size, 6x6 or 6x4, any size you keep in your lab, along with the 4 to 6 ampoule of histactyl, nectactyl, anything, N-butyl cyanoacrylate, that is glue. And then auto-transfuse it, and you do the BMB. With this, if your wire is, pictal wire is in the LA, you do the BMB, and then sometime LA pressure decrease, tamponade will resolve, and then coming with that, if pictal wire is already there, you deploy the ADO2, it will seal the perforation. And from the pericardium, after auto-transfusion, you put the N-butyl cyanoacrylate and seal the pericardium. So surgery will be avoided or not needed in most of the patient if it can be done like that. So this is called stitch effect, where you can put the your ADO2 device across, and you can this is called stitch effect, and the ADO2 device can close it without any problem. Acute MR, if acute MR has occurred, you can dilate the septum so that the LA pressure is decreased, so the pulmonary edema will be decreased, and you can send the patient to the surgery as quickly as possible. It should be, if severe MR has occurred, surgery should be done within 24 hours. Ideally, if you have delayed, the mortality rate is higher. I think that's all I have to say. Thank you.
Dr. Yadav, if you could tell the audience the importance of taking two views before doing the septal puncture. Because with one view, one can, have all these complications. And then how do you bend the angle of the puncture needle as well as the stillet in very large LAs?
Yeah, in very large LA, you bend your needle more. And you have to see the angle. Usually you go 4 to 6. 4 to 6 your indicator. But you can go even 8, 9. But you have to see in the echo. Without echo, you cannot puncture. And even if it is not puncturing, because you cannot, if you will push, it will drag over the septum. So what you do, you keep the needle there, put the hard end of the PTC wire, perforate it, and then do. Or you just touch the cautery.
Thank you, Dr. Yadav.
Thank you.
Yeah, I would continue that rather than two views, for classical teaching in our hospitals, we'll say that we have to use 4 views, RAO, LAO, AP, and lateral, to confirm the position. And then, depending upon center's choices and the way we have been trained, most of the people would like to puncture in the LAO view because it orients the septum and exposes the needle with the least foreshortening. But of course, lateral punctures are also, lateral way of puncturing is also. Yeah. Yeah, so that is many a times dependent upon how we have been trained. Yeah.
Because in lateral it will look posteriorly.
Yeah.
When you will see in RAO, it is looking backward.
Right. Yeah, so what we do is confirm in all the 4 views, but we teach to puncture in the LAO view because it is the least foreshortening of the needle, so the needle is absolutely, angulated that way. So it depends upon how we have been trained. And
wonderful cases. I think it looked like Surya Kumar Yadav batting. We were puncturing septum from all the angles. So we had a published case in JAC about the largest known LA in BMV. So we did a BMV in around 92 into 94 mm size LA, and we published it. We could not find the mitral valve with the balloon. So we took a SL seat there. So like we do electrophysiology. So we had this, we know about the SL seat and its maneuver in LA. We took the SL seat, we utilized that curve. We took a multi-purpose catheter, diagnostic catheter, and a thermo wire. through exchange lane thermowire, we went inside the LV to aorta, exchanged the multipurpose catheter and everything out. Then we took the, the BMV sets and then we could do that.
Another point about the reverse looping in the very giant size LA, I'm sure Dr. Yadav would agree that the difficulty here is that even if you enter the LV, the balloon is facing up, balloon is facing up. So that's a very important trick to, that's a very important trick to.
What you do, you have taken the reverse loop, pass the turbo into from the LA to LV through the valve, J turbo you take, so that it goes through the valve, not through the cordy, and then put the balloon, and once inflate the balloon, then pull the balloon.
Correct.
Then it will become straight.
Correct, that's it. So you have to unlock the 8 curve once the balloon is, and then you go to the LV. So
let's
that's one point that I thought. Thank you. Thank you so much.
Let's see some cases from our SSKM hospital. Dr. Saroj Mandal is, unable to come here, and then his teammate will present the cases.
Myself, Ignesh Rajendra, I will be presenting for Dr. Saroj Mandal, sir. First case, this was 1A LA thrombus was there. So we were planning for over the wire technique. So the initial step of the thermowire, and this is the initial step. The puncture, it is punctured. IA is punctured. Then through the puncture wire, we have put the LA wire directly into the LV. Through the LA wire, the IS is stretched, and without pulling out the LA wire from the LV, the balloon is crossed and it's dilated. Next case, we will see about difficulty in crossing mitral and how to.
Can I stop you for a minute? How did you take that Jalebi wire into the LV?
Sir, once the Mullen sheath is entered, the cine is not available. Either we can put thermowire directly into the LV. Here we tried with the LV with the LA wire, but it entered with the LA wire only.
Right. Generally, you'll have to exchange it. Generally, you'll have to exchange it.
Most places, people don't use the Mullen sheath. It is only the Mullen's dilator which is used.
It's true. That's true.
For the transeptal function.
That's true.
But what you are saying is, practically I'm telling you, most of us use only the dilator.
Or multi-purpose is longer than the wire, pictal wire. Then you have to cut the wire and then take out the, after putting the jelly wire, take out the catheter.
Next case, this case it was very difficult to cross the mitral wall. These are the initial steps. So that the three Mullen's dilator along with the stillet, along with the puncture needle is brought down. It is conformed in 3 positions. And then it's punctured. Here we used the probing technique. We did not puncture. We just probe. In used LA, we can use this technique. We can see that the only the Mullen's dilator enters without the needle, with the needle inside it. And the LA wire is introduced and dilated. Yeah, with this position, it was very difficult to enter the Mullen. It was difficult to enter the mitral valve. After multiple attempts, we decided to change the shape of the LV wire. So for different shapes for different types of puncture. So we did the shape, and we were able to see that it enters after shaping the LV stillet. It enters and then we dilate it. Next thing, it is a patient with a very huge LA. where the broken burrow needle gotten broken. As Yadav sir already told, it slipped and it got broken. I will skip the initial steps. It was a very hugely dilated LA and it was severely calcified. Here we will be able to see this gets slipped and it gets broken up. Yes, I will play it again. Yes, it got broken.
Recently, some company has made a broken burrow which breaks. I don't know. I have never seen the this needle, broken burrow needle breaks, but some new company has made in such a way that it breaks. I have seen broken needle.
No, we haven't seen it.
Yes. So, but nowadays different companies are making, and I think it's the company problem. Because no, even 1,000 you can use, no problem.
Go ahead.
So in the left cine we are able to see.
With one of the company. That's why I am not telling you the company name, but I have seen.
Here we are able to see only the broken part of the broken burrow needle. So we are taking this out. Here we are able to see the broken part is inside. We are taking the whole dilator out along with the broken part. So in the right image we are able to see the broken part. So actually in the above image shows the position of the normal septum. So actually in a dilated LA the septum becomes very vertical and the fossa valis comes inferiorly. So here we have to use, usually we puncture in 4 to 5 o'clock position. Here we should puncture in 6, 7 and 8 o'clock position. So we plan to puncture in such a way. I'll skip the initial steps. It's punctured at 6 o'clock position. And it's a very huge LA. We are able to see how big the LA wire is. It's a very severely calcified valve. We are able to see the calcification here. And it was very difficult to negotiate across the mitral valve also. It was very difficult. After multiple attempts, we are able to enter the mitral valve.
Looks a higher puncture.
Yes, sir, high puncture.
In higher puncture, you have to take a loop and then you go. Yes. With the stilate curve, make the curve slightly upward. Sometimes the mitral stenosis is so severe, even this balloon profile doesn't able to cross. In that case, we put jalebi wire inside the LV and then put the peripheral 12 millimeter balloon, dilate with the 12 millimeter balloon and then put this balloon and then dilate. Did you play the last shot?
Then next case is tamponade during BMV. I'll skip the initial steps. After puncture, the LA wire was introduced, and unfortunately the tamponade occurred at the same time that we lost the access to the LA. The balloon came out of the LA and it is in RA. Sorry. The balloon came out and at the same time we lost access. Then here in the left side we put a pigtail and we started draining. At the same time we repunctured again. The assistant was draining and sir had to puncture again. And with the pigtail in situ and the draining goes on and BMV is done again. The patient stabilized. The message is to continue BMV during pericardiocentesis so that the hemodynamics improve. Take home message, LA thrombus over the wire technique can be used. If balloon cannot be crossed across the mitral wall, you can change the stillet before re-attempting a puncture. Tamponade, continue PTMC while pedicardiocentesis. Thank you.
I think with the mushrooming of mobile cath labs all over the countryside, two basic prerequisites is to keep a pericardiocentesis set and protamine, because for all these tamponas you need reversal of heparin.
We don't give protamine, sir.
Half
Because
reversal
the problem is that once you give protamine, the blood inside the pericardium gets clotted, and then you cannot take out, cannot aspirate. Then only need will be surgery. That's why we don't revert the
half revert.
Not even. So we carry two things: ADO2 and nectacryl or histacryl. That is the N-butyl cyanoacrylate. You just take out the blood and auto-transfuse. After taking out, give 25% dextrose, 10 ml, and immediately inject the your glue around 4 to 6 ample together, and then take out the pigtail and keep seat, and then put another pigtail so that it take out that, but that blood you cannot re-inject.
And at times we've used coronary wires to cross these very stenotic mitral valves.
Yeah, Amit, you have
when
a comment?
the usual wires don't go in. Thank you.
I would suggest proper pre-operative as well as par-operative assessment. Before doing BFB, we have to identify the difficult cases, so we have to anticipate the difficulties beforehand, before going for BMB, because in cases of large LA where there is commissural calcium or more than mild degrees of MR, in these cases we have to be extra cautious, and often in difficult cases we have to use par-operative guidance also through the imaging.
Yeah, Amit, you have a comment. Yeah. Amit has a comment.
Great. Retrograde BMB, when I was BM student in AIMS, that time my teacher, Dr. BK Bahal sir introduced where we cannot puncture the transeptal, or there is very thick, cannot able to puncture. Then what we used to do, we have a LA catheter. There is a special catheter. We have a LA catheter. We go retrogradely in RAO view. LA catheter, we bend it, and so the thermo goes into the LA from the LV, and through that we pass the Cook extra-resistive wire. Over that we put the cylindrical balloon, and that we dilate. That is the retrograde. No, nobody does it. Same thing, LA, you can use LA catheter or you can use that one. Dissect balloon is, no, it's a very weak balloon. It doesn't have strength. So you can use Maxi LD or any of the peripheral balloon. Mammoth.
No, if there is a wire, only then he can do. If there is a wire, only then he can do.
You have punctured. You are in the LA by confirmed by your contrast as well as your jalebi wire into the LA, and then your temporal has occurred because it's stitch effect. Because you have gone through outside and then entered into LA. Because this is the RA and this is the LA. So you have gone from outside like this.
Wire is not to be removed.
So jalebi wire don't remove, and on that wire put the guiding catheter and put the ADO2 device. So it is double perforation of the Yes.
Thank you, Jignesh. I think it was wonderful revisiting BMV cases, and it was. Yes,
Dr.
sir,
Trian had described this, and the point is that in a stitching phenomena, when you inject pericardial glue, it kind of gravitates to the point of the stitching puncture. That is the concept, so that it does not really, we all think that there will be a stuck pericardium, but it will gravitate to the point of the stitching puncture, and very rightly is brought out that you have to relieve the LA pressure, and you do that by completing the BMP.
Thank you. I think we'll move on to the next session.
Thank you so much, doctors. Thank you.
Dr. Sethi has to stay back. I think he's in next session as well.
Next session, tricuspid valve interventions. I would like to invite the coordinator, Dr. Rishi Sethi. Sir. Chairperson of this particular session, Dr. Amal Khan, Dr. Tanmay Banerjee, Dr. Shomo Patro, Dr. Oviral Roy. Inviting all of you to please come on the dais. Thank you so much. The discussants of this particular session, I would like to invite on stage Dr. Hema Rath, Dr. Madhumanti Paja, Dr. Rajat Kaur, Dr. Shomokanti Datta. Inviting all the doctors to please come on the dais.
To be there. Please. Yeah, may I also invite Dr. Anantraman to be the chairperson.
Yeah. So, thanks, Dilip. It was a great way to spend a Sunday with learning lots of tips and tricks on exotic structural interventions. And am I getting the slides? Shall I play from here? All right. That's Anmol's presentation. That's not mine. Ye nahi hai. All right, so whether it is the forgotten valve or the rediscovered valve, we really don't know, because we are discovering a whole lot of issues. Yeah, I think that is okay, because we are discovering that we have bad hearts, we have functional mitral regurgitation, we have functional tricuspid regurgitation. And functional tricuspid regurgitation itself contributes not only to morbidity, but also maybe to the progression of disease. We all understand that with guideline-directed medical treatment and with great new drugs on the horizon for treating heart failure, we are better, but we must appreciate the fact that a patient who is sick, and some of them are post-surgical patients, who have severe TR, live a miserable life with ascites, pedal edema, and even effort intolerance and dyspnea for that matter. Some of them have very high pulmonary arterial pressures, but most of the tricuspid regurgitation that we're going to talk about today is not really because of the tricuspid valve itself. Even when, say, we used to send patients 20 years ago for a dual valve replacement, very often the surgeon would forget to treat the tricuspid valve. Many of those tricuspid disease have progressed. Even if that did not happen because of left heart disease, because of right heart disease, because of pulmonary hypertension, we get a lot of tricuspid regurgitation, and tricuspid regurgitation itself is associated with increased mortality independent of pulmonary pressures and right heart failure. So if we look at all this, because there are many of these patients are in atrial fibrillation, many of these patients have concomitantly poor LVs, and tricuspid regurgitation may not any longer be an innocent bystander. Whenever we have to make a decision, we have to look at the severity of the tricuspid regurgitation, and there have been changing nomenclatures about the severity. We have to look at the most nebulous thing in doing an echo evaluation or the clinical evaluation of a patient, which is to assess the RV function. We also have to assess the pulmonary arterial and venous hypertension. And we must understand that though TR is common, majority of TR is functional, and it is associated with poor prognosis. We think that if we treat the heart failure, and if we treat the pulmonary arterial hypertension, and this is what we were taught 25 years ago, the functional TR would go away. Very rarely. It does not go away. In fact, it progresses. And if you cluster this, and I think the Mayo Clinic did this work after the surgical team tried to evaluate a score called the TRIO score, this Vidhu Anand,
worked with creating some phenomapping. And she created actually 5 phenotypes of tricuspid regurgitation, a low-risk cluster with few comorbidities and lesser severity. So it is not really the TR which is important, just like we have a CHADS or a CHADS-VASC, whereas the systemic problems in atrial fibrillation become important. It is the high-risk cluster, more severe TR, more comorbidities, larger RV size, more congestive heart failure, including that with ischemic cardiomyopathy, lung disease, atrial fibrillation, and kidney disease. So these become very important. We can have multitude of scores. We can look at age, previous MIs, peripheral vascular disease, systemic implications, whether it is with CKD, thrombocytopenia, whether it is with low albumin, with use of excessive diuretics. Looking at all this, we can try and analyze which is be a perfect score. Prakash mentioned this briefly, that anatomically, there are differences between the tricuspid and the mitral valve. The anatomically, tricuspid valve has denser chordae, which are with a higher variability of chordae density, quantity, and location, some of them can be very, very fragile. There are thin and variable leaflets, usually 3, but may be variable with deep clefts and folds, unlike the mitral, which is kind of more standard. And it has the largest annulus, because most of this functional TR is because of the RV dilatation and the annular dilatation, which you can see progresses largely in a posterior direction. Now, this is where the annulus takes over, and therefore this functional TR would impact the coaptation, would impact the tricuspid valve, and as the RV failure progresses, this RV will remodel with what will be either a ventricular functional TR, or as with atrial fibrillation, there will be an atrial functional TR, which is, now there are different criteria. Atrial functional TR has atrial fibrillation, PA pressure more than 50, with normal looking tricuspid valves, and you can also see, these can be clustered with a tricuspid valve tenting height less than 10, a mid-ventricular RV diameter of less than 38, and a normal ejection fraction per se. But we need to separate this functional TR as to an atrial secondary TR or a ventricular secondary TR. Now we understand that atrial secondary TR is usually largely females with normal ejection fraction, whereas ventricular secondary is males with reduced ejection fraction, with higher LA size, with the tenting parameters are more in ventricular, the annular size is more in atrial, the RA size is more in atrial, etc., etc. So these are the challenges. We don't know the position size of the regurgitant jet. We don't know the number of leaflets. There could be presence of pacemaker leads. There's a variable shape and size of the normal D-shaped tricuspid annulus. It is not round, it is D. There's a variable and complex leaflet anatomy. There's a difficulty in capturing tethered leaflets. There's a proximity of the right coronary artery and proximity of the AV node. So even evaluating this is a challenge. So it is just not just translate into 2 things which our residents do, which is to say severe TR, moderate TR, and to calculate the RVSP by the Bernoulli theorem, and to probably add a TAPSE. But if we have to quantify, we have to see not just the regurgitation, but the annular dilatation, the leaflet tethering, the RV function, remodeling the LV function, and the RV-PA coupling. So, because we need to understand the mechanism, we need to understand the size of the annulus, the coaptation, length and motion of the leaflets, coaptation gap, and the proximity of the right coronary artery, because the TR population is heterogeneous, and even with a period of time, it can progress by continued remodeling and progressive RV dysfunction. So what about the etiology? Well, largely we are dealing with what is functional, like I said, atrial functional or ventricular functional, but it could also be related to pacemaker leads or ICD leads or CRT leads, whatever. And it could be rarely be organic or primary. There's a brilliant review in NEJM last week, I think, which by Becky Han, which we can go through, which actually talks about the differences with different etiologies. as far as the grading of TR is concerned, we used to do mild, moderate, severe, till it was realized that severe itself was an incomplete definition. And because everybody who had severe TR may not be eligible for treatments or may not be considered, so it was expanded to include massive and torrential tricuspid regurgitation. We also know that quantifying RV function is a very, very big challenge, and we don't have perfect tools to do it. Whether we do it by the FSC of global systolic function, whether we do it by RV tissue Doppler. In most of the echo machines, you would not be able to evaluate RV strain, whether you do it by longitudinal systolic function, which is a TAPSE, or by using GLS. And the RVPA coupling would obviously require us to also do a right heart catheterization to understand it. Now, if surgery is done at the time of other surgeries, it was the gold standard, it is simple, it has pretty good results. But unfortunately, as an isolated problem, it is delayed because nobody really estimates. This is another score, like I had mentioned, the trio, there's a tri-score, because the referrals are very late, the guidelines do not support it, there's a lack of early symptoms, and there's a lack of evidence for cutoff markers of early RV dysfunction, and an inability to assess futility. And this late referral perpetuates a vicious cycle. Now, what about transcatheter considerations? Because it's the largest of the valves, it lies caudal, very easily accessible, does not require arterial access or a transseptal puncture, but it is complex. Multiple chordae, tendineae, papillary muscles, risk of entrapment, hindering devices, annulus is D-shaped, which is dynamic, very dependent on loading conditions and intravascular volume. There is a close anatomical relationship between the annulus and the AV node and his bundle, and therefore there's also a relationship between the AV node and the RCA. So we have some transcatheter solutions, annuloplasty. We have recent data from not just the MitraClip being used, but also the triluminate data which has just been released with the TriClip. And we have other solutions like the Pascal and some heterotopic solutions, which are the only thing which is available to us. The holy grail may actually be the orthotopic tricuspid valves, and these are various devices. How do we choose them? Well, for edge-to-edge repair, smaller gaps with adequate length and mobility, annuloplasty in whom the distance from the right coronary artery is more than 6 millimeters, and in some end-stage disease where you just want to make symptomatic relief, maybe you can provide a heterotopic solution. So these are the landscapes. I will not go into all the trial data and all the various choices, because I think that was another talk which Harish was supposed to give, but he's gone. But I'll just share with you a heterotopic valve which is available in the country, which is the trick valve. And this requires certain anatomical measurements. We need to assess suitability, which means that in the SVC, we need to know the distance from the nominate, and in the IVC from the hepatic vein. And once we've established this, we know very clearly that we can actually put this covered stent, which will prevent the transmission of backward pressure in the right atrium to the SVC or the RVC, thus taking away some of the systemic dysfunctions. We know the various measurements that we can, and the various choices which we have. So there's just a case which was evaluated with severe TR, with all the CT measurements being done, and the adequate distance, more than 34 millimeters from the RA junction to the innominate junction, and at least 14 millimeters of the SVC, and this is the SVC valve which has been placed, and this is the IVC valve where at least a 5 millimeter distance from the origin of the hepatic vein. But we have to assess futility, because sometimes these patients have advanced liver disease, cirrhosis, hypoalbuminemia, coagulation abnormalities, which may render the patient completely futile, and we must be able to recognize when not to exhibit treatment to these patients. You may say that a trick valve can still do the trick, but remember to phenotype it with considering the RV function, left-sided disease, etiology, looking at CIED, and looking at pulmonary hypertension, And once we look at all these RV functions and maybe some functional assessment, we can keep in mind some broad things. If a V wave in SVC, IVC is more than 15, systolic pressure is less than 65, TAP-C, maybe 15, maybe up to 12, and an ejection fraction more than 30, we should consider them for various choices. The choices of physiology and the timing of disease. So, although we have new tools which are available, and they are reasonably effective, but we need to optimize them, use diuresis judiciously initially to prevent all this from happening, and then time the intervention. Thank you very much.
Thank you, sir. So, I mean, the real trick is that now many of us and most of us have little experience with tricuspid valves, and we are just beginning to understand, although theoretically and practically it seems to be a much simpler valve to deal, considering we have a lot of time and it's predominantly on the venous side. I think the key is to decide, since we have the leaflet fixation devices, we have annuloplasty, we have valve replacement from the tricuspid valve size, and the orthotropic valve, cable valves like the trick valves. The trick probably is to decide which clinical condition, which particular percutaneous technique should be used. So can you delve, I mean, a little bit you have touched upon it, secondary MR or prime, which...
See, most of the time we are going to be dealing with functional TR. Most of the time we are going to be dealing with functional TR. And we understand that, and these patients are going to be sick because they have torrential or massive TR, which is causing them hepatic dysfunction, ascites, etc., etc. So these are, and florid right heart failure. So these are patients who, if they are anatomically suitable, can be, and if there are no other options available in terms of either surgery, because surgery is usually at a prohibitive risk, and the other transcatheter devices, fortunately, I know Praveen has done a few cases using MitraClip, but fortunately, unfortunately, the TriClip is not available. We don't have any of the annuloplasty cardio bands, etc., available in the country. We don't have the Evoke as yet, and I think Evoke can be a good solution. Only thing is that the thrombogenic risk of an Evoke is going to be high. So in these patients, to improve the quality of life of, as long as it's anatomically suitable, is what we have offered trick valves to, and I think the trick valve numbers have gone up. Yes, sir.
Yeah. One thing that is so many trial who is available just 7 days before, trial who is presented 7 days before in the Europecia, there is definitely quality of life. Functional improvement right side of the heart, there is no doubt at all. Diameter of the right atrium RRP also improved, and the liver congestion and liver functions improve, and GI tract disturbances, bile disorder also improved. So as a whole, quality of life improved. But it is only thing 1 year follow-up. So let us see after a couple of 5 years follow-up.
Yeah, because if the annular dilatation is progressive, then, you know, like we used to say, MR begets MR, TR also begets TR. So if you break that cycle, maybe this will not worsen and the annular dilatation will not happen. That is the hope. I'm sure that our patients with trick valve have been very, very glad that they underwent the treatment, because their symptomatic benefit has been remarkable. But they are usually, we are still catching them in a very late stage of their disease. Right. And that is, I think, the problem. Yeah. The problem lies not with them, the problem lies with us, because we don't select them early enough.
So that's another point that I wanted to raise, and from my own understanding and for all of us, maybe any expert in the hall or on the podium can answer that question. I think trick valve is, probably it comes at the very later stages of the. So what should be the right timing? Probably it's much more, it's available to us, so we use it more frequently. But do you think we should be catching TR much more earlier?
I think Dr. Anmol is going to present trick valve, and then I think we can discuss this question after that.
Yeah, sure.
Yeah.
Sure. I invite Dr. Anmol to mention about the new sort of managements in tricuspid regurgitation. While he's setting up his slides, I'll just make it a little bit of a classification and a little bit of clear in terms of how we deal with these tricuspid regurgitations. The majority of the time, the tricuspid regurg, it's in the previously operated patients. A mitral patient operated, Either they had a ring repair or a suture repair or a valve replacement. So if you had a patient who already had some kind of procedure done in the tricuspid valve, it makes it easier for a transcatheter procedure. So if you had a valve replaced, we can easily put a valve in valve. That is 100% curable, and we have done, and it's fantastic procedure. The only disadvantage with the ring in a tricuspid is intentionally surgeons will put an incomplete ring because you have to avoid the heavy node. So you don't want heart block. So majority of the rings in the tricuspid procedure placement is an incomplete ring. The incomplete ring, if it's semi-rigid, you can still put a valve in ring, on the understanding that you might cause heart block, which can be acceptable. So that is treatable. Then coming to the other aspects of the leaflet problems, if there is a leaflet problem, at the moment, none of the devices is available in India, full stop. Even the mitral clips, they will not give as an off-label indication to put it in the tricuspid position. The TriClip is the only sort of CE-marked approved device, which will be available. At the moment, it's not available. The Pascal device from the Edwards will be available within the next 6 months' time. When it comes, you can put it both in mitral and tricuspid position. The results are exceptionally good for the Pascal. So the only available device for us in India at the moment, the CE approved, is the TriCvalve, heterotropic. So it's outside the tricuspid, it's heterotropic. It does serve the purpose in the patients with end-stage tricuspid regurgitation, where you are really having liver congestion and right heart failure, where your PA pressures are less than 60, where your right ventricle is still functioning, the TAPC is more than 13, 14, those cases do exceptionally well. So in terms of the solutions, these are the solutions we have at the moment for the tricuspid, and I think Anmol will touch on some of this and we'll have some more discussion.
I think Anant, you have really nicely summarized all the options in a very peculiar manner. I think the most important for TriCvalve, I think we should remember it is for a primary TR or a low pressure TR. If it is not at all recommended for a high pressure TR, because these patients will not do well. The cutoff for PA pressures for this patient is 65, as Anant has rightly mentioned. So I'll just take you with a case example. Severe TR, basically it is a complex condition of RV and tricuspid valve apparatus, frequently associated with symptomatic heart failure, high morbidity and mortality. Medical therapy is restricted to only diuretics. Heart failure treatment is frequently ineffective. Surgical repair has high risk of morbidity and mortality if it is an isolated tricuspid disease. And multiple innovative interventional treatments to replace or repair function are under investigation, but most of them are really not available in India so far. I'll just share one case for the better understanding and how to use this valve step by step. This patient is a very interesting patient, 70 female, chronic bronchial asthma, non-hypertensive. She is a rheumatic heart disease. CMV was done in 1978, followed by she underwent a mitral valve replacement in 1998. She had a CVA in 2009 with no intracranial hemorrhage and no carotid disease. She had atrial flutter with atrial tachycardia with 2:1 AV block. February 2019, she had a bradyarrhythmia, junctional rhythm. The heart rate was 55, LA size was 6.7, ejection fraction was 35%, moderate TR, and pulmonary artery pressure were 45. So again a low pressure TR. IVC was 21, non-collapsing. She had one more episode, 2-3 episodes of VT and VF and cardiac arrest, for which she has been revived. Her angio was done, which was normal, and we planned and CRT-D in view of his VT, VF and all devices. So the CRT was planned in February 2019. And she did pretty well for 1 year. And exactly after an year, she had RV dysfunction, EF 35%, prosthetic valve thrombosis, which has been treated with intravenous thrombolytic agent STK infusion. She again did well for an year. Again in Jan and March 21, again 1 year later, she admitted with urosepsis, septic shock, AKI, total counts were 18,000. Gross ascites, RV dysfunction, severe TR. She had a spontaneous VT episode which has been tackled by the device. Her LFTs were grossly deranged, SGOT PT were in 4,000 and PT was in 1,600. Creatinine was raised and again the angio was done, which was normal. This was an echo of this patient. This is a short axis, this is long axis, this is short axis. The mitral valve was functioning well. There was a severe TR and the PA pressures were 38. Right ventricular function, the TAPC was 13. IVC was grossly dilated, non-collapsing. This was in chest X-ray 1 week prior. She was grossly in failure, grossly edematous, treated with diuretic. 1 day prior, she looked little improved. Then we planned in view of renal function, not improving hepatic function. We thought, I think we should offer this patient caval valves. So transcatheter caval valve implantation, which is called as CAVI, which is aimed at to resolution of caval backflow that occurs in the late stage of severe TR. It is compassionate treatment in highly symptomatic patient with multiple advanced comorbidities and usually has less procedure-related mortalities. So the trick valve, basically it is a system of 2 self-expandable biological valves for the treatment of hemodynamically relevant TR and caval reflux. It is specially intended to use in patients who are extreme risk and are inoperable for open heart surgery. The cardiac CT is important for various measurements for deciding your valve at the SVC and IVC junction. They take a measurement superior to pulmonary artery, at the pulmonary artery and inferior to pulmonary artery for the SVC valve. And for IVC, it is at the hepatic vein, above the hepatic vein and below the hepatic vein. This is a sizing chart. The most suitable valve here was 25 millimeter in our case. I'll take you through the steps. The most important thing is you have to put your multipurpose catheter in the right pulmonary artery as a landmark, so that you can put your SVC bulb, the lower end of the bulb, at the, your multipurpose catheter, so that you can precisely deploy your valve without any problems. This is just an hepatic vein angio, because you have to have this because the skirt should not come in front of the hepatic vein and it should not obstruct the hepatic vein. Otherwise, it will cause another catastrophe. So the valve was taken. It is a venous side puncture. On a stiff wire, you can track this valve very easily, straight. You can see it is a bulge, and the lower end of the bulge, you have to keep it at the MPA level. That is the simplest marker. You can keep it and then deploy. As I mentioned, you can see, I don't know whether you can see, there is a marker here. You can see this MPA, you just keep this bulge at the MPA catheter and then release the valve. It is a very simple device. You don't require any pacing, you don't require any maneuvering. Just go there, keep it, precisely position it, and then open. It is a very controlled device. So you really don't have to worry about, and you really don't have to hurry upon. Then after confirmation, you can deploy and release. It doesn't move, it doesn't get dislodged. It is a very controlled device. Look at this, very slow and controlled release. After the valve is released, the assembly can be just pulled out over a wire without any problem. As soon as you release, the valve starts functioning. Then the IVC, the most important thing is keep one multipurpose catheter in hepatic vein as a landmark. The radiopaque marker, what we can see here, the skirt is still here, so you just have to see hepatic vein should not, the skirt should not come bang opposite the hepatic vein. Then you can start releasing. Just maintain the position at the hepatic vein and start releasing. As I said, it is a very controlled device. You really don't need to do any maneuvering. It is a low pressure system. Then confirm, as you are 80% deployed, then you can confirm the skirt, take and shoot. Before releasing the valve, just see the hepatic vein has not been occluded. It is flowing well and there is a good pattern flow from hepatic vein to the IVC. Once you are sure about it, just release the valve. Then just check a confirm angiogram from the hepatic vein, then just pull out the hepatic vein catheter, and that's it. It is one of the very simplest device to use, very controlled way, and is the final 2 valves, one in SVC, one in IVC, one CRT, and one metallic valve at the mitral position. As Dr. Bhal said, it is a really rewarding therapy. The patient starts reversing and shows clinical improvement from day one. There was a significant resolution in heart failure. LFT started reverted back to normal from the second day. Ascites started recovering back. Edema started recovering back. Renal function showed significant improvement and recovered back to normal. Nutritional build-up with correction of hypoproteinemia is important. Patient got discharged on day 10 with oral anticoagulation. Mark my word, this patient required an oral anticoagulation for lifelong. And the patient is doing well for last 2 years. This is an X-ray 2 weeks later, completely controlled heart failure. RV function, the TR has subsided, the PA pressure is 32. This is the IVC valve. Look at the hepatic flow, we can confirm on echo as well. RV function, the TAPC, which was 13 before the procedure, has improved to 19. So there is a significant improvement in the RV function. So I think this is very simple to use. Important thing, this is the only thing what we can offer to our patient as of today. But important thing is, it is always to be offered to the patient who are low pressure TR. You cannot offer this patient this therapy for a high pressure TR, for a secondary more than 65 or 70 PA pressure. So this is the one thing you should always remember. Thank you so much for your patient hearing.
Thank you, sir. So, any questions, comments?
No, that's an exceptional good summary of the therapy, what is available, and I think you have highlighted the importance in terms of screening. Echo is the first screening test. You do the echo, you get the assessment, severe TR, you do the right out TAPC, and as long as the RV is more than 13, it doesn't need to be normal, then these are fine. Next step is you do a CT scan, because during screening CT, we lose at least 30% of the patients, because especially the SVC side, the SVC nominate is not suitable. But in the studies as well as experience that you can do IVC valve alone in those cases which are not suitable for SVC. Ideally, you should do both, but where you have done a screening CT, they are not suitable for the SVC, at least the IVC alone is more than enough for these patients. But this is definitely a much better solution rather than just a diuretic for the rest of the life. Patients feel better, they eat well, they gain weight, because these are the main things for a right heart failure patient. They are not able to eat, they keep losing weight, they are completely pathetic, and all those things do improve.
So we understand that it is a palliative procedure for most of the time, quite hopeless situation for the patients. But do we have any data of how long, what is the maximum experience that we have in terms of duration of these, functioning of these valves? Do we have?
I think if I'm right, I think the maximum durability, what I have heard in some reports, it is 7 to 8 years, if I'm not wrong, so far. I think Relisys people might be the...
Yeah. You want to comment on that?
Yeah. Internationally, the longest follow-up is for 9 years, sir. We lost the patient to follow-up during COVID. 2011, the valve was deployed. 2020, we were able to try follow-up. Within India, the longest follow-up has been little more than 5 years. So the median survival of these patients in India is 4.8 years so far.
The longest follow-up in India is more than 4 years. That's a case myself and Gopal Murugan did. That's the first pediatric valve in India.
Yeah, I mean, that's
more than
great.
4.5
that's
years.
Great looking at the overall clinical picture. Yeah.
My patient is doing good for 3 years.
When Dr. Case presented the data in Chennai, as you said, more than 7.5 to almost 9 years follow-up is there. But I think it's more than the longevity of this, is the quality of the life the patients get. What was surprising from the studies, from the MRI studies, is we thought that the atrium will continue to dilate and it will become one, the right ventricle and right atrium, but it didn't happen. The opposite has happened. There was a 30 to 40% reduction in the volume, and the remodeling is happening, and the RV function is improving. So that is a surprising finding. It was not a finding that was expected, and that's a surprising finding. I think the paper now is coming out from Dr. Case.
Yeah. Because unlike the previous belief that it was only a pressure-affected chamber, the right heart is actually also very highly volume affected. That's why timely diuresis also actually helps, and that is why even better use of GDMT, and it's a thought that I've been talking to Bayer about, that maybe using some of the new SGC inhibitors like FSCAI earlier may actually help in right heart function over a period of time.
And then one more angle is, if this the valve is not, subjected to very high pressures like aortic valve. It is not 140, 130 blood pressure, so it is around maybe 17, 18, 20, 25 maximum. So the durability should be much higher, much longer, this valves. Yeah.
Yeah, but improvement in RV is something that probably is surprising, but that, yeah.
That was a surprise for the primary investigators as well.
Yeah, but do you think going forward and when we have devices for the valve fixation also, we would come to a stage where you will start fixing the valve at an early stage of TR, and then probably when that fails, you will save the trick valve for the later duration of the course.
Yes.
So maybe that is how.
No, definitely, because this is a venous procedure and it's much less complicated than a mitral. As already Sarah has shown, we will see a total tricuspid replacement earlier than a mitral, because these valves are already gone through the first in human. They are looking impressive. So the treatments for tricuspid looks more impressive than the mitral.
I would like to, sir, highlight another two important points. One is the dry tissue technology that has been incorporated in this valve has really put this valve to more number of cycles, which means this valve doesn't suffer structural valve degeneration earlier, like the valves which were otherwise preserved in glutaraldehyde.
That's true.
So that's one biggest advantage. And second thing is, sir, we ourselves are working on a coaxial device where we would like to do the annuloplasty and then deliver the valve at the position of the valve. It might take another year or two for us to work on it.
Wonderful.
Thank you.
Thank you.
Thank you so much. Thank you, Dr. Anmol. It was a wonderful presentation.
Thank you very much. I think this session is coming to an end, no?
Yeah.
Just I'll make one comment.
If dry tissue technology is a thing which is improving, then maybe the polymer-based technology for the valves is going to be yet another game changer.
Yeah. Just one final comment. Obviously, this trick valve is being sort of supplied by the Relicis. The Relicis is coming up with the same dry tissue technology in the aortic position. It's the Venibri valve, and it's already crimped. It's like stents. So you just take it out of the shelf and put. You don't need a clinical specialist to crimp the valve in the lab. We have used it 7-8 years ago, even before the CE mark was there. Now the next generation valve is come. I think they're releasing it in the NIC. And that will be a life changer. When the TAVI becomes a common procedure like PCI, the clinical specialist may not be needed, and it will be like, so you pick up the size from the shelf and put. And that is the only dry tissue technology. I don't know why the other companies have not sort of managed it, but the sort of Venibri aortic valve will be released in the NIC. Yeah?
Yes, sir.
Good, thank you.
We are planning to launch it.
Thank you so much,
Let's give a big
doctors.
hand to,
We move on to
Relicis dry tissue technology.
We move on to the next session, cardiogenic shock. I would like to invite the coordinator of the session, Dr. Shomitra, on the dais, please. Also, I would like to invite the chairpersons, Dr. Samir Saraf, Dr. Debanu Ghosh Roy, Dr. Siddhartha Banerjee, Dr. Kashinath Ghosh Hajra, Dr. Indranil Datta, on the dais, please. Also, I would like to request the discussants of this particular session, Dr. Pankaj Singh, Dr. Shojata Chakraborty, Dr. Ayon Kaur, and Dr. Shomu Guho to kindly come on the dais. Thank you so much.
Thank you. Good evening. I'm calling from here because I won't stay for long because of some personal emergency. We are changing gear now. Last 4 sessions were on chronic situations where you have got all the time to think and manage the patient. Now it is the brake is failed and the car is going to crash. So it's cardiogenic shock. So I give my chairpersons and discussions to start the session with the first speaker, Dr. Smith Srivastav, on cardiogenic shock and support devices. Dr. Srivastav, please. Is Dr. Srivastav? Yeah, please.
Dr. Smith will combine both his talks, cardiogenic shock and support devices, and when and which MCS and cardiogenic shock.
Yeah, thank you, Dilip, for inviting me here. It's a pleasure to be at Calcutta once again, and both the talks had a lot of overlap, so I thought that I'll better combine it and make it short, because I know everyone is in a mood to call today, because we had a very good discussion throughout, and I can see fatigue on everyone's face, including mine. So cardiogenic shock, the traditional definition and the operational definitions, we already know when the blood pressure is less than 90, the heart rate is more than 50, and we have a higher PCP. And the point to remember is that it should be adequate intravascular volume. And that is what separates it from septic shock, where we have similar conditions, but the fluid volume is less. The clinical features were described by Henrik in 1912, but the treatment for cardiogenic shock was thought even almost a century before the definition of cardiogenic shock came, and that was where the first concept of an artificial blood pump had come, and then we see a lot of development happening, even including a withdrawal of a hardware in 2021. So we have some promises, some expectations, and some disappointments. The incidence is around 5 to 15 in acute myocardial infarction, and we have witnessed a lot of drop in mortality because of acute myocardial infarction, but acute myocardial infarction associated with cardiogenic shock, the mortality rates remain the same. There are no improvements, whether it is ST elevation MI or it is non-ST elevation MI. 1967, a very good classification had come, which is very practical and clinical, but now we have other classifications. Even SCAI has introduced a new classification, which has been validated. We have a IABP shock 2 risk factor scoring that is also validated, and it has a very good correlation with the mortality. The cardiogenic causes are, again, we are aware, more seen with ST elevation MI than non-ST elevation MI. We can have a good differential from the various parameters, clinical parameters, and it can give us an idea of what probably can be the cause of cardiogenic shock. Before we evaluate the causes of cardiogenic shock, we must remember these differentials, because these are the ones which often escape in a rush to reach a diagnosis, and these are the ones which usually we can tackle very easily and get over it. The physiology, the understanding of cardiogenic shock has come a long way. Initially we knew that it's a low output and low stroke volume, and combined with hypoxemia, but to this systemic inflammation is added, it becomes grave. With this understanding, we now are able to treat it, put mechanical devices and try to use inotropes, fluid managements, so that we can tackle these. But in the long run, or as our knowledge has improved, we find that even managing with these sometimes is difficult because of the coagulation and the bleeding complications associated with these. So it's like a sepsis situation where it's a third space loss in sepsis, but here we find that it's more in the organs that the congestion occurs. There are indexes. The best index is cardiac power index, which combines flow with pressure, and this is defined in watts, and this has the best way to understand the hemodynamic predictor outcome of a cardiogenic shock. IBP risk score, as I was discussing, it also correlates very well with the mortality in infarct-related cardiogenic shock. The treatment that we offer for these patients, it includes revascularization, fluid management, vasopressors, inotropes, GP2B, and we'll just briefly brush through where do these stand. So that is the second part of my talk. So fluid management, yes, initially it works very well because we need increased preload, because that will translate into increased cardiac output, but in later half, if we go beyond certain limit, it results in more pulmonary overload and more pulmonary congestion. So there is a J curve there. After 2013, norepinephrine has scored over dopamine in patients with cardiogenic shock. Revascularization, that definitely we all understand that it works better than the medical management for cardiogenic shock. The single vessel, 2 vessel or 3 vessels, usually again the common practice or advisable is treatment of the culprit vessel rather than in these patients until unless we have a non-infarct related artery which is supplying to a major part. F60MAB or GP2B, they have a non-significant benefit in such situations. So ultimately we are left with a bridge somewhat held by inotropes, norepinephrine, and a bridge mainly assisted by the assist devices, which finally result in a functional recovery from this acute situation. So these can be of various forms. The most common which we are familiar with is intra-aortic balloon pump that has both, it unloads the left ventricular pressure, it facilitates coronary filling, or we can have only LV volume unloading, or we can have it coupled with membrane oxygenation. And we can have a spectrum of pumps from minimum of 2.5 liters to maximum of 10 liters, which can assist in left ventricular supply. The fundamentals are very similar, very simple. Most of us have understand these wells. So whenever we have, the concept is that we need to maintain the pressure, but yet we need to decrease the peripheral resistance. So this becomes two-edged sword, and we wish to have the heart rate raised to an adequate level, but not beyond that. So briefly discussing IBP, the mechanisms are known, the complications are known, but this is the one that provides the least amount of support among the MCS which are available. The status for IABP, the 2012 IABP Shock 2 trial, it suggested that the medical management before revascularization did not had any difference with IABP insertion in patients with acute myocardial infarction and cardiogenic shock. So in Western world, the usage is on decline, but we continue to use it because this is one which we are very familiar to use. It's widely available. Almost every cath lab has it. And we personally, every one of us feels that it works for our patient. So this was the trial where there was no difference between the medical management in acute MI with cardiogenic shock patients. Impeller devices, again, the mechanism is based on the Archimedes screw pump. It unloads the ventricle, it decreases the myocardial consumption. Status, the ISR shock trial in cardiogenic shock patients, Impella was safe. It provided more support than IBP, but it did not translate into a decrease in mortality. Protect, where it was used in PCI, again hemodynamic support was greater than IBP. Again, no differences between the major cardiac events at 30 days as compared to IBP. FDA had issued a warning here that it has higher mortality rates for patients when they are treated with Impella in this subset. In primary PCI with cardiogenic shock, again the 30 days or 6 months mortality rates were high or similar to IBP. For right support, there are again limited data which are available, but it works on a similar principles. ECMO is the mini bypass. This provides the highest level of support, but it has significant amount of complications in form of pump thrombosis. It needs a higher level of expertise to implant it. The north-south syndrome or the Harlequin syndrome is understood, where the upper part of the body and the lower part of the body have differential hypoxias because of a normal cardiac output and a severe impaired pulmonary functions. These are again more of, I can say that they are still more in the evolving or the experimental stages where very limited data are available. They again show that they have improved hemodynamic supports, but again when compared with IABPs, they do not have a very clinical significant outcomes. The dual systems where both the right and the left hearts can be supported, again the data are limited. CentriMag is one that can provide around 10 liters of per minute of flow, and it has again very limited data where out of 12 patients, 8 patients were surgically successfully bridged to durable MCS, 2 were bridged to recovery, and 2 died while CentriMag support. So we have right and left ventricles. We have a array of MCS to support our patients, but to conclude, these are the indications where the green ones are which have good evidences, the yellow ones have 2B evidences, and so I'll rather stress on the red ones, that non-infarct related artery, again it carries 3B. Routine use of IABP, it carries 3B. For right-sided, again non-routine PCI of non-related artery, and IABP again they carry the red flag. And so finally, if we understand this, which MCS to be chosen was the second part, but for us it depends upon the availability, and most commonly the available one is IABP, and secondly our technical expertise in putting these. Again IABP comes to be one that is the easiest to put in. Final words, sometimes we miss over the other reasons for cardiogenic shock, which can be a VSR, and it can be easily tackled it can be tackled with a device closer. So to conclude, it is IABP. If once we have a clear indications where IABP in Western world, in Western literature is not considered, it is recommendations are against use in AMI with cardiogenic shock. And when we compare all these MCS with IABP, it still turns out that the data for these use still needs more work to be done. Thank you.
Wonderful. I think one ECMO support is also available now in many Indian centers. But the main problem is ECMO increase the afterload. So once a patient with a interval MI and is in cardiogenic shock, you want to revascularize, you take the patient on ECMO. It has to be supplemented by either IABP, which unloads very less. It's not an unloading device, but it tries to reduces the afterload, and it helps. Isolated ECMO becomes little detrimental in these situations. Cardiogenic shock with large interval MI or something like that.
Yeah. Or pharmacologically, you have to decrease the afterload.
We had a case where we used the ECMO, and because of the LV dilation, the cardiologist had to put an impeller for LV venting. Because the problem with ECMO is it doesn't unload the LV.
So we had a patient with, during COVID time, I did an angioplasty to LAD, and he went into cardiogenic shock after 24 hours. But the myocardial thickness was preserved, and at that time we put the IABP first. Still, his lactates were deteriorating. We put the patient on ECMO. He was on ECMO and IABP for 7 days, and finally we rescued the patient. So the heart has to recover. So the timely revascularization was there, and finally it made the patient bailed out. Thank you so much.
Actually, if you see the trial, ECMO cardiogenic shock trial, ECMO CS trial, so no benefit. It's a randomized trial in cardiogenic shock of ECMO versus no ECMO. There is in place of non-ECMO, they have used either IABP or they have used only inotropic. So there was no benefit.
So the most promising device at present is Impella in cardiogenic shock, but still we don't have RCTs with that. Yeah. We are eagerly waiting for trials like German shock trial and all. So maybe in next couple of years we'll get more exact recommendations which way to go. So with this we have our friend from Canada, Dr. Sanjog Kalra, online, and he's going to tell us about Impella, how he has used in cardiogenic shock and protected PCI, and a little nitty-gritties on Impella. Hello, Dr. Sanjog Kalra. Can you hear us?
Hi. Hello, my friend. How are you?
Yes.
Thank you very much for having me.
Thank you. Thank you for being there, and we are eagerly waiting for your talk. And here, Dr. Hajra, Dr. Nantraman, Dr. R.D. Yadav, Dr. Panja, many senior cardiologists, and we all are waiting for a talk. Yeah.
Wonderful. Thank you very much for the opportunity to speak to you. I'll try to keep within time. I'll just share my screen here just a quick moment. Can you see that now?
Yeah, we can see the slides, yeah.
Great. I enjoyed listening to Dr. Srivastava's talk a few moments ago. I think there is certainly a lot to be done on the data end for some of these devices. It's hard to say ECMO works or ECMO doesn't work, because I think what we realize in shock is that these are very heterogeneous populations, right? Where, you know, even if you look at IMPRESS, 50% of those patients died because of anoxic brain injury, for which we have no fix, right? So we have to recognize that each of these devices has a therapeutic envelope, and beyond that therapeutic envelope, they're just not going to be all that useful. My center in Canada, we don't have immediate access to Impella all the time, right? We're quite judicious with our use. And so this gives you an idea of some of those patient selection pearls and nitty-gritties that we can get into that may make those of you who are Impella users jump forward a little bit on your outcomes, and those who are not yet Impella users consider doing things optimally from the get-go. These are my disclosures. So this is a 74-year-old with an EF of 20%. The lima is patent, but after recurrent PCIs, he has 2 layers of stent at the distal left main with severe in-stent restenosis. And now comes for revascularization of this dominant circumflex with a downgraft to the circ and a patent lima holding open half of the LAD. Does this patient need hemodynamic support with Impella? Right? Someone, once again, who has a dominant circumflex, an EF of 20%, a large lateral wall ischemic defect, but a patent lima. Well, if yes, what are you trying to accomplish? So what we try to accomplish with any hemodynamic support device during high-risk PCI, or shock for that matter, depending on what the circumstance is the avoidance of disruptions in cardiac output and systemic pressure, right? We just need to make sure that the body is well supplied, because one of the challenges with treating these complex patients is recurrent hits to end organs. These patients are already sick, so they already don't have a lot of end organ reserve, and so those little short hits to the kidneys and to the liver end up with kidney injury and liver injury, which ends up prolonging stay in hospital, prolonging stay in ICU, giving you the risks for sepsis and these kinds of things that often come up. And then there we go, we end up with a poor outcome, but not because of the specific cardiogenic shock, it's because of the recurrent issues that happened after the cardiogenic shock, which gets lumped in to the entire hospitalization and the outcome of that hospitalization. So it's really important to maintain hemodynamics throughout our case as well as we can so that we avoid these injuries to the end organs. We want to facilitate complete and optimized revascularization. So not halfway work, right? Get all the way from where you are to where you want to be with as little drama as possible. That means IVUS or OCT or optimized bifurcation PCI, etc. Because ultimately, as was just the point that was just made, is these patients are only going to survive if their results are optimized. And then of course, we want to maintain case safety, right? Provide adequate support so that complications can be managed. So this is how Impella works, right? There's no magic here. The device sits inside the left ventricle, sucks blood in from inside the left ventricle, and spits it out in the aorta above the aortic valve, just at the level of the coronary arteries. But in doing so, we create a very complex hemodynamic change that optimizes our systemic hemodynamics and reduces the likelihood of functional decline. By reducing pressure within the LV, we reduce LV EDP, that reduces wall tension, and therefore reduces the amount of work the heart has to do, right? It's pumping against less pressure. By reducing the wall tension, you also reduce microvascular resistance, and you increase coronary perfusion, because as we know, coronary perfusion is aortic diastolic pressure minus LV EDP. So if you drop the LV EDP, the coronary perfusion goes up, right? So that then increases oxygen supply to the heart while reducing its demand. And at the same time, we satisfy our first goal of maintaining systemic hemodynamics by holding a map at between 40 and 55, depending on how big your patient is. And that allows you to get through these recurrent hits without an important disruption in systemic perfusion. So when you look at this on our pressure volume loop, this is your regular PV loop, once you put in an Impella, it becomes this funny trapezoidal shape. But what you see here is your end diastolic volume has dropped. You've lost your isovolumetric contraction and relaxation phases because this is a continuous flow pump. The area under this curve, which is your cardiac work, has gone down, right? So you have much less area under the curve, the heart's doing less work, but with maintained afterload and maintained systemic hemodynamics, right? So what you've done here is now decoupled the body's supply of blood from the work that the LV is having to do to get it there. So tip number one is your patient selection is everything. Everybody's seen this slide with these three bubbles or the Venn diagrams, right? Where we talk about the three groups that justify your complex PCI patient. But getting into these nitty-gritties a little bit, when we talk about complex coronary disease to me and to some of the other senior operators in the crowd may be different than complex coronary disease to a relatively new operator. And so it's important to recognize that some of the ways you can manage outcomes in these types of patients is double scrubbing cases. So you may have a sage hand on your shoulder to say you don't need hemodynamic support here, you just need experience. But for those where that's not the case, where we have bad hemodynamics as well as complex coronary disease, as well as patients who have bad comorbidities, who can't survive those recurrent hits, these are the ones where you're going to want to end up choosing hemodynamic support, potentially with Impella for high-risk PCI. I think the comment that the IBP doesn't work is wrong, right? If we look at BSIS 1, you know, yes, there was no difference within the acute hospitalization of the acute study period with IBP, but we had less VTVF, less CPR, less hypotensive events within the procedure, right? So it's not the IBP doesn't provide support, it's that it doesn't provide enough support for some patients, right? And for those patients for whom it doesn't provide quite enough support, where you want to avoid those downstream hits, this is a good device. So who is truly high risk, right? How do you decide on prophylactic versus stand-by use? How much support is necessary? What's enough support for the IBP type patient versus someone who maybe is like the patient that we talked about a few moments ago? And then how do you consider cost into the paradigm, right? What's the cost of a 20-day ICU stay versus a 3-day ICU stay? And then, of course, you need to balance the risks and benefits of these types of procedures to recognize that there's a risk of bleeding versus the benefit of the downstream hit. So to give India something that makes a little bit more sense, we have this contemporary high-risk PCI algorithm that we recently published in Asia Intervention. This is a made-in-India solution designed for India and other managed healthcare markets, where it takes into account these clinical aspects of patient care and the technical aspects of coronary intervention, and gives you a point system that gives you at least a guide on when we should be considering support. This is relatively hot off the presses, and it's most important to really validate this. And that means that operators throughout India, when they do these cases, should use this algorithm and collect the data so that we can be honest with ourselves as to whether or not we're doing a good job. Tip number 2 is hemodynamics. Hemodynamics are critical to both track efficacy and to decide on weaning. So why are poor LV function patients, the ones that typically get these devices, so high risk? Well, as we talked about, we can't magically put stents up into the arteries without blocking out flow because we need to inflate balloons. And for those hearts that are particularly weak, every time you do that, you reduce the ability for the heart to continue to supply itself and therefore supply the body. So recurrent ischemic hits happen with every time a stent goes up, every time a balloon goes up, every time we put a microcatheter through a dominant collateral, etc., etc. And as a result, we end up with recurrent episodes where there is poor flow to the body, and then those recurrent hits that we're trying to avoid. So the lesson is, the heart is generally worse after we do our high-risk PCI, not better. And so you're acutely best at the start of your case, which means that this is hemodynamic support without right heart catheterization, right? You really don't know where you were at the beginning of your case or where you are at the end of your case unless you have the data. So what you try to do then is make sure that you've actually got a view through your cockpit as you fly this plane, right? That you understand the hemodynamics pre and post so that you can affect appropriate function of the device as well as appropriate weaning. This is the Smart Assist platform that's now available through Impella, where using a right heart catheterization, you can put in a cardiac output, and using a hemodynamic sensor within the device now, it will give you both your running cardiac output, your total output, as well as your cardiac power output, and then give you a trend based on how the device is functioning and what your LVEDP is, so that when you try to wean it, you can try to turn the pump down and see that your native cardiac output increases as your Impella flow decreases with a consistent maintained cardiac output. That's how you know you're ready to wean, but you really can't do that without using a right heart catheterization. This is what a successful weaning case looks like, where as you reduce your P level, and you spend not long, 10 to 15 minutes at each P level, what you find is that your cardiac output here is maintained, your pump output goes up, your native cardiac output goes up in the white line, and in the green line, the pump output goes down. That's a patient that's successfully weaned and ready to come off. Tip number 3 is the battle is won and lost at the access. So I won't go through the fundamentals of access for this group because I know we have a lot of experienced interventional cardiologists in the crowd. But one of the things that we know about large bore access is that wires bend. And when wires bend and accesses are at major angles, we create an ellipsoid space around a sheath, particularly a large sheath that predisposes to bleeding behind it as the sheath kinks. So this is when you use a really stiff wire to dilate the arteriotomy and allow for the smooth implantation of a large sheath. And then, of course, use micropuncture and ultrasound to gain access in the first place so you find a healthy area of vessel. We can use the pre-closed suture technique that, again, is fairly well understood, but one of the things you can actually do is a post-closure, where when you put pre-closure sutures in, you can wrap them up in betadine impregnated gauze or tourniquets that we use in the operating room to suspend pericardial sutures, and then tape them down, and then once the device is explanted after a stay in the ICU, you can tighten those things down. And this is a nice review of that technique. This is the single access technique for Impella in high-risk PCI, where once you put in the Impella 14 French sheath, you use a micropuncture kit and puncture at either the 2 o'clock position or the 10 o'clock position. You place a micropuncture wire through and then place your micropuncture sheath in. Through that goes your J-wire, as you'll see now. Okay, this is a standard J-wire going in. Once the J-wire is put in, the micropuncture sheath is removed from the Impella sheath, and then along this you can place your Terumo 7 French 45 centimeter destination sheath, and that sits right inside the Impella 14 French sheath and allows you to do your case through that single access. It's largely become the standard of care for these types of procedures and reduces your vascular access complications because you're only poking the patient once. What about occlusive sheath management? Well, the bottom line is make sure to get blood to the distal vessel and watch out for the inflammatory response if your vessel has been occluded for an extended period. So the best way is remove the peel-away sheath. That's easy. How about when you remove the peel-away sheath but you still think you're going to have bad flow? Well, this is called an external ipsilateral bypass, where you first place an antegrade puncture down into the ipsilateral SFA using a micropuncture kit. Right, so that's what's happened here. Okay, you've got flow down and access into the SFA. Next, you place a wire down the SFA. So you can see this is in some small vessels. You pull the wire back here and direct it down the SFA. Okay. And then along that wire, you place a 4 or 5 French short sheath and simply connect the short sheath to the sidearm of the Impella sheath, and you can supply the distal part of the leg because the Impella sheath itself has some distal flow. It's an 035 lumen, big enough to accommodate a J-wire about the same size as a 5 French. Alternatively, when you have more supply needs, you can do an external contralateral bypass, which is not all that different. You just put a contralateral 6 or 7 French sheath into the right common femoral, and then using an ultralançons connector, connect it to the antegrade sheath that you've put into the ipsilateral SFA, and that way you have supply down the leg. It's very similar to how we do these things in ECMO as well, right? Only with ECMO, you have the antegrade sheath and you hook it up to the arterial cannula. Here, you're just hooking it up to a 6 French sheath on the contralateral side. The patient's going to be flat on their back anyway, so it's really not a big deal for a couple of days. I recommend running the ACTs over 200 if you're going to do that, just to make sure that you don't have any clotting within this connector arm, and that connector arm should not be the tiny little 4 French lumen, it should be a larger 6 to 7 French lumen. This is a good review on a variety of techniques, including these two. Tip number 4, ICU management is critical. The best ICU management starts in the cath lab. So know when, through your hemodynamics, your myocardium is stunned and you need to leave the patient on pump. I was recently in India doing some proctoring and came across a case in a hospital where the pump had been explanted in the cath lab. When I looked at the hemodynamics, it was clear it never should have been done that way. I happened to be there 2 days after this case. I went to the ICU and found the patient in severe cardiogenic shock. We turned the patient's cardiogenic shock around, and he still died because he spent 2 weeks in the unit, got sepsis and the usual ICU complications, and that's why. And that's a shame, because that guy should have lived. And so the best ICU management starts by knowing when you should leave the pump in and making sure that you have excellent hemostasis at the positioning site. Make sure that you tighten the TUI-Borst valve. That's where that sterility sheath tightens onto the repositioning sheath, because that's actually what holds the impella in place. Otherwise, as an Archimedes screw, it will move. What you want to make sure is that you have a stable position in the mid-ventricle. You have unobstructed flow, you have no hemolysis, so you're constantly checking the urine, making sure that there is no redness, tinge, or reddening of the urine. If there is, that's a position issue most commonly, and using an echocardiogram, you can reposition the device to minimize that. The echocardiogram should show you this picture. Your best view is a left parasternal long axis view, where you want your inflow cage recognized with a little mosaic flow just proximal to the pigtail in the mid-LV, and your outflow cage at roughly the level of the left coronary artery above the aortic valve. Ultimately, the distance between here and here should be about 3.5 centimeters. But most importantly, learn your AIC. This is beyond the scope of this talk and would take more time, but one has to become familiar with the algorithms that incorporate hemodynamics and the Impella control console information to troubleshoot device function. Whether you have a suction alarm, a poor placement signal, low flow states, etc. All of these things can be easily solved using a simple set of algorithms that we've developed that can be taught. So it's most important to recognize that when you take a patient from the cath lab into the ICU with the Impella in place, you cultivate a culture of migration and daily monitoring, because that device will move if you let it. And it's a very good device to support ventricular function while the heart recovers, but you have to be looking after it. So you can't just set it and forget it. It's not like an IABP where it just keeps going. You do have to look after it. And it's important to not simply explant after the PCI because the ICU is scared. Confidence comes from experience, and so reach out to your company representatives and they will line up ICU training for your staff so that they know exactly how to use this device, not just the AIC, but how to troubleshoot the problems. And then, of course, tip number 5, don't forget the PCI, right? This is a famous slide from the Syntax trial where this was your CABG MACE rate and this was your PCI MACE rate in some centers. You probably don't want a PCI here any more than you want a CABG here, right? And that's because not all procedures, patients, or operators or environments are created equal. So it's important for us to recognize our own skill sets, refer on if we're not comfortable with a given PCI, or if we are, or if we have a partner that isn't comfortable, scrub with them to be able to ensure that we get our patients the best outcomes. And that we focus on the patients that have the most to gain. We all know the ischemia trial showed us that even with patients with ischemia demonstrated in multiple territories that was non-left main, there wasn't a benefit of invasive therapy versus conservative therapy with medical management in the short term. These were those outcomes out to 3.3 years, right? So, you know, interesting finding. It's important, right? Tells us a lot about simple disease. But when we look at more complex disease, when our Duke treadmill score gets bigger and bigger, when we get into more and more complex disease, these are the patients that actually have the most to gain. And interestingly, those are also the patients that often justify the use of hemodynamic support, because those are the ones that are at the highest risk of having a peri-procedural complication that we want to avoid if we want to get these types of patients the best outcomes they can have, right? And for what it's worth, this was an analysis of the ischemia data that demonstrated in patients with the worst LV dysfunction, those are the ones that actually had the biggest benefit from invasive management, and the ones that suffered the most when they had conservative management. So back to our case. Angiography and IVUS of this demonstrated these findings, where you had a minimal lumen area that was about 5 at the distal left main. Now, I chose to put an Impella in because I knew I had 2 layers of stents, and this is before we had access to shockwave. And so in order to prep this, I did a bunch of contrast-enhanced laser and then took very high-pressure balloons to high atmospheres and sat there. And ultimately, I sat there with a 4-row balloon at 34 atmospheres for 3 minutes and 34 seconds. That balloon was up, plugging this dominant circ. And for at least 1.5 minutes of that time, his heart was not pumping. He was completely flatlined, dependent on the device for support. So this becomes a case that you really can't do unless you can crack that stent open, right? He was not a candidate for redo bypass. And so in this situation, this was the classical case where An IBP wouldn't work, right? You can't counterpulsate when you have no pulsation. And ECMO is just going to load an already sick LV. So the Impella becomes an optimal device here. And ultimately, once we were able to pop that open, we ended up stenting him, getting this final result, but the imaging is always what defines whether or not the result is good, so you can see for yourself. This was the left main pullback in that case. You'll see the multiple layers of stent coming up towards the distal left main, where there is, of course, a degree of constraint of the lumen as you come around the corner. But when you actually measure out how we did, well, we didn't do too badly when you recognize that the minimal stent area on this man was 10.49. So he's going to stay open, and he has stayed open. This case is years old now. So post PCI, because this was an Impella single access case, we had to explant the sheath that was inside the Impella sheath, and that's easy. These are my hands, and this is how I do it. You just pull it out. There is no magic, no nothing involved. No drama, it's very simple. Note the Swan-Ganz catheter, the right heart cath that's there with the Impella device in place. So hemodynamic support for high-risk PCI is growing and allowing access to optimized results. And device selection is really important, right? It's all of these devices have their place, but the Impella is probably becoming the workhorse, recognizing that we have to manage the cost implications, particularly in environments like India or Canada. And so it's important to recognize not only who the right patients are that are going to benefit from these devices, but how to manage them after the procedures are done to make sure that we maintain optimal results. Thanks very much for your time and attention.
I think it was a wonderful talk, Dr. Sanjog. And when we look at the, the data
Apologies if I went over.
Data from Protect 2 to Protect 3, the initial benefits were nullified by the, adverse events from vascular, adversities. Like the more and more we are gaining the confidence in properly ensuring the vascular closure, probably the results with Impella will be much better. So I
think that's a very, very good comment.
Yeah.
Right, the number of vascular access complications has dropped steadily as you've gone out from experience, right? From Protect 2 out to the end groups of Protect 3 where serious vascular complications are down to 2%, right? So that really had a major effect. And I mean, there's a lot of made out of this FDA black box warning around bleeding and these kinds of things. And that when you dig into those results and dig into those data, that was a hack job, right? Using national inpatient sample data, right? It's very unsophisticated data. So it's very important for us to recognize that experience counts for something and that we actually have to look at the data carefully before we make sweeping kind of judgments. None of these devices is perfect. That's the truth.
And one more point I would like to have your comment. One kind of concept is gaining a lot of noise is when you get a large interval MI, better to put this patient on Impella MCS and do the procedure revascularization of 30 minutes. So what's the basically hypothesis here and how they are gaining, what is your idea about that concept?
Sure. So that's the concept of door to unload, right? This was a concept that was born out of preclinical data that showed when you create an anterior wall MI in an animal and then you unload the left ventricle for either 0 minutes, 30 minutes, 60 minutes, or 90 minutes, and then digest the protein and do a gel, what you see is the activation of heat shock proteins and all of the pro-inflammatory cascade proteins in patients who have no unloading with 30 minutes of ischemic time, or unloading for 60 and 90 minutes for 30 minutes of ischemic time. But at 30 minutes of unloading, despite a closed LAD, the proteins that are digested and run against a control sample were almost the same, right? So they realized that they were avoiding the inflammatory cascade. And that's what was responsible for the later reductions in LV function that are observed at, sort of 6 months to 1 year after a big anterior wall MI. 50% of those patients are still back in hospital with heart failure at 1 year, right? Even though we're doing door to balloon times in the 30-minute range now. So there was that residual sort of bit to gain. So that's where the concept of door to unload came from. And that was studied in a feasibility trial that we published in January of 2019 in Circulation, where patients were unloaded when they had a defined anterior wall MI with more than 5 millimeters of ST elevation summatively. And what they found is that it was safe to sit there and unload the patient for 30 minutes and then do the intervention. Now, as an investigator on that trial, what I can tell you is what you see when you do that is sort of miraculous because the patient's pain starts to go away. And a lot of times their ST segments come down as well because they have collateral flow, some of the recruitable collaterals that they're born with, that start to get better flow when the culprit artery is closed, because you reduce LV-EDP, you increase coronary perfusion pressure, and you make it most likely that the distal vessel ends up getting some supply. You also decrease the demand, so you decrease the chest pain. But that has not yet been studied in a pivotal trial. That's what's going on now. That's called DTU STEMI, and we hotly await the results of that trial. My expectation is that we will find a reduction in the size of the infarct on MRI at sort of 3 months, 6 months after the anterior wall MRI. That's going to be the big benefit. It's not going to be a benefit for the short term. It's going to be a benefit for the long term, because these are not patients who are in shock with their anterior MIs. They are just your garden variety anterior STEMI who's not tanking, right? Those patients have a lot to gain long term from maintaining good ventricular function and not taking recurrent hits, not ending up on 20 different heart failure therapies. Their gain in the short term is our PCI. So much to be learned there yet.
Very interesting demonstration of the different cases. That is enough role of the Impella. My question is that the Impella 2 trial already shows that it is beneficial compared to the IBP. But what is objective of the Impella, the Protect 4 trial? Whether it is the FDA FDA already shows the mortality is higher in the Impella. Do you want to disprove by the Protect 4 study? What is objective of the Protect 4 study?
So yeah, so these are good questions.
What is objective of the Protect 4 study of Impella?
Yeah, let's thank you, Dr. Panjay. So let's clarify that a little bit. Protect 2 demonstrated that in the intention to treat analysis there was no difference. But when you actually look at the patients who crossed over and you look at the per protocol analysis, there was a difference in MACE of 29% at 30 days, and that was largely driven by complete revascularization, which we know helps, right? So that's point 1. Point 2 is what is Protect 3 and where does the FDA warning come from? The FDA warning came from a national inpatient sample that effectively homogenized large groups of data with different indications. As a result, patients who had multi-vessel disease and multiple comorbidities were lumped into the same group of patients who had much fewer comorbidities and simpler disease. And that makes it much more difficult to actually hang your hat on that recommendation. But at the time, it was important to recognize where the potential safety flaws lay so that we were putting safety first, right? That was an appropriate thing to do. So the idea of Protect 4 is to do a more definitive trial with patients that Protect 3 has shown are the most likely patients that actually get Impella support. So this is a properly done sort of optimal PCI trial in the setting of Impella support. That means we're not recruiting the EFs of 40% per se to this trial. These are the patients who have really low EFs, really, really bad multivessel coronary disease, large delta syntax scores to be achieved, optimized PCI with imaging guidance, etc., has been strongly recommended. And the idea is for us to actually not do the crossover that happened in Protect 2. So with Protect 4 now, you cannot bail out from IBP to Impella. You can't do that. You will recruit to IBP and stay on IBP, and your bailout becomes ECMO. Because that's really what you're comparing against. If you start with Impella and you need to bail out to ECMO, you can, right? Otherwise, you stay. So we're purifying the groups to really define whether or not it's the Impella support that's making the difference in this high-risk PCI, and is there a difference above sort of conservative, typical management or strategy, which is either nothing or a balloon pump. It clarifies a lot of the questions that came out of Protect 2.
Okay,
thank you. Thank you, Dr. Sanjog. Thank you for taking your time out and being with us. So stay
My
back
pleasure. Thank
if
you
you
for
can,
having me.
and we now move on to next presentation. Dr. Sunandan Sikdar is there. He will talk about right heart catheterization. So we'll hear about cardiac power output and PAPI index and where to go for right hearts, and give us some more clarity.
Thank you, everyone. Have a good day.
Thank you.
Good evening, everybody. Thank you, Dilip, for this excellent evening and the fruitful discussions that are going on. So we will be going to a very important concept today, right heart catheterization. We all know that whatever goes back or goes past comes back again.
So it is like this, that this right heart catheterization is having its second renaissance. So it was actually this right heart catheterization that started the chapter of interventional cardiology, because it was from Forsman that this right heart catheterization started. And we can see William Gans and Swan, who were the originator of the pulmonary artery catheter that started the entire thing. And we can also see the Diamond-Forrester classification that came out in 1970s that ushered in the era of CCUs and hemodynamics. So what happened in between that right heart catheterization went out of vogue? So it was the ESCAPE trial. That was actually a study of 400 patients comparing heart failure patients, and it excluded patients in whom RAC may have been warranted. These were patients with renal dysfunction, prior use of moderate inotropes or pulmonary hypertension. They did not study cardiogenic shock, particularly those who were in inotropy or vasopressor therapy. And the study concluded that the use of right heart catheterization did not demonstrate a mortality benefit. However, if you look at it in a detailed way, high volume centers in the ESCAPE trial along with the patient with cardiogenic shock may have shown some outcome benefit, particularly if the interventions that were done based on the PA catheter result, if were done more judiciously. So there was some lacunae by which this pulmonary catheter and right heart catheterization went out in vogue. So what are the applications of right heart catheterization today? So as we can see, this is the area actually which we are talking about, cardiogenic shock. So diagnosis, risk stratification, real-time titration of pharmacological versus vasoactive medication, and implantation of mechanical circulatory support. This is what actually characterizes the right heart catheterization today in the context of cardiogenic shock. In other cases also, we can see that right heart catheterization has come back as heart failure centers and heart transplant centers are grown in stature. So what are actually we looking in right heart and left heart catheterization? We all know that pulmonary artery pressure, pulmonary capillary wedge pressures, right atrial pressures, these are the major things that we look at, and in particular cardiac output is a very important thing that we should measure when we are using this right heart catheterization. So current indication may be an invasive hemodynamic assessment for diagnosis of cardiogenic shock, continuous hemodynamic monitoring with PA catheter in places with mechanical circulatory support, or for weaning from mechanical circulatory support, and to assess the candidacy for transition to the advanced heart failure therapies. So this is actually an important paper that right heart catheterization cardiogenic shock was associated with improved outcomes. So there was a significant 30% reduction in mortality on index admission, 17% reduction in 30-day readmission, and 6-fold increase in use of LVAD. This came out in 2021 from the Sagar Ranka group. So there are certain precautions while we are going for this right heart catheterization. 2-hour fasting is important, and overhydration is to be avoided because the exact pressures may not come, and we should avoid sedation. We all know about these pressure curves from right atrium, right ventricle, pulmonary artery, and pulmonary capillary wedge. But there are one or two important things that we will discuss. So once in the pulmonary artery, pressure recording is to obtain to confirm the position, and we should look that this is in pulmonary artery by confirming the presence of a clear dichrotic notch. And all pressures have to be recorded at the end of expiration when intrathoracic pressure is closest to 0. This is important at end expiration when the intrathoracic pressure is closest to 0. And saturation should be obtained from PA and RA simultaneously, because then using FEC equation is much better. And we should confirm in the pulmonary artery wedge pressure by looking at oxygen saturation. So once a patient is ventilated, and once we should be looking at this. For spontaneous ventilation, all pressure should be measured at the peak of the waveform. But if a patient is on positive pressure ventilation, should be made at the troughs of the respiratory cycle. So for spontaneous breathing patients, it is at the peak. For the ventilated patients, particularly on positive pressure ventilation, we have to have on the troughs. So we know the definition, actually this criteria, as we have to utilize the pulmonary capillary wedge pressure, we have to do a right heart study. So these are the shock parameters that we can get from the right heart study. And this is important, diagnostic shock by hemodynamic data. So if it is a cardiogenic shock, we will have a decreased cardiac index, increased SVR, increased RA pressure, increased pulmonary capillary wedge pressure, and decreased SVO2. While if we have hypovolemia, we have decreased cardiac index same, but we will always have a decreased pulmonary wedge pressure, which is increased in case of cardiogenic shock. So we can differentiate cardiogenic, septic, hypovolemic, and neurogenic shock by this hemodynamic data. So coming to the important concept of cardiac power output. So this actually was studied in 1990 by Tan et al. And it was actually brought to the forefront by the Finke group. It is actually a combination of flow plus the peripheral resistance. So in this we can say that if the probability of in-hospital mortality of CPO is less than 0.5, then there is high chance of death. But if it is more than 0.5, it is a higher chance of survival. And normal cardiac power output for hemodynamically stable average adult is approximately 1 watt. And it is cardiac output into peripheral resistance divided by 451. This is actually the index. So what is PAPI? This is another index that is utilized in the right heart study. So it is pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by right atrial pressure. And if a PAPI is less than 1, it predicts severe right ventricular dysfunction. So CPO or cardiac power output less than 0.5 and PAPI less than 1, these are important indicators that the patient of cardiogenic shock may be in requirement for a mechanical circulatory support. So hemodynamics is important in right heart failure as well. Isolated right heart failure, hemodynamics is important because RV is prone to rapid decline in function and the immediate mechanical circulatory support can save it. And coming to the shock team, standardized team-based care for cardiogenic shock. This Teherani group actually had given this score. That is a cardiogenic shock risk score. The lactate should be more than 3. Pressure duration should be more than 36 hours. Cardiac power output less than 6. Diabetes, dialysis, PAPI less than 1. And age more than 71. These have been scored. And if the score is high, that is high risk score, 5 plus or more, the mortality is, 30-day mortality is 82%. This is actually the shock algorithm. So the shock algorithm tells us if we have a cardiogenic shock defined by definition and lactate level is more than 2, you go for the next group, that is hemodynamics. If their hemodynamics shows that the pulmonary artery wedge pressure is more than 15, cardiac power output is less than 0.6 and PAPI is less than 1, then there is a role for mechanical circulatory support. So there are 3 types of mechanical circulatory support, we have come across it, and the predominant effect of a mechanical circulatory support is also to ventricular unloading and also increase the myocardial perfusion. So this is one of my case where I hadn't had time to do RHC. So the importance of this is to do a hemodynamic study is not always feasible. 42-year-old male, a lawyer by profession, smoker, diabetic, 2-hour chest pain without any palpable pulse. And BP is not recordable. So what we do is, we have this is inferior wall MI with AV block, EF 22%, ABG severe metabolic acidosis 6.99 pH, lactate is 15. Do we have time to do a hemodynamic study? No. So there is no way that we can avoid a mechanical circulatory support, and I only have IABP in my center, I do not have any impeller. So we have to go to this. This is the artery, you can see the LAD is gone. RCA is also gone, there is only a diffusely disease circumflex with EF 22%. So we put in immediately an IABP with ventilate the patient and did it the primary angioplasty on the IABP in this acidosis. On the second day, the pH normalized and we had a decision of whether to take off ventilation or IABP. We always extubate ahead. We keep the IABP because it is necessary for a longer time. Then on day 2 again we have an ST elevation, now in the anterior leads. But fortunately for me, I didn't have to go on do an LAD on a 20% ejection fraction. That it settled on day 3, and gradually the patient was weaned off the IABP, but at this point again the BP came down, adrenaline had to be introduced, and ultimately vasopressors were tapered off. Patient was ultimately discharged on day 10, and we had thought of doing the LAD, but patient refused at that time, and the pandemic was going on. This patient actually survived for 1 more year, and he had died ultimately because of a ventricular VF, and he had refused throughout to do an LAD angioplasty. But important thing is to show that sometimes we may not have time to do a right heart cath in a circulatory shock. So this is the postulated mechanism of advantage of IABP in RVMI. To summarize, right heart catheterization is having a rebirth after an era in wilderness. Crucial planning in cardiogenic shock is a must. And important indices today are cardiac output, pulmonary capillary wedge pressure, right atrial pressure, PAPI, and cardiac power output. These are important indices for MCS deployment. Thank you.
How long would you monitor this right heart catheterization, number 1? And secondly, after the patient recovers from the acute cardiogenic shock, patient goes into the chronic heart failure, does it give an indication the utility of cardiomem in the later stage for chronic monitoring?
Yeah, as far as the monitoring part is concerned, I think there is no clear-cut guidelines. There is no clear-cut guidelines of how long the right heart catheterization, basically pulmonary catheter, how long you have to keep it. But till the patient has taken off all the inotropes and vasopressors, I think it is necessary to keep this pulmonary catheter. If the patient is already on a MCS or mechanical circulatory support, it is even more important to keep the pulmonary catheter because malfunction of the MCS can be earlier detected by pulmonary catheter. So either vasopressors or mechanical circulatory support, if they are there, keep the pulmonary catheter. The other part of this MEMS part, this I actually don't know. This any recommendation related to this, I didn't study it, this part.
Thank you, Surendra. It was indeed a wonderful talk and wonderful case. I think you rescued the case almost. So with this, we have a device which has saved many lives. The last presentation of this session, and that is available in most of the hospitals now. ECMO, and we have someone who has maximum experience of ECMO. I think not in India, among in Asia also we can say. The team managed around 38 ECMOs in a day during COVID time. So it's just an incredible work. Dr. Deepanjan is going to speak on ECMOs in cardiogenic shock.
Thank you. Thanks for the opportunity, and thanks to the previous speakers who have made my work very simple. So, we have seen various devices. We have seen Impella, we have seen IBP, we have tandem heart. For the right heart, we have the Protect Duo. So which device to use and when and how to use, it is one thing that we all need to learn in a patient of cardiogenic shock. I'll just go through a case. This was a patient who had an MI outside, was admitted, angio done, left main with triple vessel disease. After 10 days, the patient was referred to our center, and we found that the patient was in failure with poor ejection fraction, TAPSE of 12. We put the patient on BiPAP and LASIX infusion. Within 1 day, the patient's X-ray improved. We changed over to a nasal oxygen. But after 2 days' time, again, we found that the patient is going into a cardiogenic shock, low output, oliguria, cold extremities, hypotensive, arrhythmias occurring. And we started adrenaline infusion, did an arterial line, central line. Still the patient was not stable, so we ventilated the patient, and primarily what we usually do in these patients is put in the IBP. So once we put the patient on IBP and in 2 days the patient metabolically stabilized, we took the patient to the OT and did a on-pump CABG, 3 grafts, and the patient came off with 3 inotropes and an IBP and ventilation. But on the day of the surgery evening, what we found that the patient was again oliguric, lactate was rising, the patient was having arrhythmias. In ABG there was metabolic acidosis. Echo was showing poor contractility, and you can see that the lactates are going up. So in the same day, evening, we put the patient on peripheral VA ECMO support. And as soon as we put the patient on ECMO support, within a short while the arrhythmia settled and the urine started to trickle down, that we very commonly find in the patients with cardiogenic shock. So the lactates came down within 24 hours, the pulse pressure improved, and the contractility also was slightly better. On the 6th day, we started to wean the patient off the IBP, of the ECMO. So we came down on the ECMO flows. So as we gradually came down on the ECMO flow, we saw the hemodynamics, the arterial pressure was stable, but the PA pressure was mildly higher, and the ABG showed a metabolic acidosis appearing. So on the 6th day, we had to abandon the process and went back on full flows on ECMO. And then, again on the 9th day, the echo was better. Metabolically, the patient improved further, and we again started the patient to wean off. So we came down on the ECMO flow, and then there was no metabolic acidosis, and echo was good. We took off the patient from ECMO. Usually, initiation of ECMO is by percutaneous route, but when we are taking off the ECMO support, we usually take the surgical help for taking out the arterial cannula. The venous cannula can come off and on its own, but we do not need to explode the vessel there. But the arterial cannula is always closed and taken off under vision. So the patient was taken off ECMO, and then we did a tracheostomy. Gradually, we came down on the inotropic support a bit, took off the IBP. Initially, the patient was better, but again, the patient had an episode of sepsis, low output, which was managed, and later on, the patient's tracheostomy was decannulated, inotropes were removed, and the patient was discharged on the 35th day of the surgery. So it was a prolonged time that the patient needs after the initiation, after the patient had a cardiogenic shock and ECMO. Though the period of ECMO was only 9 days, but the patient needed a prolonged period of recovery to be stable to go home. So when we have a patient of refractory cardiogenic shock, our target is to have the immediately have a proper tissue oxygenation. So it is not the heart that we are targeting, but the tissues. If the tissue oxygenation is hampered and the patient lands up with multi-organ dysfunction, the outcomes will be poor. So once we need the proper tissue oxygenation, what we need is a short-term mechanical circulatory support device, and ECMO is one of them. So when when we need to put the patient on ECMO. Do all the patients in shock need an ECMO? It is not. But some of the patients may have a vicious cycle and go into a severe cardiogenic shock, and they will need an ECMO. So we need to know the timing of initiation of ECMO. Early ECMO, if we put very early, then it will be of not much help. As the ECMO shock trial, the ECMO CS trial has showed, the very early initiation of ECMO will not be helpful. But once the patient, you are seeing that you have done everything for improvement, you have started inotropes, you have ventilated, but still the lactates are going up, the patient is having or going into multi-organ dysfunction. So before that, you have to intervene. So the hemodynamic problem progressing to hemometabolic problem. So it is there that you have to intervene before it has progressed to a hemometabolic problem. So, and what the ESC guidelines say, ESC guidelines also say that according to the management, you have to consider oxygen, ventilatory support, inotropes, as well as at the same time consider about mechanical circulatory support devices. ECMO patients, usually we have to optimize the flow because the flow determines the tissue perfusion as well as the map. But if we increase the flow, what we have seen in the previous talks, that as we go up on the flow, because it is going retrogradely towards the heart, it increases the afterload. So we have to balance the afterload increase as well as the flow. And adequacy of tissue perfusion has to be ascertained by assessing whether the lactates are coming down, whether the patient is having a good urine output or not, or the mixed venous oxygen saturation. Two things that are problematic in ECMO. One is the distal limb perfusion, because we are doing a peripheral arterial cannulation, the same limb, there can be an ischemia. So as we have seen for the impella, we also give a distal limb perfusion cannula for the same limb in ECMO. And we always note the flow in the popliteal arteries. Also we can put an NIRS to see the flow is adequate or not. The second thing that we have to note is that progressively the LV can distend. Because of the increasing afterload in a failing heart, ECMO is not very, very friendly for the heart. So if there is an LV distension, we have to detect it early and do a drainage, either by an IBP, decompress the LV, or we can put an impella along with it, or we can use what we primarily do is continue the inotropic support, use inodilators so that the afterload can come down. But there are certain advantages of VA-ECMO over the impella or other mechanical circulatory support devices. It is one of the devices which can give the maximum support to the circulation. And it can give biventricular support, both in right and left heart dysfunction, it can give a support. In malignant arrhythmias, where there is no ejection, VA-ECMO can continue the circulation for the patient. If the patient has a lung problem, along with it, if the oxygenation is deficient, then this is the only support that gives oxygenation to the patients. And it is very quick and easy to initiate in skilled hands. It takes only 10 to 15 minutes to initiate ECMO. And it is comparatively quite less costly than the impella that we have. But the main problem is again the afterload increase. In the cath lab, there are three scenarios where we have to use ECMO. One is if the patient has a very bad coronaries and you suspect the patient may have a cardiac arrest within during the procedure, so you can do a protected PCI with the help of ECMO. Second is if the patient has come with an MI and cardiogenic shock, you have stabilized the patient on ECMO, and then you revascularize the patient, take the patient to the cath lab and do revascularization. And the third is very upcoming is the eCPR, because in the cath lab, if the patient is crashing, we have to access venous and arterial access in the groin, where you can easily put the cannula and continue the circulation. Last few slides. I'll not go to the cases. So key aspects is the timing. One is you have to initiate ECMO at the proper time. Second is the level of support, how much ECMO support, how much flow you need, you have to assess. And the third is the prevention and management of all the complications, both the patient related and the device related. Thank you. All hospitals who are having the ECMO team should have an ECMO shock team now, because this is a shock team that is going to assess the patient and give early benefit with either ECMO or Impella or whatever device is needed. So the shock team is the demand of the day. Thank you.
I have a few technical questions, if that's okay. So what do you use for your distal limb perfusion? What size cannula do you use?
Usually we put a 7 French sheath in the same artery in the directed downwards, and we take the blood flow from the side arm of the this ECMO cannula, and that we connect to the sheath.
And when you decannulate, then this particular distal perfusion, you just compress it.
Now, when we are decannulating, it is under the surgical guidance. We can take it out.
But that is for your arterial cannula. What about
both are quite close together.
Okay.
Well, both are quite close together. No problem.
And what is a heparin and ACT strategy?
So, see, the VA ECMO usually requires a higher ACT than the VV ECMO. We usually, it is not the ACT that we followed, the APTT usually is followed, and at least twice the normal of APTT that is going on. If the flow is coming down, when we are weaning the patient, then we use a higher heparin dose, because there the chances of clotting in the cannula or the oxygenator can come. So we use higher heparin during weaning off, but otherwise it is twice the normal APTT levels. If you have a patient who has a aortic dissection or a severe aortic regurgitation, in those situations we do not use. Second is, just like an IBP. Second is, if the patient has an arrest, unwitnessed arrest, and you don't know about the cerebral situation, there you do not go ahead with an ECMO.
Bad peripheral disease.
Peripheral, if the patient has a peripheral vascular disease, we can initiate ECMO with by the cannulation of the by the surgical cannulation with the right internal artery.
Thank you, Dr. Dipanjan. It was a wonderful presentation, and we have saved so many lives. We have seen. So thanks again, and it brings the end of the session. Now we are moving to the session on leadless pacemaker, and may I invite Dr. Prakash Hajra to give his presentation. May I request Dr. Sunandan Sikdar and Dr. R.D. Yadav to be on dais.
Hello. I think it's needless to speak on leadless pacemaker, the last hint of the meeting, because everybody is hungry.
I just wanted
It's
anything which is related to large bore access should be our structural heart, under the gamut of structural heart intervention. That's why I kept this topic, leadless pacemaker.
Okay.
What's new on leadless front is what we expect to hear.
Can I have the first slide? Thank you very much, Dr. Dilip Kumar, and much congratulate him for his endeavor, and he's a visionary here in eastern part of India. I'm so glad he is one of the few of our new generation of cardiologists who knows about ECMO, who knows about TAVR, who knows about mitral clip, also LA closer, wireless pacemaker, complex PCI. And over the last decade, the center, Medica Hospital, has emerged as one of the best centers in Eastern India. And just because of one person with his team, headed by Dr. Dilip Kumar. And I'm so proud to announce here that I'm not scratching his back. He's supported by a strong management. His passion to teach, his passion to organize an academic program involving seniors, juniors, forgetting the caste, creed, religion, political affiliations, so on and so forth. I'm really proud of him, and he's a proud product of Calcutta. And he has been a proctor. You'll be glad to know that he has recently been proctor for many procedures. And also very glad to have Anand Jadhav, Dr. Ganguly as a teacher, and the audience here. So my talk is very simple, which I am doing for last few years. It is not life-saving, but its pacemaker is the most satisfying procedure I do in eastern part of India. It's not TAVR, not complex angioplasty. Primary PCI and doing a pacemaker which can work for 10, 20 years in patient's life and can save another syncope or even death by a simple procedure, and it has been miniaturized to a pacemaker which is like a Bicosol capsule. And where the technology is moving, this technology, artificial intelligence is the best new thing in the town, and the battery technology. Whether it is a car, whether it is a drone, the same technology like a nuclear battery in a pacemaker, which can outlive the patient's life. So nuclear battery or a biological pacemaker, or a GLP-1 which can work as a biological pacemaker which increase the heart rate in 6 sinus syndrome. So these are the thought process, or sinus node transplant or something like that which will work as a biological pacemaker in the future. And this is the pacemaker and how it is different from the normal pacemaker. Normal pacemaker, when you implant, you touch. When you touch something which is inserted in human body, there is always a chance of future infections. Now we know that pacemaker infection can be treated in many ways. You can just keep it open and the pocket heals. There is an Israel study of 300 people. They give intravenous the vancomycin. They give a very high dose of vancomycin in the pocket. After 3 to 4 months, it heals automatically. The ICD CRT is a costly device. There are patches which can prevent infection in a pacemaker, like Medtronic, they have patch. And now we also know, we know bacteria, we know virus, we know fungus, we know microbes. Then we know microbiotas. So what is this microbiotas? So microbiotas is much smaller, much dormant. It's just like a sterile inflammation in pacemaker pocket. Where from they come, whether it comes from blood, and it has been seen on electron microscope that if you have a pacemaker which has got red inflammations and infections, the microbiota may be important, because most of the time you do not culture these, you are not able to culture anything from this pacemaker. And Eastern India has been the hub of bradycardia, unlike the northern part where I got myself trained in PGI, we hardly used to have. But we used to see a lot of pacemaker infections. So pacemaker infection, as you do not touch it, and there is no skin contact, there is no chance of microbiota forming in a pocket, the chance of wireless pacemaker getting infected is very low. And also the polishing part, it is continuously being flushed in the RV, the shaking of RV with contractions, and the polish, beautiful polish, which can prevent the pacemaker infections. So that's why the wireless pacemaker is free from many infective complications. It's not that it doesn't happen, it does happen, endocarditis can happen. The only treatment of endocarditis in pacemaker related infection is just to snare the pacemaker out. So it's like a female's pendant, and the pendant, you know, you have a necklace and it's a pendant. The necklace is invisible, the pendant is visible. And there is a hook. So if that hook you need it for future extraction, that hook can be used for extractions in a pacemaker where you have endocarditis, which is also very, very rare. But it can happen in drug addicts and those who are drug abuser, or in any form of dialysis patient. Even the dialysis patient can get infected. So this pacemaker is the only pacemaker which is done by a cardiologist the way the angiogram angioplasty or RV angiogram is done. With the training, you can do without knowing the RV apex, but it is basically a fall from above. Never ever try to push the pacemaker from below. It's always a fall from above. So you go as high as possible in the SBCRA junction, and you you release this pacemaker and the sheath knows where to go. So there are 6 movements in the sheath. You can go forward, backward, clockwise, anti-clockwise, flexion and anti-flexion. So these 6 movements always take you there where you want it to go. Now, many times we keep a temporary pacemaker and that works, the tip of the temporary pacemaker works as a lighthouse. So you know that it is a piggybacking. That means on the back of the temporary pacemaker, your sheath can fall back. So visually you know then when you come to RO or LO, you can have the trajectory of the wireless pacemaker and you go to your destination. So when you have reached the destination, you can go for a small angiogram, and if you see this angiogram, it is in the apex, just take it. The first cut is the deepest cut in any forms of interventions in cardiology. Whether TMV, the first clip you use, whether it's XT, whether it's GT4, the first TAVR, what you use, whether it's balloon expandable, self-expandable, Indian valve, Western valve, accurate new, because that valve is going to stay there. So similarly, the first stent or the first position you get in micro pacemaker, just take it, because you have given the least effort to reach to that spot, and the chance of complications is almost negligible, because if you really retrieve it and go to other position, always chance of having difficulties. So take it. The only problem of going to inferior, if you produce a perforations, if it is a large perforation, you get tamponade. Whereas if you go to the septal area, the chance of perforation is much less, because it's much thicker, stronger. And if you perforate perforation, you produce a VSD, patient still can survive. So we have moved from single chamber to a double chamber, and if you have a lucky patients, you can have VDD-like pacing immediately after implanting the pacemaker. You make them walk. This is only pacemaker, device which can be implanted from the groin, and you give a compressions, reverse the heparin, and patient can walk. And when they are walking, you can see that is you're tracking your P wave, and a large femoral bore or any access from the femoral vein, the large bore sheath should be kept for future extraction of your devices. Like last week, I had an embolization of the Lamprey device in the LA, and the patient suddenly, the patient was doing fine. Then my echocardiographer said that Lamprey has embolized in LA. So I take out this micro sheath and I repuncture the same site on heparin. I placed the micro sheath in the RA, entered the LA, grabbed it and just pulled it, because it is a large sheath. Without any effort, you can drag the Lamprey or large ASD device. The large TMVR device, I do not know whether it can be. Anand can tell me. Anand, can you take this mitral valve through the septum back into the RA and drag it to the microsheath? No. And, that is the only device I think you cannot drag it down through the microsheath. But large device, please keep this for future references. And there's a beautiful connections between your atrial contractions. This is basically same pacemaker, same size, same kind of deployment, but the algorithm is different. So AV micro works, and you know that the venous system, when you enter the same venous access, you know how to enter, how to exit. So only point the tips, you having a large bore access on the venous side with a TMVR or a large molecular device or a micra, that once you puncture, you just introduce a sheath, then you keep the wire, take the sheath out, then again you go. So if you have any inadvertent entry through and through the artery, you will see the spot. So if you see the spot, whether if you are doing an mitral clip or a large femoral sheath, please do another puncture, because it's a venous puncture. Trich valve, again trich valve, if you have an access which has gone through and through to the artery, you know, if you introduce a 27 French sheath through arterial line, you can imagine what will be the shape of the leg. As I said, these are the movements, and you know, this is sometimes this is the only pacemaker. I have upgraded. This is my first double chamber micro pacemaker. This man developed LV dysfunction. He was having a 6 sinus syndrome, so not 6 sinus syndrome. I think he was a advanced AV block, but LV function was all right. But later on, his ejection fraction fell down because after COVID, he had LV dysfunction. So I had to upgrade to at least a VDD pacemaker with a GDMT. So this works, and in lifetime you may need 3 or 4 micra, so up to 3 pacemaker can be accommodated in pig's heart. If you have a bovine heart, then perhaps 4 micra pacemaker has been demonstrated to work. But human being, since the micra pacemaker is not there for a long time, so this is one of the first patient who had infected pacemaker. So the same day you take out the laser. Smith is sitting here. He's the master of having laser. He's the first man to do laser angioplasty, Dr. Smith from PGI, and I'm glad to see him here. So he uses the same laser technology, same machine for the laser extraction. Our UICon on next week, I'll be showing some laser technique for the removal of the pacemaker from UK. So he had extraction, of the lead by laser. Then he just entered there, sheath, these dilatations. The single dilatation can take your micra up to the, previously used to dilate the femoral vein with gradual increase in dilator size, but nowadays the micra dilator is the best dilator, and you must use or keep this dilator for ECMO. So in our hospital during COVID time, we had the problem of entering into the femoral vein at the bedside. A lot of dilators are used. You just take out the microdilator, dilate this thing, the veins with the larger size sheath, Edwards sheath, you can introduce this. So there is always a value for reusable material in our country, whether it's Inouye balloon by Dr. Jadhav or a micro sheath by me, or only the stent doesn't have a reuse value, or a balloon. So you go there, inject, and now the mechanism is so strong, I never ever seen any micra embolized. So sometimes you can use this MP catheter if you have a difficulty. If you face any resistance, just lift your hand from the micra, and the micra will be in neutral position. So step back and go in a different directions. So you make this swan necking. If you may make this swan necking, you know that micra has gone inside the trabeculae in the RV apex, and you just release the micra, and micra will stay there. In 95% you get the threshold of 0.3 or less than 0.3. Most of the time it is 0.3. So if you do not get a proper threshold, you can always recapture. So what you have to do, you have to pull the necklace again, you reload the micra, and the pendant will be in a different place. You see in 2 different directions, like in LO, it will be perpendicular to the septum, and if it is perpendicular to the septum, the chance of perforation, as I said, is smaller, chance of death is smaller. You can take this, and now knowing the septum, for the beginners is very important nowadays. When you do certain procedures, like if you start doing LBB pacing, so you know the septum. In the septum, when you do LBB pacing, so in the LOA view, LBB pacing usually at 3 o'clock. Micra is 3 o'clock. LA closer from 2 o'clock to 2.5 o'clock. That's it. Not at 12 o'clock, not at 3 o'clock. So knowing this clock position is very important, where to go. Pulmonary vein almost always at 2 o'clock. So enter in the pulmonary vein at 2 o'clock and goes beyond the heart. So this clock position, if you have this wire, and you can remove, and this is the future of pacing. So ladies and gentlemen, I stop here. There are many other newer things. There are much more important things to do here than my micro talk. Thank you very much for your kind attention.
Now new micra is coming, which will be, I think, that will work for 15 years. That is called micra VR2, and micra AV, which is 110 bits is the sensing power for 1:1 conduction, 1:1 sensing, which they have increased to micra AV 2, that have increased the sensing power up to 135 bits per minute. So you can, the tracking rate is much better. So yes. This time I went to FHRS and saw the newer devices. So these 2 in the micra is coming. Another one is from Evir VR from the St. Jude, Abbott, and that is also doing very well. And that is a screwing lead. The pacemaker is this leadless pacemaker is having a screw, and there is a sensing tip there, and both device is very good. Same implantation technique, everything same. Somewhat there it is more knob is there than this. This is much simpler. Micra is much simpler to implant than the IBHRE. IBHRE has many knob. You have to know all the knobs before putting that.
Yeah, that about, the beauty is like if you screw it and if you do not get the threshold, you can retrieve and go to the different position. Whereas in Micra, you do not know the threshold.
No, in Micra, sometimes when you put, your threshold will be higher, but wait for 3-4 minutes, then it comes down.
Dilip.
Thank you, sir. Thank you. I think it was a wonderful presentation as usual. And
Dr. Hajra, can I ask a question?
Swamikda, yes.
As of now, this therapy is a niche therapy. What do you think would be the drivers to make it a mainstream therapy? That is number one. Secondly, this age of conduction system pacing, how do you see this device evolving to
Okay, so there are two questions. Is it ready for prime time? Micra is not yet ready for prime time because of cost and a large board device, and that longevity has improved. So I will not take that as against any considerations of having Micra in human beings. And some people are thinking that the QRS duration by Micra is much wider than the QRS duration you achieve by septal pacing or conventional pacing. QRS duration is little higher because of the large this polarity head. So I don't think it is still ready for prime time. But those people who do not want a conventional pacemaker, like elderly people on oral anticoagulant, dialysis patients, they have like children, those who do not want to have a epicardial pacemaker or having like infected pacemaker in children, it can be done from the jugular. And what else? Sixth sinus syndrome. Very bad skin, those who have psoriasis or an eczema on the skin. So these are so many issues. The female patients, they are very, concerned about the aesthetics and the looks of the skin, because if you form a keloid for female, that can be a social issue. Now, I'll tell you one story of, if you give me 2 minutes. The first lady who had about, this wireless pacemaker, this lady had, I was just talking with Soumitra Rai. At 8 years, she had first transplant because of congenital cardiomyopathy. That lady had rejections at the age of 15, so she had another heart transplant at the age of 19. At the age of 19, she had a third transplant, and after 5 years, she had rejection and she had 10-second pause. So the Micra people, the Abbott people was looking for a volunteer in whom they can try this pacemaker first time in US. So she volunteered herself, and she was giving the interview, and the beautiful story you can find in YouTube. So it is not meant for everybody. And conduction system pacing, Dilip is one of the pioneer in eastern part. I have almost converted every pacing into LBV pacing to a very honest. 99% is LBV pacing. And I have done more than 350 LBV pacings, all complete heart block, all sixth sinus syndrome. It's a class 2A, but it is going to change very soon. So it is still not ready for the prime time because a different technique. You have to know the QRS. Sometimes you need the help of the EP machines, but I do without machine. He has the luxury to do without ECG machine. So how do you do LBV pacing? You have now Medtronic, you have Biotronic, you have a Senjut. So you take these positions, you do the RV angio. I do RV angio initially, never used to do. We know where to go. So once you enter in the RV, then you position your sheath, then you fix your lead, either Medtronic or Abbott or your or Biotronic or Boston has come to Calcutta. Then you check the QRS on 12 lead ECG. That's it. 12 lead ECG, continuously take the print, not on the screen. You take the print and because that is the proof of the pudding. If you do not have QRS widening, then you have to change the position. So still not yet ready for the prime time, but future will tell us that perhaps that is the way to go.
Sir, can I have a question?
Yeah.
This is just if you have complete heart block.
Yes.
You want a pacemaker.
Yes.
Which pacemaker you will like?
LVV pacing.
Left bundle pacing.
Left bundle
Means
pacing.
Not Micra.
Not Micra.
Recent
Not
HRS,
Micra.
recent HRS has given the guideline.
Yeah, class 2A
Class 2
indication
indication now, yeah, for CSP. Thank you, sir. Thank you. And we are moving towards last sessions. And may I invite Dr. Somik Basu, Kajal Ganguly, sir, Dr. Rishi Sethi to take seat on dais. We are going to discuss Know My Valve. After that, Know My Valve. Dr. Anant Raman will show us how the My Valve works, and he will also give us an idea. Dinner symposium will happen after that. So, a brief kind of summary on pros and cons of other valves as well. He will give us an idea, and what are the factors he feels that which should be considered in choosing a valve.
No, I think you had the presentation. No, you just opened. You opened, no? Go to session 12. Merrill, the last one, yeah. And then, yes, just open that, yeah. Good evening, I won't take long, just take you through quickly on this My Valve. After that, I will probably comment on the other valves for 4-5 minutes because we are all hungry and it's time for dinner. Just show the slides, please. Now we have to be very proud about this particular valve because it is indigenous and it has made a huge difference for transcatheter valve therapy in India. I think now the majority of the usage is the Merrill My Valve in India. More than 65% of the market is covered by them. This shows that if you are able to produce a device that is Indian made and affordable price, it will work and people will have confidence. So before I talk about this newer version of this My Valve octa-core, I'll show you the older version so that you will appreciate what the difference is. So this is the previous generation or which is still available, which we quite widely use. This is the My Valve, it's a balloon expandable valve. So the difference is, as you can see, the cells shapes, notice that, and then when I show you the octa-core, you will notice the cell shape that is different. There are 1, 2, 3 rows of cells. The bottom 2 is covered, the top one is not covered. So when you crimp it, this is how it looks, dark band, light band, dark band, light band. Now we go with the second dense band for implantation. When you implant this, so that is the iotogram, and that's where we want. First dense band, second dense band, a pigtail, that's about. Because when it sort of implanted fully, it foreshortens from LV towards aorta. So in one of the cases we were discussing, that was one of the issues, that foreshortening, because that was already high. Foreshortening means it went to 0%. So we have to be aware of this and about second dense band. If you don't see that second dense band, use this dense marker which is available and keep it around that pigtail. So that will work. So this is this My Valve, the previous generation, and which is still we use quite a lot for the aortic position as well as for the mitral positions for valve in valves. The commonest views is the coplanar view. That means you have the NCC, RCC, LCC, all three in one plane. That is the commonest view for the balloon expandable valve. For the self-expandable we use the cusp overlap. That means we are overlapping the right and left cusp and isolating the non-coronary cusp. So that is the dense band where I was mentioning. You can see the pigtail. Rapid pacing is essential. You pace, you bring the blood pressure down to around 50-60, and that's the kind of very slow inflation you have to do, looking at the calcium movement, and then the final one. And you see the foreshortening from LV towards aorta. Then you get a perfect sealing and a good coronary flow because it's low frame height and a fantastic sort of no gradients things. So that depth gives you less than 3 millimeters depth, so no conduction abnormalities. The other advantage of our sort of indigenous made valve is intermediate sizes. Comparable sort of other valve, balloon expandable valve in the market, there is no intermediate sizes. This intermediate sizes means that you can size according to that, within that 5 to 10% oversize. You don't need to go too much or put this 2 ml extra, 2 ml less. You really don't know what this 2 ml extra and 2 ml less does. So that is the older version. I'll just skip that for the purpose of time. You also have a larger valve, balloon expandable. The only company that makes in the whole world the 32, and then they're coming up with the 34.5 as well, is this Merrill, because the Edwards is only up to 29. So this is the only sort of larger valve sizes you can put it in a sort of balloon expandable. It's also useful in the pulmonary position. When you have a native RVOT and you want to put a transcatheter pulmonary valve implantation, probably the larger ones that's currently available is the MyValve 32, and 34.5 is on the way. So this is the older navigator system, balloon. I'll just skip through because I want to show the newer version because that has more advantage and the octacore design. So this is a change in the design from there to there. There's only 2 rows of cells and it's become an octagon with interlaced. Inside is a rhomboid. What it meant is the lower cells, both the inner skirt, outer skirt, that is covered. This is the large open sort of upper cell. Now this gives a fantastic radial strength, at the same time a good sealing, and this helps in terms of coronary access, all different things. And foreshortening is literally 0. This one, the foreshortens by 30%, literally there is no foreshortening. So where you place is where the valve will be deployed. Also there are additional markers that is put in, I will show in the next few slides, in terms of depth marker, in terms of commissural alignment marker, and in terms of commissural alignment, the sheath itself. So that is the Medtronic Evolute self-expanding valve. That's how the shape looks. And that's the Pro, Evolute Pro. That's the currently available one. Again, the sealing is there. About 70% I use that. About 30% I use the balloon expandable. And in terms of the current availability, apart from these two, there are other valves, the Accurate Neo, as well as Portico is available. The only place I use the Accurate Neo is large open cells, low coronaries, narrow small sinuses. It gives you access. And moderate or less than moderate calcium. If you have more than moderate calcium, the radial strength is not enough for Accurate or Portico. So these are the way I select the valves. So coming back to the octacore, the design is very peculiar. So they have applied for patents for that. So as I said, it is interlaced. So the octagon cells and becomes a rhombus body. And that gives you the strength you need, at the same time a good open cell upper cells. There is the anti-calcium treatment for the bovine pericardium, so we are expecting that to last much longer. And as I already mentioned, obviously the foreshortening is much less. It covers all the sizes you need. And the 32, we are going to have a 34.5 as well, so it will cover even the larger ones. At the moment, it's CCDS approved, CE approved, and majority of Europe and Africa and South America are also using it. So uniqueness, there is a marker, depth marker, which was there previous generation, the second dense band. Now you have a depth marker. So you can just keep the depth marker and implant it. You don't need to worry about too much movement this way or that way. The depth marker helps you where you want to keep it. So the other aspects, the sort of beautiful dark and dense bands, and more than that, the new catheter has the aligner. I will show you in the next picture. There is a 4 sort of bands of aligners, which gives you, when you keep it at 12 o'clock and take it in, that is used for the commissural alignment and the commissural tab. Obviously, it's a peculiar kind of commissural alignment you'll be having with that. So you have a landing zone marker, the V-shaped hinges with interlocked octagonal fold that generates the dense bands, and the rhombus zone in between that gives you the 2nd up to 4th rows. So we are aiming for around depth of this. So very less chance of any needment of pacemaker, because most of the times you will get that less than 3 millimeters depth. And this is one I was mentioning. There is this marker for landing zone. There is the distal edge aligner, which continues in the catheter. There are 4 of them there. So you keep it around 12 o'clock position, and that gives you the commissural alignment. And the commissural alignment based on is your CT scan. You identify your right coronary cusp, and you just create a perpendicular and a horizontal line, and then you identify your coronary, identify the angle, and from that you can create the clock angle. I'll show you in the case presentation how the clock angle is created. So this is how the intermediate size helps. This particular case, obviously severe aortic stenosis, and that's the 433. So balloon expandable, we do it with the area, self-expandable with the perimetry. So 433. So in this particular case, the valve sizing, you want it between 5 to 10% in a balloon expandable, you have a 24.5. Otherwise, if you use a 26, it's 22% oversize. If you use a 23, it's minus 4.2. You can add 2 ml with that well or reduce 2 ml with this well, but you really do know what you are doing with that. Here you are exact, 24.5 will fit in perfectly, and that's where this intermediate sizes helps. The angle is good, all the other features are fine. And the femorals, it's pretty good, more than 6. Now this is what I was mentioning about. So in this particular case, RCC, the middle of the RCC through that, when you draw a line, you're getting a sort of a 305 or a 3.8. But if you look at the coronary ostium, this is the right coronary ostium, that's 3. So we call it a 3.01 or 3.02. So 3 just away from that, 3.02. Basically what you mean is around that, you want to keep one of the commissures and crimp it, and you will get 80% of the time commissural alignment. So this is the case, femoral access, iotogram is done, and you have the depth marker there. Depth marker is there. And when you implant it with that depth marker, you see there is no foreshortening and a perfect deployment. Depth-wise, there is only about 2 millimeters depth, coronary is flowing, a perfect result with no paravalvular leak. And that is a pre and post gradients. Mean gradient is 7. And that is a post CT, gives a perfect sort of commissural alignment within 15 degrees. So both coronaries are looking pretty good. So you can get a good commissural alignment in a balloon expandable valve with this newer technology with the Octaline. So I'll stop with that in terms of the sort of this newer valve and how you do commissural alignment, other things. So currently you are going to have at least 10 different valves, if not more, next year in India. You will have the Medtronic, you will have the Edwards, you will have the MyValve, you will have the Accurate Neo from Boston, and the Portico from Abbott. And then a couple of others are coming. As I mentioned, the IBHRE will be released in the NIC, which is the only dry tissue valve, and the Translumina is occurring one valve. And there's going to be one more indigenous valve produced in Visakhapatnam. So about 10 different valves available. The important thing for you to do in a center is get used to one particular valve. If you're using a self-expanding, in 70 to 80% of the cases, you can get away just using that. Familiarize yourself and have access to a second valve, because balloon expandable you will need in some cases, sort of a valve-in-valve cases as well as other workout cases. The third valve is only for specific situations, very low coronaries or very narrow sinuses. If you use too many valves, your team will not get used to that, you will not get used to that, and you will run into a lot of issues. So whatever your workhorse valve is, have one workhorse valve, one self-expanding, one balloon expanding option, and one for obviously special indications. Now the differences between these valves have become less and less in terms of the access size, in terms of the pacemaker rates, in terms of the overall complications. It will get much less and less because Edwards is bringing it S4. S4 will look more like the Octacar in sort of, there will be a depth marker, there will be a commissural alignment marker which is available in S4. And the Evolute is coming up with the Evolute FX. That is a much flexible system. So all the parameters which are adverse, like the horizontal iota, all the other things will be taken away by the FX. The commercial alignment will be there for both the balloon expandable valves. So in terms of the differences between these valves, it's becoming less and less. So it's more of a patient-centric approach. So you put the CT, you decide the calcium amount, you decide the radial strength you want from that, you decide on the coronary risk and all the other risks, then you decide on the valve selection rather than deciding on the cost. And that should be the sort of valve selection for TAVR, maybe in 24, 25. Thank you. Sorry, sir? At the moment, no, Resilia is Edwards' property. Even this Octacore, they will be applying for FDA approval because this is completely, Foldex is non-biological material. Foldex is coming up in the TAVR valve. Foldex is already there in the surgical valve. And I think one of our colleagues in Mumbai is the primary investigator. And it's also coming up in the TAVI as well. Foldex means it's a non-biological. You can get away with anticoagulation. The durability is almost many, many years. But at the moment, the longest durable biological tissue is Resilia. Resilia is shown already in the surgical. Now they are putting it in the transcatheters as well. But it will not be available for the other companies, no.
Thank you.
Thank you, sir.
Thank you. We got such a wide overview of the valves and how to choose. Kajal Ganguly sir, you have any comment?
This is a very good valve to use in our country. Price is reasonable, so we can afford it. Our patients can afford it, and it is mainly a balloon expandable, na?
Yes, my valve is balloon expandable.
Balloon expandable, yes.
Thank you. Thank you, sir. So we move on to the last dinner symposium, and I request Ravi to give us an idea about how Relisys is, coming up with so, fancy and good, useful devices for all of us. Ravi, for you. Yeah.
Dr. Dilip Kumar, esteemed gathering, respected doctors and my industry colleagues, good evening to each one of you. I am Ravi Patnaik and I take this opportunity of presenting as to what my company Relisys Medical Devices does. And with the consent of Dr. Dilip Kumar, I'll be talking a little bit on the trick valve and then the aortic valve that which we would be launching in the days to come. Good evening to one and all, and Relisys Medical Devices Limited was the company which has introduced the first drug-eluting coronary stent system in the country. So this was initially known as Kalam Raju stent, and since then we have been manufacturing stents for the country as well as for most of the countries outside India. In addition to drug-eluting stents, we manufacture balloons, guiding catheters, guide extension catheters, diagnostic catheters, peripheral vascular products, and percutaneous valves. The company was incorporated in the year 2003, and this was basically a project that was mentored by His Excellency Dr. APJ Abdul Kalam. So we are an integrated facility. Very few facilities in this country or anywhere outside the country have got both backward and forward integrating capabilities. So we take pride in saying that we are a fully integrated facility. We are ISO 13485 certified. We have got various technology platforms, especially the metallurgy and polymer chemistry. These two are our specializations. We have got enough capability to meet the requirement of the domestic as well as the international markets. And we are the largest stent manufacturing company. We proudly place it on record. We cut about 1 lakh stents every month. So these stents are being sent to various companies and various countries which are being used across the globe. And in the year 2018, Relisys has acquired Multimedics, which is a CE-based, CE-certified company with CE-certified products. With it, we have a host of CE-certified products with us. So the major product portfolio is stents, PTCA balloon catheters, and catheters. Within stents, we have got the everolimus, sirolimus drug platform stents, and then the PTCA balloons. And within catheters, we have got the diagnostic, the guide extension catheters. And our other products are coronary accessories. We have got the wedge pressure catheter, central venous catheter, hemodialysis catheters, peripheral stents, strap liner, and expandable sheath. All these products are currently available in the market. And the products in the pipeline are microcatheter, steerable microcatheter, and covered stents. In addition to this, we are working on our transcatheter pulmonary valve, transcatheter mitral valve. Transcatheter aortic valve would be launched in about a month's time, and then the endobentile device. So this is our geographic presence. We are present pan-India and in most parts of Europe and Latin America. And within minimally invasive heart valves, currently trick valve is available, which is transcatheter bicaval valve system. And then Vienna aortic self-expandable transcatheter aortic valve is round the corner. And then we have our mitral as well as pulmonary. So I would like to take another 5 to 10 minutes in talking about the role of CAVI in treatment of tricuspid regurgitation. Tricuspid, there has been enough discussion today. Thanks to Dr. Dilip Kumar, he has planned the agenda so well that, this neglected valve has started gaining so much attention. And sir, I think today there has been so much of discussion around this valve. I think, in fact, since beginning this valve has always been left out when Nina Braunwald has suggested a conservative approach for the treatment of this particular valvular lesions. Principally, we understand that its anatomy, its location also has contributed to the negligence of this valve. Surgeons would not intervene as of now. So now again it has come back to the cardiology, and cardiologists are endowed with the primary responsibility of treating the valvular lesion, this particular valvular lesion. So when the patients present to you, they present to you in these three forms. Either they come with pure or dominant tricuspid stenosis, tricuspid regurgitation, or of mixed etiology. And when we look at the incidence, about 1.6 million people have been affected with tricuspid regurgitation in USA alone. The surgical mortality is quite high. About 9% of these patients undergoing surgery would not show up again. There have been multiple transcatheter devices that have been developed for the treatment of TR in high-risk patients, but none of them have demonstrated any superiority so far. So as of now, our understanding is when tricuspid annulus is severely dilated or prior pacemaker leads contribute to tricuspid regurgitation, caval valve implantation might be the preferred option. And when we look at the prognosis of tricuspid regurgitation, the patients along with tricuspid regurgitation and other comorbid conditions have a declining survival in the days to come, especially in patients with chronic heart failure and LV dysfunction. Therefore, severe TR has a significant impact on survival and it needs treatment. This particular slide becomes all the more important in trying to understand the risk stratification and the heart team decision making. Before the patient attains the point of no return, the patient should be treated. Therefore, these patients generally when they present, I think the treatment should be offered to them. Various treatment options. We have got various devices which address the tricuspid regurgitation at various levels. We have got devices which address at the annulus level, which address at the ring, which address at the level of coaptation, the leaflet coaptation, and the valve to be replaced. Currently, the valve replacement has not been so successful considering the hugely dilated annulus that the patient presents with. So, when it comes to, out of all the choices that are currently available, trick valve seems to be a very feasible option because we don't touch the orthotopic valve. This is a heterotopic implant. So trick valve is a transcatheter bicaval valve system which contains two self-expanding biological valves, and these are designed for the treatment of patients with hemodynamically relevant tricuspid insufficiency and those who have marked caval reflux. And this is especially intended for patients who are at extremely risk and are not considered suitable for open surgical intervention. These prostheses are implanted percutaneously into the inferior and superior vena cava without disturbing the native tricuspid valve. This is how these two valves look like. The first valve is the superior vena cava valve. The top portion of the valve is known as the crown, and then the middle one is the belly of the SVC valve. The actual valve sits in the bottom. This is the one where it sits, and it's made of nitinol. And there is a long skirt which ensures there is no paravalvular leak. And the one on the right is the IVC valve. This is basically, this sits at the IVC level. The valve is on the top and the radial force is stronger as it goes down. We have incorporated dry tissue technology into these valves, which means we again take the pride in saying that these are truly fourth generation valves. All of us understand the first generation biological valves have undergone mechanical treatment, the second generation have gone mechanical as well as chemical, and the third generation have undergone mechanical, chemical and anti-calcification treatment. Now the fourth generation is we have gone one step ahead in dehydrating the tissue. This has given at least 2-3 benefits. The biggest benefit has been we are able to pre-crimp this valve onto the delivery system, as a result of which these comes preloaded into the laboratory. So the time that we invest in loading the valve within the laboratory is minimized. It reduces contamination. It also reduces, the team size. Number 3, it reduces the time. And second most important thing is, within the laboratory setting, we could find that because of dehydration, the collagen integrity has improved within the tissue, as a result of which this valve doesn't suffer structural valve degeneration much faster like any other valve that is preserved within glutaraldehyde undergoes. So this is the concept of the trick valve system. Basically, trick valve prevents backflow. It reduces congestion, as a result of which there is an RV remodeling which happens. Because of all these, there is a reduction in symptom and then there is a reduced mortality. Like any transcatheter transfemoral procedure, trick valve also has got a CT angiogram protocol. A three-dimensional multiplanar reconstruction is being used to transfer the images and to arrive at the sizing. As on date, we have got about 3 sizes within SVC valve and 4 sizes within IVC valve. Depending upon the patient anatomy and the CT MPR planning, we appropriate the size of the valve to the anatomy. So at the level of SVC, there are about 7 measurements that are being taken. So these elaborate measurements are taken to just ensure 2-3 things. One is no PVL, because right valve is important to ensure that there is no PVL. Second thing is this valve should not be embolized. That's the most important part. Therefore, measurement is taken at the various levels. The primary location is the confluence. From there we start deploying the valve. Therefore, we measure that, and we also measure the length of the SVC from the confluence to the SVC RA junction. So these two becomes very, very critical in addition to other 5 parameters. And choosing the SVC valve, these are the various measurements, and we have got cutoff ranges. If any anatomy falls within this cutoff range, we screen them off. And as Dr. Anantharaman was speaking today during one of his lectures, 30% of the patients really do not make for the implant just because of anatomical mismatch, or they get screened out of because of anatomy not fitting in. So this is again a design, dedicated valve design. The crown anchors at the level of the brachiocephalic confluence. The belly provides proper anchorage within the SVC. And there is a high skirt which ensures there is no PVL. And for the IVC valve, we take measurements at 5 different locations. Again, within this particular valve, the most important parameter that we measure is the distance between the suprahepatic vein to the IVC RA junction. We expect the distance to be at least 1 centimeter. Usually in Indian anatomies, we don't get to see 1 mm. Sometimes we manage with 6 or 7 mm also, just because these patients have got grossly dilated hepatic veins, and we take the comfort of occluding a certain percentage of the hepatic vein. So again, within this, there are certain measurements. If the patient doesn't fall into this criteria, we screen them off. These are the screening criteria which become very, very important to screen a patient pre-procedurally. Echo and right heart cath report, these two become very important for us to assess the patient's suitability. Most importantly, the patient should be in NIHA class 3 or above. Ejection fraction should be greater than 40%, and the patient should have been able to walk 60 meters under 6-minute walk test. And the life expectancy of the patient is expected to be greater than 12 months. And these patients should not have any left-sided valvular lesion, should not be in severe renal failure, and there shouldn't be child C liver cirrhosis. Anatomically, I spoke just a while ago, and within hemodynamic parameters which are measured through RHC, the V wave in IVC and SVC should be greater than 15 millimeters. The TAPC, which is an indicator of right ventricular function, should be greater than 12 mm, and the patients with SPAP less than 65 millimeters mercury would be considered. Any patient with severe pulmonary hypertension would be deemed unfit for this procedure, because we haven't seen better results for these patients when we have given trick valve. This is quite an easy procedure. Most of the alternative treatment methods have been performed using annuloplasty rings and surgical repairs. Is bicaval trick valve implantation the solution on the horizon for severe tricuspid disease? This is a question which we will have to still answer. As on date, we have done about 60 implants across the country. Within Europe and other parts, we could do close to 500 implants. So this is our current experience with trick valve in the country and outside the country. Maybe with more experience that we gain, we'll be able to answer these questions. Various devices have been used for the treatment of tricuspid regurgitation, but did not meet with proper success. And then within the clinical evaluation program of trick valve, the compassionate program, Tricus single center study and Tricus Euro study have been studied, and we are up with the results. critical patients have been taken into the study, poor GFR and patients who have undergone prior valve surgery and then poor Euroscore have been considered, and the in-hospital mortality has been 0. The technical success, this was the initial days results when the valve was getting crimped within the laboratory. Therefore, there were few instances of valves getting embolized. But now, thanks to dry tissue technology, we are able to crimp it within the factory, preload it within the factory. Therefore, the procedural success is as high as 100%. And the functional outcomes, all the patients have shown tremendous improvement in their functional results. No one within NIHA 4 has remained in NIHA 4. They have come down to NIHA 3, 2 and 1. And so is true on their 6-minute walkability, and the overall quality of life as measured by Kansas cardiomyopathy questionnaire was also improved. And the weight of the patient has come down. There has been improvement in the RVD basal and mid-ventricular volumes. And this is the one which Dr. Anantharaman was talking today in one of his presentation. The reduction in the chamber volume, the regression of the chamber volumes, which we could measure 8 months post-implant in few patients. So now what we do is we also take a basal MRI and post-procedural MRI after 6 to 8 months to assess the change in the dimensions of the chambers. There has been reduction in the hepatic backflow. IVC V wave has come down. There has been an improvement in the liver enzymes, and this is the overall result of the TRICAS study. There has been no device-related mortality. There was a single hematoma at the access site, and one was converted to surgery. So the TRICAS Euro study results have been published now, and these are again the baseline characteristics. Patients with pacemaker, patients with AF, patients with poor GFR have been considered. Most of these patients have had prior valve surgery, and these patients, these are the results. Improvement in quality of life, improvement in NIHA class, improvement in 6-minute walk test.
One more small presentation left, so if you can do it little quickly.
I will do it. I'll complete, sir. And this is what this particular study says. The reduction in caval regurgitant volume may increase RV stroke volume to the pulmonary circulation, thus potentially increasing cardiac output. This is the explanation given as to how there has been an improvement in the hemodynamics. So this is a table which talks of pre-CAVI implant parameters versus at the end of 3 months. There has been a tremendous improvement in various parameters, and this we have spoken. I'll just run a very short video which shows the procedure. TrickValve has been deployed in most of the centers across India, thanks to all the doctors who have shown confidence in these device. This is just a short animation which shows of the deployment of the valve. This is quite a simple procedure, as simple as an IVC filter is being deployed. We use normally a super stiff amplaz wire. First the SVC valve is being deployed. Brachiocephalic junction becomes very important landmark, and from there the valve gets deployed. Once this valve has been deployed, the delivery system is pulled out, and over the same wire another delivery system with IVC valve is being deployed. So this is the IVC valve. So now we have two competent valves sitting within SVC and IVC, and this takes care of the backflow, and then the JVP, the edema, distension, ascites, everything is taken care. So TrickValve is a new, promising and less invasive concept for the treatment of TR, and successful and uneventful initial experience showed feasibility of applying this new therapy in patients with severe TR, and there has been tremendous improvement in the patients after 6 months, and the confirmation of these results in large cohort will definitely prove this to be a new avenue for the treatment of TR. Thank you so much. Thank you.
Thank you, Ravi, for
thank you, sir,
taking us through your products. And TrickValve has really, a bright future. What we see, it's the only available solution for tricuspid valve pathology as of now. So we, I think from Abbott, Saurabh will briefly discuss. 5 minutes to you, Saurabh, to just tell us about positive points of our valve.
Thank you, sir, for this opportunity. So we have got the latest generation TAVI system from Abbott. Just wanted to, can you just display the slides? Yeah, so I would just come to the very unique feature. So first you see that this is a self-expanding system, but the most unique feature is, unlike other self-expanding systems, the placement of the leaflets is intraannular rather than supraannular. And as we have seen that because of supraannular leaflets, we get very good hemodynamics. So the same hemodynamics are maintained, but then the reason why the leaflets are placed at an intraannular level so that you can have easy coronary access. Plus also see it has a large cell design, so you can always have easy coronary access going ahead. Then you also look forward to, very good PVL mitigation. So what we have done is that we have got a NaviSeal cuff, which is a dynamic cuff which actively synchronizes with the cardiac cycle. So here you see you have got a huge calcium at the annulus, maybe going into the LVOT. But then the way NaviSeal cuff works is that it actively synchronizes during the cardiac cycle, so the cuff opens during ventricular diastole, because of which it stops the blood from going into these channels. And this is also visible in the PVL data, where 80% of the patients had none or trace PVL. And then usually endothelialization takes place and the channels are plugged. So this is the most unique feature of Navitor. Plus, this valve is very conformable. We all know that, the annulus is not exactly circular. So this valve conforms in the elliptical manner to make sure that there is reduced PVL. You can see the radial strength across all sizes of Navitor is optimal, so that, there is good sealing, and again, helps in reduction of paravalvular leak. As I was mentioning, although this is an intraannular valve, but you can see, there are single-digit gradients. So you get good gradients without compromising on your coronary access. So this is just a comparative data of Navitor with other technologies, self-expanding and balloon expandable. The gradients are maintained over a period of 1 year. And because of this, Navitor helps exhibit the lowest prosthesis patient mismatch. Again, due to the intraannular placement of the leaflets, when you are unsheathing the valve, what happens is that there is an early leaflet function. So because of which, if you do not want to do any rapid pacing, you can do away without any rapid pacing. So this is basically designed for immediate functionality and durability, and this also sort of gives you a peace of mind when you are unsheathing the valve. Again, uncompromised coronary access because of intraannular placement and large cell geometry. Coming to the FlexNav delivery system, so it is a 14 French delivery system with 5 mm minimum vessel diameter. And as you can see is that for 23 and 25, the minimum vessel diameter is 5, and for 27 and 29, the minimum vessel diameter is 5.5. However, we have done cases with femorals as low as 4.2. Another benefit of having an optimal radial strength is that when you're unsheathing the valve, the opening force is very controlled. So where you have taken the position, the valve will exactly open there rather than diving into the LVOT and again, milking or adjusting your catheter. So this has a very stable deployment. So there's always a peace of mind that if you have taken a position of 3 mm infraannular, so it will deploy at that particular level. Again, so we have this capsule under which the valve is crimped, and this capsule does not have any braiding. So when you're taking it over the arc of aorta, it has excellent deliverability over the arc of aorta into the aortic valve. This valve is recapturable and repositionable even up to 90% of deployment. And as you can see is that because of this low profile of the device, the major vascular complications are 0.8%, which is one of the lowest in the class. So you can see the major vascular complications. Thank you.
So thank you so much, Team Abbott, and Now it's time to thank everyone. Thanks to all the faculty coming from different parts. Thanks to all the delegates. Thanks to all the industry friends who made it possible. And we have never, compromised on anything. Everyone asked, anyone asked something that we need to do this thing for betterment of the program. We did that. And I hope it has created an impact on our Eastern, India interventional cardiologist and structural heart interventionist population, and they will take up this kind of tower, left appendage occlusive devices, tricuspid valve interventions more strongly, and hopefully we'll do next year in a bigger fashion. And thanks again to everyone, and we can have some feedbacks if anyone has, how we can go ahead, any scope of improvement, any of, if they have felt something which could have improved. Thank you. Thanks again. Thanks.